A very good afternoon to everyone who's joined in today for the 10th International Joint Symposium in Diabetes being organized by CMRE, the Consortium for Medical Research and Education, along with AASD, the Arabic Association for Study of Diabetes in India, and DIPSI, the Diabetes in Pregnancy Study Group India. This is our 10th year, a decade of academics that we have been delivering, me and Dr. Rajiv Chawla, my co-director of CMRE. We conceived this baby about 10 years back and it's 10 years old today. And I'm sure the academics that we have delivered has been useful. AASD has been our partner for the last few years. We've had associations like the Cardiff University and DIPSI and even IDF Southeast Asia who partnered with us earlier. So this is just the 10th and the baby is still growing and very soon will be an adolescent and then an adult. So the academics continues and I'm sure the scientific content has been appreciated globally. The audience logged in today is not only from India, but the entire Southeast Asian territory and the Middle East, the Arabian countries, Egypt, Cairo, Gulf, Dubai, Emirates. So we have delegates logged in from all over. So I welcome all of you who have taken the effort to join us today in spite of the different time zones. And we promise you a great scientific feast with experts sharing their knowledge, their inputs with all of us on different topics pertaining to diabetes from worldwide. So without further delay, let's invoke Goddess Saraswati and start today's proceedings with a prayer to Goddess Saraswati to give us wisdom, to continue with the scientific pursuit and to be more knowledgeable, enrich ourselves and gain more wisdom, which can help our patients deliver the best diabetes care to everyone. Can we have the Saraswati Vandana, please? So after that invocation of Goddess Saraswati, let's kickstart the events today. Welcome Arvind Gupta sir, my co-chair for the first symposium. Can I have his CV slide, please? Can I have Dr. Arvind Gupta's introduction, please? Dr. Arvind Gupta, my co-chair for the first symposium, on clinical pearls in managing diabetes, is Senior Consultant Physician and Head Department of Diabetes, Obesity and Metabolic Disorders at Mahavir Jaipuria Rajasthan Hospital, Jaipur, an eminent academician with lots of awards and allocards to his credit. And he is somebody who's known for his academic pursuit in the entire diabetes fraternity in India and abroad. Welcome, sir.
Thank you, Shalini, for the kind introduction. Will you start just now? Because I think time is 2 o'clock.
No, sir, it's 1:45.
Okay.
Just a moment. Let me just cross-check, sir.
Yeah. I think I have been informed around 2 o'clock.
Oh, is that the reason? Okay. So I think Dr. Kovil is just joining. So yeah.
Yeah, so that's the reason. Actually, I was surprised. I was thinking that 15 minutes will be the buffer time for us.
Oh. I think there is some miscommunication then.
Yeah.
Okay. So we still have another. Okay. So what we can do is, now that Dr. Kovil has joined, maybe we can kickstart with his session and have some discussion with him.
Perfect. Rajiv, are you ready?
Perfect. Always ready.
Yeah, I think you are ever ready.
Ever ready.
Yeah.
So, sir, I'll request you to introduce Dr. Kovil.
Yeah. Good afternoon, everybody, and welcome to the beautiful conference of Cardiff Conference. I think this is one of the very important international conferences where we learned so much from the international and national speakers. And now we'll start with the very important session of diabetes and chronic kidney disease, which is also my favorite. But Rajiv will be speaking. He's a very eminent speaker, prolific orator, I can say, one of the best orators I can say in the country. He's a medical director and consultant diabetologist of Kovil's Diabetes Center. Abhi time hai. Let me introduce.
Okay.
Rajiv Kovil.
Rajiv, we have time, and the best part is we have a global audience.
Yeah.
So it's,
okay.
You know, we have people from the Middle East, from Egypt. So we have a lot of logins from the other places. ASD is partnering with us. So we have a lot of evidence from that side as well.
Yeah. So he's the founder, member, secretary of United Diabetes Forum. He's the vice president of Indian Podiatrists Association and principal investigators of various clinical trials. And you will be realized after hearing his deliberation on diabetes and chronic kidney disease, how prolific speaker he is. So Rajiv, stage is yours.
Thank you so much. Thank you so much, Shalini. Thank you, Dr. Rajiv Chawla. Thank you, Dr. Gupta. Again, it is also my favorite topic. And in the last 10 years, we have evolved from diabetologists to cardiologists to diabetonephrologists to technologists. So there's a lot of evolution in us, and probably all these evidences which has come in has helped us. CKD and type 2 diabetes is a vast topic, and I'll try to cover as much as I can. I will speak a little bit extra on finerenone because that's the new kid on the block for chronic kidney disease. Thank you, Shalini and Dr. Chawla, for giving me this topic as well. So this is my table of contents where we are going to look at the burden of CKD, especially in relation to India. How do we diagnose CKD, and how do we give importance to UACR? Because there's been a debate for last 20 years about UACR. What are the treatment paradigm, pathways of CKD, and something about finerenone as such. So let's look at Raj. He's not a pet name for myself. So we have almost not 80s, we have 100 million people with diabetes, 126 million with pre-diabetes, and estimated almost 35 million adults have CKD. And the prevalence in India is anywhere from 35 to 40% of our patients with type 2 diabetes have some form of chronic kidney disease. If you look at why do we need to treat chronic kidney disease, and this we had learned way back at the UKPDS also, because there was a sub-study which looked at progression of chronic kidney disease in the newly diagnosed diabetes in UKPDS, and it showed that at every stage of chronic kidney disease, the patients with chronic kidney disease had a higher risk to develop an adverse cardiovascular event rather than progress to the next stage of chronic kidney disease. And then there was this whole cry across the globe that whether chronic kidney disease should also be called as a CHD risk equivalent. And if you look at this data, the 10-year CV mortality for diabetes and kidney disease, when they come together, there's a lot of synergy. And it is not 1 + 1, 2, but it's almost much high into 6 times is what the chronicity of the complication comes in. So CKD, when do we start screening? We start screening type 1 diabetes yearly, starting 5 years after diagnosis. Type 2 diabetes almost starting at diagnosis, because almost 19% of people in the UKPDS had retinopathy. So microvascular complication could be there at diagnosis. What to do with a positive result? Again, evaluate possible temporary or spurious cases. Only persistent abnormalities should redefine CKD. Initiate evidence-based treatment. How do we screen? With a spot ACR and an EGFR. What is CKD, or when do we call a patient with having chronic kidney disease? Is that one, he has a persistent UACR at least twice more than 30, which according to guidelines is A2, and or persistent EGFR less than 60, so he is in G3 or stage 3 chronic kidney disease, or he has any other evidence of kidney damage. So A2 and G3 by itself, or G3 and or A2 can be defined as chronic kidney disease as such. So if you look at how do we assess chronic kidney disease and how do we stage chronic kidney disease, the presence of albuminuria we stages at A1, A2, and A3, where A3 is more than 300. And if you look, if you stage chronic kidney disease based on EGFR, you can see that it's G1, G2, G3A, G3B, G4, and G5. And majority of our patients in all chronic kidney outcome trials have been in the stage 3A or 3B chronic kidney disease, with DAPA CKD and the Fidelio having a mean EGFR of around 44, Credence around 48, EMPA kidney slightly higher, around 60. So we had patients who were majority in stage 3 chronic kidney disease, and albuminuria seems to be the driver for diabetic kidney disease in patients with type 2 diabetes as a whole. So this is in a whole the risk, the staging of CKD, and as you can see, as you go ahead, there's an increasing risk, and our whole focus would be kind of reducing the stage, or at least causing a 20 to 25% reduction in albuminuria, which is the driver for chronic kidney disease. Now, whatever be the kidney outcome or the cardiovascular outcome, you can see that albuminuria seems to be the driver for kidney outcomes and cardiovascular outcomes. So patients non-albuminic albuminuric CKD compared to albuminuric CKD are the ones who will progress, whether it's progress towards the kidney or progress towards heart failure or other cardiovascular events. Time will decide, but these are the patients who need to be screened much, much higher as compared to non-albuminuric CKD. And over the last 10 years, the prevalence of non-albuminuric CKD has also increased in people with type 2 diabetes as compared to people with type 1 diabetes. So in type 1 diabetes is very similar, where you have podocyte damage and you have leakage, and then you develop albuminuria and progress to diabetic kidney disease. Type 2 diabetes, you may have other non-diabetic related chronic kidney disease also. You may have chronic kidney disease related to diabetes and not having albuminuria. So there's a lot of heterogeneity in the last 1.5 decades about the etiology of chronic kidney disease in people with type 2 diabetes as such. Again, as you can see, cardiovascular events are very common and they exponentially rise within a few months of CKD diagnosis itself. So early, again, if you see that within 1 or 2 years of chronic kidney diagnosis, patients are at very high risk for cardiovascular events. So importantly, the guidelines recommend annual ACR, EGFR screening to actually stage chronic kidney disease and actually look at progression as well. The ADA, KDIGO, ESC, ESD guideline recommends screening for ACR and EGFR. Again, the frequency is at least once a year, sometimes if twice annually, if you have a stage 3A or 3B chronic kidney disease or an A2 or A3 on ACR. Urine albumin excretion varies over time. Again, abnormal results should be confirmed over at least 2 measurements because any kind of stressor, sepsis, infection, pregnancy can cause an increase in ACR as such. So in our typical patient who was Raj, his risk of CKD is underestimated when we look at EGFR alone. When we actually put his UACR also into consideration, you will see that he is G3A and A3, which is very high risk for progression towards chronic kidney outcomes as well as cardiovascular outcomes. And then he should be screened more often, at least twice annually, and looked at how we can reduce the driver for chronic kidney progression, which is albuminuria. So each 30% reduction in USR leads to kidney and cardiovascular benefit with the potential to reduce the risk of CKD progression and CV risk from severe to moderate. So what we should try to achieve if our UACR is done, at least a 30 to 40% reduction in his ACR, which can actually reduce the burden and the load on the kidney as such. Again, a lot of barriers are there to chronic kidney disease management, and we need to have a multidisciplinary staff with a self-management program for helping people with chronic kidney disease as such. What are the recommendations and what are the pillars of management which have been endorsed by the KDIGO, ADA, KDIGO, as well as recently by the European Society of Cardiology, which came up with guidelines on these 3 pillars just 2 weeks back, that there are now 3 distinctly different classes of drug which have a very strong level of evidence and which has been there over the last few years. RAS inhibitor, we know for the last 2.5 decades, trials like the IDNT and RENAL have proven to us that how they can prevent the progression of chronic kidney disease. SGLT2 studies right from CREDENCE to DAPA-CKD to EMPA-Kidney has shown us that how it can also prevent progression and also treat chronic kidney disease and also treat a usual comorbidity with chronic kidney disease, which is heart failure. And the new kid on the block is finerenone, which is a mineralocorticoid receptor antagonist, and it comes with a complete different pathophysiological defect, which was earlier not defined in people with chronic kidney disease. So this is the proposed pillar approach. As we have the 4 pillars for heart failure management, we have the 3 pillars for chronic kidney disease management as well. Not getting into details, we know that SGLT2, based on the robustness of evidence of these 3 chronic kidney outcome studies, have come up right up there in patients with albuminuria CKD and also with patients with non-diabetic chronic kidney disease and also with patients without diabetes with chronic kidney disease based on the DAPA-CKD and the EMPA-Kidney study. So you have a very large evidence for SGLT2 in chronic kidney disease prevention and management. GLP-1 again has got a good amount of data on chronic kidney disease management. Not getting into details of how ACE and ARB and the SGLT2s work. We are fairly convinced over the last 4 to 5 years that these are drugs of nephrology which have a hemodynamic effect, which have a diuretic effect, which have an effect on the tubular glomerular feedback and causing a reduction in the intraglomerular pressure, and that's why they help in reversibly reducing the EGFR and thus reducing the load on the intraglomeraulus and thus helping kidney. So they're basic drugs which work through the kidney, have emergent risk reduction in the heart, which is related to adverse cardiovascular outcome and heart failure. And they also reduce blood sugar. They are primarily not just anti-diabetic drugs as we earlier thought about. If you look at CKD and CVD progression in type 2 diabetes is usually driven by multiple factors where metabolic, hemodynamic, and today inflammatory and fibrotic pathways have also come in. We have been treating the hemodynamic and the metabolic pathway using RAS inhibition as well as SGLT2 inhibitors, which works both on the hemodynamic and metabolic pathway. A lot of evidence to show that mineralocorticoid receptor activation or the MR activation can cause a lot of damage, including mesangial expansion, glomerular sclerosis, glomerular hypertrophy, leading to both CKD as well as CVD progression. That's where the MR overactivation, which has been seen in people with type 2 diabetes and seems to be a defect in people with type 2 diabetes whose kidneys get damaged, may contribute to CKD progression and adverse cardiovascular outcomes. So that's where we need to come in. When we look at the residual risk, and this word has been there whenever we have used statin therapy and how there has been a residual risk, and there's been a debate over the last 3 to 4 decades whether the residual risk related to high triglyceride and low HDL needs to be treated either with a fibrate or with any other form of therapy. But today we know that there is a residual risk which occurs when we treat patients with an ARB or an SGLT2. And if you look at the primary outcome of renal as well as credence, they are very similar, which is looking at doubling of creatinine. DAPA looked at a 50% drop in CKD, 50% drop in EGFR. EMPA kidney looked at a 40% drop in EGFR, but the primary composite endpoint and the renal endpoints continue to be very, very similar. But you see that there is a persistent risk even when we have treated patients with an ARB plus an SGLT2 inhibitors. So let's get back to a patient, Raj, who's elderly, 63, diabetic, HbA1c not well controlled, on an ARB plus a diuretic, EGFR as stage 3A, and with an A2, A3 albuminuria. There is, apart from an SGLT2 and an ARB, which is helping him hemodynamically and metabolically, can we add something which can help in reduction of progression of chronic kidney disease and cardiovascular outcome in this patient, which is albuminuria? And that is where drugs like selective MRAs like finerenone come in, where there is in type 2 diabetes, MR activation may contribute to CKD and adverse outcome. And that's why inflammation, fibrosis can be one of the pathophysiological defects, which if left untreated can make people progress towards end-stage kidney disease or heart failure or other sequelae of cardiometabolic syndrome as such. Now, finerenone, just getting into a little detail because this is a little newer drug as compared to an SGLT2 inhibitor. Finerenone and steroidal MRAs have distinct chemical structures. We both know that the MRs are activated by cortisol and aldosterone. Aldosterone antagonists, we know spironolactone and eplerenone. Spironolactone is eplerenone is more specific as compared to spironolactone. Finerenone is a non-steroidal, highly selective MR antagonist as compared to spironolactone and eplerenone. In all these studies of finerenone, HFrEF or heart failure with reduced ejection fraction has been excluded because there's overwhelming data on spironolactone and eplerenone with the eplerenone data on heart failure with reduced ejection fraction. So if you look at the whole chronic kidney disease landscape, and if you look at renal and IDNT, they were much smaller studies as compared to the SGLT2. But if you look at Fidelio, which looked at chronic kidney disease as the primary outcome, that is a 40% reduction in eGFR, renal death, or progression to end-stage renal disease or cardiovascular death. Or Figaro, which looked at cardiovascular outcome as its primary outcome. We are looking at 13,000 patients with chronic kidney disease who have been followed up for 2.5 years, 2.6 years in Fidelio, and 3.4 years in Figaro. So we are looking at a large group of patients with chronic kidney disease and looking at outcomes. If you look at Fidelio DKD, the primary outcome, as I said, was a 40% reduction in eGFR or kidney-related death. Figaro looked at patients who had a cardiovascular non-fatal MI, non-fatal stroke, or hospitalization for heart failure. The primary endpoint of Fidelio was a secondary endpoint for Figaro and vice versa. We also had Fidelity, which was a pre-specified pooled analysis, and it looked at 57% kidney composite endpoint, which is very similar to, as a secondary endpoint, which is very similar to doubling of serum creatinine. Fidelio had more severe patients with their eGFR around mean eGFR of 44 and almost 85% of patients between a 30 and 60 eGFR and albuminuria. Figaro had patients whose eGFRs were mean eGFRs were more than 60, but they had established cardiovascular disease in 45%. So you looked at two different group of patients, one group of patients which had bad kidneys, another group of patients which had decent kidneys with cardiovascular disease. So Figaro actually comes across as the variety of patients that we actually see in our clinic. And Fidelity was a pre-specified pool analysis of both these studies to look at the key outcomes of cardiovascular and kidney composite endpoints. These were the inclusion and the exclusion criteria. Patients should have a good optimal treatment with ACE and ARB for 4 weeks. If you look at primary outcome of Figaro, which was the primary outcome of cardiovascular, it reduces the risk of primary CV outcome of 13%, was mainly driven by hospitalization due to heart failure. If you look at on the secondary kidney outcome, there was a 36% reduction. Again, the endpoint is driven by reduction, not by a softer endpoint, but a very harder endpoint like end-stage kidney disease. If you look at Figaro DKD, it significantly reduced the new onset heart failure by 32%. So again, the heart failure with reduced ejection fraction was excluded in the study. So these were new onset heart failure in patients who came with probably heart failure with preserved ejection fraction or heart failure with medium range ejection fraction. You had a 32% reduction in new onset heart failure. If you look at Fidelio DKD, which was the primary outcomes, was looking at the kidney, there was again a reduction of 18% in kidney specific outcome, again driven by a harder endpoint like end-stage kidney disease rather than a softer endpoint like microalbuminuria or a UACR. If you look at the secondary endpoint of the Fidelio DKD, again, you see a 14% reduction, largely driven by reduction in hospitalization due to heart failure. The exploratory kidney specific endpoint showed a 24% lower of exploratory endpoint, which was a kidney specific endpoint in both the studies put together. The acute effect of finerenone is a drop in eGFR but the long-term effect is slowing of an EGFR decline, as you can see in the curve here. If you look at fidelity, which was a pre-specified analysis, not getting into a lot of details, but there were a lot of patients who were on background drugs which helped the kidney. So majority of the patients, 100% of patients were on RAS inhibition. 75% of the patients were on statins. Patient had a longer duration of action. Male predominance, 65-year-old, very similar to our hypothetical patient. 45% of the patient had history of established cardiovascular disease. 8% of the patient had heart failure at baseline itself. And you can see that SGLT2 use was close to 7% in these patients in this pre-specified analysis. In the fidelity, finerenone reduced the risk of 57% EGFR composite endpoint by almost 23%. So when we say 57% is very equivalent to doubling of serum creatinine, again, driven by a harder endpoint like end-stage kidney disease. It also reduced mortality and more by 14% compared to placebo. Again, the time to first hospitalization due to heart failure was 22% reduced risk, and time to CV death or first HHF was also 17% reduced with finerenone. So overall, if you look, there is a significant amount of reduction, and there was a 30% reduction in 4 months itself in albuminuria, which is the driver for chronic kidney and cardiovascular outcome. If you look at the use of SGLT2 or with or without SGLT2 in that 8% of patients, so you will see that usage of SGLT2 or not did not make any difference in the primary and secondary outcome in a pre-specified analysis of fidelity, which was Figaro and Fidelia put together. So if you look at the CV and kidney benefits of finerenone were consistent irrespective of SGLT2 use at baseline. So whether it was looking at cardiovascular or EGFR or HHF, irrespective of baseline SGLT2, it was favoring finerenone. So finerenone had similar adverse events compared with placebo. We should look at hyperkalemia, hypotension, and hyponatremia when we look at using this particular molecule. Demonstrate good benefit irrespective of SGLT2, irrespective of prior cardiovascular history, irrespective of age, sex, and obesity, irrespective of what stage of chronic kidney disease, and irrespective of baseline blood pressure. That's why the recommendations as compared to 2002 has changed a little. In patients with chronic kidney disease and albuminuria who are at increased risk for CV and cardiovascular or chronic kidney progression, a non-steroidal MRA should be shown to be effective in clinical trials is reduced to recommend CKD progression. For patients with type 2 diabetes and CKD treated with maximum tolerated doses of ACE and inhibition, addition of finerenone should be considered to improve CV outcome and reduce the risk of CKD progression. The ADA guideline has changed from last year, where it was said that you can use it after RAS inhibition if an SGLT2 is not tolerated. That has changed right now. So you have a good class 1A indication for all these products. So whether it is an ACE inhibitor, a statin, an SGLT2, and finerenone in changing outcomes in patients with chronic kidney disease and heart failure as such. So again, if you look at the 2023 update of ESC heart failure guidelines, it has been used in finerenone can be recommended to reduce the risk of heart failure. So again, in prevention of heart failure in people who are going to be at high risk, finerenone has got an indication as such, as is the SGLT2 also has the same similar indication. So if you look at our patient, he's already on a lot of drugs. He's on a lot of preventive. He's on an ARB, he's on an SGLT2, he's on a statin, he's on good drugs for blood pressure. I think if we can, based on the data that we have, if we put him on an additional drug, we can surely reduce his albuminuria and also help him in reduction of his chronic kidney and cardiovascular outcome. In short, when we start at 10. If the patient EGFR is good, start at 20. If you find there's a lot of drop, more than 30% in EGFR, go back to 10, or if you're on 10, continue 10. If potassium, again at 1 month, recheck creat, EGFR and potassium. Potassium rises more than 5.5, temporarily stop and then restart and see how things are handled. Contraindications is Addison's and hepatic impairment, and any other drugs like a ketoconazole, which has a strong, which actually incites the cytochrome 3A4 inhibitors as such. So again, chronic kidney disease is a huge problem, and people with chronic kidney disease die of cardiovascular disease, and hence both cardiorenal prevention of progression of chronic kidney disease should be foremost in our mind when we treat patients with cardiovascular as well as chronic kidney disease. Thank you all for a patient hearing, and I hand it back to Dr. Arvind Gupta to take it forward. Thank you, sir. So you're on mute. So you are on mute. You're on mute.
Yeah. Thank you, Rajiv, for your excellent deliberation on the chronic kidney disease. Let me start one of the basic question, Rajiv, and this basic question is
Sir, sorry for interrupting, sir. Can we have the 3 sessions and then the discussions in the end, sir? For all 3 speakers?
Okay.
Right.
Sure,
Thank you. Dr. Jyoti is also joined in, so you can introduce him, sir.
Yeah. So before we start the discussions, after all the 3 sessions, let me introduce one of my close friend, Dr. Jyoti Dev. I can say one word introduction to him is the digital man of the India. Is a techno expert for all the digital solutions, especially in the field of diabetes. So that is my way of introducing my friend Dr. Jyoti Dev, a digital man of India. Of course, if I can say, is the person who is heading the one of the very big center. Can I have the slides, please? Can I have the slide, please, just for a moment? Yeah. So he is the chairman of Jyoti Dev's Diabetes Research Center. Very, I mean, I can say very well organized center where we can find all the digital solutions, all the treatment options for the diabetes patients. He is also a Central Executive Committee member of RSSDI and ARO. He is Vice President of Kerala RSSDI, and he is the Managing Trustee of P. Kesadev Trust, which is actually organizing so many other programs other than the diabetes programs. He is the Editor-in-Chief of International Journal of Diabetes and Technology, and you can see he is publishing almost a monthly internet journal, and he is also having several international and national publications in the peer-reviewed journals. So Jyoti Dev, we want to hear from you regarding this topic.
Many thanks, Arvindji, for those kind words of introducing me and for that special honor bestowed upon me. And congratulations to dear Rajivji and Shalini for yet another wonderful event, very successful event. I know we are very strictly adhering to the time. So I'll be speaking only for another 18 minutes or so. Am I right? 18 minutes. Okay.
Yes, sir. Thank you so much, sir.
Sure. And if I'm exceeding, please alert me. And this is the title which is given to me by Dr. Shalini and Rajivji, Managing Diabetes Digitally and Virtually. Of course, when you are honoring me as a digital man of India, I should be sharing, and I'll be starting with my own experiences. Recently, many of us are in multiple WhatsApp groups, and recently I happened to see in a WhatsApp group one doctor making a comment. We have been using telemedicine during the COVID times very much, but now we have almost completely stopped using telemedicine. It was a slightly shocking statement for me because I am using telemedicine for many years and still using it. And I personally know more than 20 more doctors, very passionate and probably much more with telemedicine, even after the COVID times. Of course, when compared to face-to-face consultation, they are more into telemedicine practice. So let me start with a story which is from my own biography, and this is in 2011. Because there's a girl sitting along with me in the clinic, and this is Rebecca, who was on a sabbatical from Yale University in the United States. She was a medical student at those times, and now she's a well-known endocrinologist practicing in the United States. And she worked in a conventional diabetes center with us, run by us, and another center, which is a comprehensive telemedicine-based center. And after working with us for almost 1 month, Rebecca approached me. Hey, doc, I foresee that there are differences in the outcomes in the centers when you're comparing the two. Can I do a comparative study? I said, why not? When you are with us, you have to do studies. And whenever there is an idea, please come up with this, and I will, of course, approve it. And she started comparing the two centers. She published this paper in 2016, and we were also slightly surprised that there were differences which were statistically highly significant. Between the two centers, highly significant differences in terms of hemoglobin A1C, in terms of cardiovascular risk parameters, with telemedicine proving to be much, much superior. And she presented the same data in the American Diabetes Association in 2015. And in 2023 American Diabetes Association, that is in the very same year, this year in June, we presented another data of 15 years of telemedicine comparing in the same institution. So the other institution is no longer in existence. We have only the telemedicine-based comprehensive diabetes center now in Trivandrum. And there are people who are getting registered for telemedicine. Then there are a group of people who doesn't like to be followed by telemedicine protocol. So we compared the two. And at the end of 15 years, and this is much more shocking. And we couldn't also believe it. And we presented this at the American Diabetes Association. It was an oral presentation. There were so many questions related to this. With any micro or macrovascular complication, for the telemedicine group, it was only 9.8%, and 82.1% in the control group, or those undergoing conventional management, developed complications. So huge difference in the outcomes when you are adopting telemedicine in our daily practice. And this is how we are sharing our electronic medical records during a telemedicine consultation. And this is over the years how the parameters, and this is the hemoglobin A1C, and this is another parameter. This is the low density lipoprotein over the last 10 years or 12 years or 13 years. And this can also be probably analyzed with the help of an AI or machine learning or deep learning, when it can be used for predicting the complications in diabetes or the early onset of chronic kidney disease or similar other illnesses, which you are probably much aware of. So something new to all of you, because whenever we are lecturing and whenever we are in an international prestigious event like this, something should be there which is new for all of you. And we are all lucky. Of course, it is a little bit late for India. Abbott is now getting geared up for the launch of digital tools in India. And this will be launched in another 2 weeks' time. The Freestyle Libre Link. So the Libre Link app is currently not available in India. So in the Apple Store and in the Google Play Store, it will be appearing within the next 2 weeks' time. And we can all ask our patients to have this deployed in our mobile phones. And the moment it starts working, you can start the Libre sensor and you can visualize the data. It will also provide you with all the glucose in ranges and the metrics, including the TR, below range, above range, and so on. This is my own phone, my own data, where I have been using for a couple of years now, of course, not from India. And this is the real-time data. Whenever I'm scanning, I will get the data. And this is the TR metrics. And the next one is, there is one more. And that is the Libre Link Up. The other is Libre Link. And the Libre Link Up is meant for the people who would like to follow the patient who is using a sensor. And you can share the data with up to 20 people. And they can be your own relatives, mother, father, grandmother, friends, the teachers, the nurses, or even doctors. So the patients can share the data for up to 20 other people. And the third component, of course, LibreLink, some more information, the LibreLink, it is ideal for parents and caregivers. The family member or the friend receives the invitation by the email. And then you can follow the invitation, you click on it, and then you can download the data. Of course, Abbott has made it very particular that this is a very secure and safe platform. The data is secure. The data doesn't belong to Abbott. The data belongs to only the patient. There is a third component, and this is the LibreView. LibreView is a cloud-based diabetes management system. You can visualize all your patients on sensors. It can be Libre Pro, it can be Libre. Again, a very secure cloud-based platform. And there is a separate one for the healthcare professionals and another one for the patients. For the healthcare professionals, we have a lot of data, a lot of information, and a set of clear, intuitive reports. It can provide you with the reports on ambulatory glucose profile. And this is the flow. You apply the sensor. You can use either a reader or a mobile phone app, or you can use both. If you're using the mobile phone, which is connected to the internet, the moment you are scanning, the data is actually stored in real time in the cloud-based platform, and the doctor, me, can also visualize it. And if somebody is using a LibreLink app in the mobile phone, they will also be able to visualize in real time. And then the LibreView, which is there in your laptop or in your desktop, which is capable of generating all the reports, the entire reports. And the healthcare professional will be capable of reviewing the report even during a telemedicine consultation. You need not be there physically present for a consultation. And this is how the LibreView report will look like. You have the TR metrics, the time in glycemic ranges, above range, within range, and below range. And you have the ambulatory glucose profile report in color. And you have the 24 hours graph, the model graph, which looks like a single day graph, but it is collated from all the 14 days of information. And in the bottom panel, you have the daily report. And what are we supposed to do? After 2 weeks, we are supposed to visit libreview.com. And then you have to select India within it. India is not listed currently. And then we have to make our own username. You have to create your own username and password. And the patients can also visit the same platform, and they can also create their own username. As remember, similar to OT Reveal that we have been using for more than 8 years, there is a separate cloud-based platform for the patients, and there is another one dedicated for the use of professionals and for the hospitals. So, okay, let me move on to another one, which is in probably a part of daily lives. We are all part of Google, and Google is a household name now. It's like Dettol, it's like Colgate. And whenever we are sharing the location, what happens? Our dear and near ones will have an information where we are, whether we are in India, where we are traveling within our own state, and are we in a hotel, are we in a park? So the dear and near ones will feel safe and secure. So all of us will have the mind to share the location in real time with the dear and near ones. And this is a perfect example of a connected device. And the diabetes treatment is now transforming to connected devices, connected diabetes care. The telemedicine that I have described at the beginning is also an example of connected care in diabetes. If somebody, like a medical student, is asking you the definition of a connected device, these are physical objects. So when you're using a location sharing with Google, you're using a physical object, your mobile phone, that can connect with each other and via other systems. And this is via a wireless protocol. And they are embedded with technologies such as processing chips, such as in mobile phone, software, sensors. And the wireless protocols can be Bluetooth, Wi-Fi, near-field communication, 4G, 5G, and so on. So the question is, how can connected devices make a difference in diabetes? It makes life simpler. It makes life easier. But for doctors and for the patients in general, connected devices brings down the cost and burden of care in diabetes. The ulterior objective is to prevent the cost, which is the result of complications in diabetes. And we have probably more than 30 to 40 very popular connected devices. Most of you, I believe, are used to by many doctors in India, many patients in India. I will go through a couple of them. Some of them familiar, some of them not that familiar. You know that one of the major challenges in insulin experienced patients in diabetes with uncontrolled glucose is loss of potency of insulin. And we never come to know whether the potency is lost or not. We don't know whether the insulin is retaining the potency or not. And if you are using a mobile health app and a Bluetooth temperature sensor for medication app, every time the temperature approaches or exceeds the safe limit, it will give you an alert. And these are the devices where there is a coin-sized battery, and the battery can last for as long as 8 months or even 9 months. So convenient, so comfortable. And there are connected BP apparatus. And I procured a connected BP apparatus more than 12 years ago from the United States. Still with me, still working. And the modern day devices include even a digital stethoscope, electrocardiogram, and you have the connected weighing machine. And I procured one from Fitbit from India. And that was more than a decade ago, still working. The moment you are measuring the weight, it appears on your mobile phone, it appears on your laptop, on your website, on your, and so on. And it will also give you insights on the weight over the last week, over the last month, or probably for several years. And it can work in unison with Apple Health, Samsung Health, Google Fit, and so on. Connected glucose meters, I will never venture to discuss again because we have been having multiple sessions over the last more than 7 to 8 years. And there are a couple of branded connected glucose meters, highly reliable, capable of generating electronic medical diary. And the take-home point is the M-Health applications which comes along with the connected glucose meters, such as the My Sugar, the OT Reveal, they are far, far superior. And studies have shown that just by using an M-Health application along with a glucose meter, we have also done studies to show that A1C reduction can be more than 0.5%, which is superior to some of the drugs. And moving on to another virtual care, and that is with the help of automated insulin delivery, becoming so popular. 780G is actually not now available in India. It is short supply because of the high demand from the patients, very high demand from the patients. And this is a system where both the basal and the bolus is automated. Another bit of information for those enthusiastic with learning. If somebody is asking you the classification of automated insulin delivery devices, number one, it can be commercial. Commercial can be minimum Medtronic 780G. Then you have the Omnipod 5 from the Omnipod family, Insulet family. Then you have the Tandem, T-Slim, really reliable. And most of them are examples of automated insulin delivery. So there is a pump, there is a sensor which is highly reliable. And most of them are now approved for use by the FDA. And you can even make insulin dosing decisions without using a glucometer. That is non-adjunctive use of a sensor. And then the third component is a highly sophisticated control algorithm. So these are some of the patients, and they have given consent to publish the papers, the pictures of all age groups, starting from very small children to grown-up adults. And what I would like to highlight is, when you're using an injection with the basal insulin, such as Lantus or Tresiba, you cannot stop 2 a.m. and 3 a.m. If you look at this pink area, there is no basal. So if the patient doesn't require insulin, even the basal can be stopped automatically. And if there is a maximal basal delivery and still the glucose is high, these blue vertical lines over there indicate during the sleep at night, even when the patient is sleeping, the device is bolusing automatically. So the basal is automated, the bolus is automated, and most of the patients are lucky enough to maintain a time in range of even 100% consistently, 90 to 100. This is exceeding all the international recommendations. The international recommendations are only to maintain a TR more than 70%. So here, 80, 90, 100% has become possible without much manual efforts. And that too, with factory calibrated sensors, and this is from the minimum Medtronic family. The Guardian 4 is now there in Indian commercial, is available. both standalone as well as along with 780G, which doesn't require a calibration. What is new with continuous glucose monitoring? Soon we are going to have, along with CGM, continuous ketone monitoring from the same sensor. I know some of you will be asking a question, why do we require a continuous ketone monitoring? There are multiple reasons why I can only say, because of the shortage of time, O'Neill has described about the continuous ketone monitoring, comparing this with the airbag in our automobile. You might never require an airbag, but it could save your life. That is how he has compared with the continuous ketone monitoring. Connected pens, I still remember Dr. Shalini Jaggi making wonderful, brilliant presentations on connected insulin pens, connecting via Bluetooth, connecting via near-field communication, transforming the information via NFC to a diascend. So the pens are capable of storing the information, the insulin injection information, the size of the bolus, 800 memory, 1000 memory. There are older pumps, and this is the generation. And these connected pens are supposed to replace at least 30 to 40% of those sophisticated automated insulin delivery devices based on insulin pumps. So it can be TIP, which stands for tracking insulin pen, SIP, which stands for smart insulin pen, or it can be smart insulin caps. And this is on the Bigfoot family, the smart caps. And the moment you scan with the cap of the pen with the sensor, it not only displays the glucose number, it also displays the insulin to be injected. How much insulin as a correction dose need to be injected for the value of 260. Amazing, amazing. And this is the Pendic generation 2, USB cable, multiple pens available, 1000 memory, and it's so special that it is allowing increments of 0.1 units up to 60 units per injection. And if you are so interested to go through the evolution of insulin delivery devices, how we are managing all those delivery devices, this is the review that we have published recently, referred to by the ADA and EAS and EAST in their clinical practice guidelines. And for the geriatrics, we have SOCs, smart SOCs, and these are the 6 key points to detect early signs of inflammation. So the future is already here, and this is going to be the virtual diabetes hospital with all those connected devices and capable of remote monitoring. So this is my concluding remark. Telemedicine, virtual diabetes care, and all those digital solutions already have proven that they are bringing much, much better outcomes in diabetes. But believe me, this is not a substitute for face-to-face consultations. Face-to-face consultations, at least once or twice, should continue along with virtual care. Thank you very much. And this is an official invitation to the World Congress of Diabetes Technologies and Therapeutics, DTEC. And the next Congress is going to be in Kerala, in the city of Kochi, from 17th to 19th of May. So thank you very much, my dear friends, for this opportunity.
Thank you, Dr. Jyoti. I think the people of the country now should know and should use all these gadgets which you have mentioned just now, the connected devices, the connected pens, the virtual diabetes clinic, and probably this is all our dream. We'll ask the questions after this next session. And now the next session will be by Dr. Hitesh. He's a director of Chaitanya Cardio Diabetes Center in New Delhi. He is a member of RSSDI and some of the services, the comprehensive management of type 1 and type 2 diabetes, also the counseling and thyroid disorders, and is hypertension and various cardiovascular disease infections. He's speaking on all these aspects of diabetes management. So now he'll be speaking on chronic lung diseases and diabetes. So Hitesh, the stage is yours.
Yeah, thank you so much, sir. Thank you.
Yeah.
Let me share my slides.
I swear. Chalo, anyways, thank you and have a great time. God bless you.
Shalini, we are all
Bye.
hearing you.
So my slides are visible?
Yeah.
Okay. Thank you so much, sir. Thank you for this introduction, and let me take this opportunity to congratulate Dr. Chawla and Dr. Shalini, for organizing such a feast, the academic feast. And Dr. Chawla, I had privilege of working with him for 14 years, and his organizational skills have been always very, very exemplary, to say the least. So the topic with me today is uh, diabetes with CLD. It's a chronic liver disease, and this is how our flow is going to be like. That first we'll try and understand this association between these two chronic entities, which is diabetes and chronic liver disease, and we'll try and find out the strategies for early diagnosis and intervention, if we can, to make a bigger impact on the outcome of diabetes as well as CLD in these patients. And thus, in the last, we'll discuss very briefly about the most adequate management options that are available to us, and that how and when we should be using them. So first, chronic liver disease, as we know, it's a very, very broad spectrum. We write starting from your non-alcoholic fatty liver disease, what we call as NAFLD, moving on to alcoholic liver disease, chronic viral hepatitis B and C, and certain genetic causes like alpha antitrypsin deficiency, or for that matter, hemochromatosis. And various autoimmune conditions like primary sclerosing cholangitis, primary biliary cirrhosis, so on, and cryptogenic idiopathic. So it's a very vast and very, very broad topic. And if we just talk about the cirrhosis part, so, and as per the definition, it's a continuous process of inflammation, destruction, and regeneration of liver parenchyma, and which leads to disturbance in the architecture of liver, and there is a formation of widespread nodules, and overall structure of liver is damaged. So this is how cirrhosis is being defined. But firstly, because cirrhosis is a very advanced stage we see in liver disease, and there is not too much that as an interventionist or a diabetologist you can do once the cirrhosis is set in, apart from maintaining decent levels of blood glucose. So the place where we can really hit hard, and we really make a difference is this condition, what we call as non-alcoholic fatty liver disease. And this again, what exactly? First, let's see what is non-alcoholic fatty liver disease. So it's a complex disease resulting from various environmental and genetic and metabolic factors. They interact and they produce this disease. And when we talk about the burden, maybe I think most of us will be surprised how huge is the burden. So it's almost like 70% of diabetic population is impacted by this disease. So 70% is a very, 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 very big number. And if we leave out diabetes and if we take general population, even then the prevalence is almost 30%, which means what? This is what I'm talking about globally. So this means that almost 1 billion population on this planet is being impacted by this disease. And along with the other metabolic, the diseases like diabetes and obesity. So this prevalence of this NAFLD is also increasing worldwide. So this is just a brief, view of how globally, it's almost 25 to 32% prevalence in the general population. So it's almost a global epidemic, as we can see here. And we as a population, because of our ethnicity, we are all the more predisposed as compared to our Western counterparts. So this NAFLD is again has two components. One is that it's just the plain steatosis or fatty liver, as we call it. So this is NAFL, which is non-alcoholic fatty liver. And then you have the NASH component, which is when the inflammation is added to it and fibrosis starts coming in. That is the stage when we call this as a non-alcoholic steatohepatitis or NASH, which we all have seen. There is almost a tsunami of these NAFLD and NASH patients, which we have seen in last decade or so, and it has been constantly increasing. So if we talk about NAFL, and if we talk about it in context of type 2 diabetes and metabolic syndrome, it's just one of the hepatic manifestations of metabolic syndrome. So obesity, type 2 diabetes, dyslipidemia, they are some of the risk factors. Along with it, there is also a genetic component which includes various polymorphisms, including PNPLA3, as we know this. So there is not just that it's overweight and these insulin resistant patients who are developing it, but also there is also a genetic variant which is seen in some of the lower weight population as well, or patients those who are not overweight, they also have this tendency because of this genetic predisposition. So when we say NAFLD, it will be wrong to say that it's just contained to the liver thing. The impact or the manifestations or the outcomes of NAFLD, they are really scattered onto various other systems as well. So it leads on to the not just eventually cirrhosis and end-stage liver disease, but it also increases the propensity of cardiovascular disease, of the CV events. Diabetes, of course, has a very strong bidirectional relationship with this, and then it also ends up with leads to, or contributes to chronic kidney disease. So if we talk about the progression in these patients, as we see, so if there are about 80 million, this is the data, because in India we don't have exact figures. So this is the closest that we had around 2021, I think. It was published in the journal by Lumba et al. And they said that if 80 million Americans, they are affected with NAFLD, so it's almost about 20 million are having NASH out of these. And these patients, over a period of few years, the 20% of NASH patients, they develop fibrosis, and eventually 20% of these turn on, they lead on to cirrhosis. And this progression from fibrosis to cirrhosis, that is the various stages of fibrosis that we have, stage 1, stage 2, stage 3, it takes 7 years for a patient to progress from one stage to the other stage, and eventually it leads on to enhanced morbidity and mortality in terms of liver disease. So it's not just the NAFLD or the NASH which makes the difference. Actually, it's the staging of the fibrosis, which is very, very important when we are seeing our patients in our clinic. So we have to be very mindful of this entity. And then we also have to keep in mind that we need to stratify these patients in various categories. So patients we can, high risk, low risk, which are the patients which we can manage on our own, which are the patients which need to be referred in this category. It can make a huge difference. And once we have this insight that the staging of fibrosis has this much impact, so this makes a very big difference in the outcomes of these patients. So the mortality in these patients is not just, again, as we mentioned, from liver disease, cardiovascular disease, extrahepatic manifestations in the form of various cancers. They also play a huge role in overall increasing the morbidity and mortality burden of this disease. So this graph very beautifully depicts the time at which the real inflection point comes in. As we can see that as the patients are moving from fatty liver to grade 1 fibrosis, stage 2 fibrosis, overall mortality is not impacted much, but this inflection point comes at stage 2 fibrosis, and it really takes off after that. And it's not just liver related mortality, it's all cause mortality, including the cardiovascular outcomes and non-hepatic cancers as well. And if on the right side we see the liver related mortality, so this inflection point, it comes at F3 fibrosis. So after stage 3 fibrosis, the cirrhosis develops, and there is an exponential rise in terms of morbidity and mortality in these patients. So how, once we have this insight, so how to go about diagnosing these patients? So gold standard, as we know, is a very difficult option, that is liver biopsy. It's very difficult to subject 1 billion population to liver biopsy, and there are pitfalls in that as well. It's not a 100% proof diagnostic thing. So we have to have certain other modalities as well, and this FIB4 score, many of us may be conversant with it, few of us might be using it as well, but I just wanted to bring it in here because this is something which is very, very useful in our clinical practice. So this is a surrogate which uses this FIB4 score. It uses just 4 components. One is age of the patient, liver enzymes, SGOT-PT or AST, ALT as these are called. And fourth is the platelet count. Platelet count again, has been one of the sensitive, very sensitive indicators of chronic liver disease. And I remember during our rounds when Dr. Chawla and we were together. So this thrombocytopenia was one clue which led us to many patients of chronic liver disease. And similarly, FIB4, this brings into account these 4 factors, and you put these factors as per this equation. And we have all mobile calculators and apps these days. It's very, very easy. And this is the figure that we need to stress upon, 1.30. So once you put in the data and you get the FIB4 score, the figure comes out, and anything less than 1.3 makes us very comfortable that this patient has very less chances of moving on to liver fibrosis, or the burden of liver fibrosis in this patient is not likely to be very high. Similarly, on the other end of the spectrum, we have this figure of 2.67. Again, this just increases the chances of a particular patient having liver fibrosis exponentially. And in between 1.30 and 2.67 is the gray zone, and almost 1/4 of the population falls in this zone where we need to go for further investigations. Now, the beauty about the FIB4 score is that it has got a very good negative predictive value. When I say negative predictive value, what I mean is that if the score is less than 1.3, then you can be very, very comfortable that the patient is very unlikely to have a liver fibrosis burden at present. But if score is more than 2.67, then the chances of him having they are moderately increased. It may not be having as good a positive predictive value, as great a negative predictive value it has, but still it does carry a modest benefit in terms of positive predictive value as well. Those patients who are in gray zone, then these are the patients who need to be referred to this ultrasound modality that we have, what we commonly call these days as a fibroscan. And in fibroscan, again, we know that anything less than 8 kilopascals just relieves us in terms of that the patient might be having very less fibrotic burden, if at all. And again, at the same time, if the score is more than 12, so it again makes us these are the patients which they are very likely to have very high risk of having this liver fibrosis, advanced stage of liver fibrosis, and these are the patients which need to be referred to hepatologists as well. So that was about the NAFL part. Now we'll move on to the other extreme spectrum, which is the liver cirrhosis. And if we just take out NAFL and just talk about the cirrhosis part, so here the prevalence is almost 30 and 40% if we are talking in terms of diabetes and impaired glucose tolerance. Now this prevalence again keeps on this prevalence of this impaired glucose homeostasis, it keeps increasing as the severity of liver disease increases. And as with NAFL, this association again is bidirectional. So what do we mean by bidirectional is that diabetes, as we know, is a risk factor of liver cirrhosis. Being both of them, they share, because diabetes is underlying mechanism is insulin resistance, and NAFLD, and when it is non-alcoholic, and in alcoholic and other reasons, so we have different reasons, but if you're talking about NAFLD, so this again, because of the diabetes resistance, is playing a huge role in the development of progressive fibrosis and in chronic liver disease. And liver cirrhosis in itself again is a diabetogenic condition. So this makes this a very interesting, this association between these two conditions. So considering this bidirectional relationship, there have been two types of diabetes which have been associated with chronic liver disease or liver cirrhosis. So one is our traditional type 2 diabetes, and other, which is little lesser known entity, is what we call as hepatogenous diabetes. So hepatogenous diabetes is those patients, those who develop their diabetes once the liver failure is already set in. And this slide depicts the pathophysiology of this condition. So as we can see here, so as there is a liver disease is progressing, there is insulin resistance at the level of direct insulin resistance at the level of liver. There is indirect insulin resistance at the level of muscles and adipose tissue. Along with it, the clearance of insulin is also decreased because of impaired hepatocellular function, and portosystemic shunts have already set in, so they also impair the clearance. So all these features, what they lead to is hyperinsulinemia, and this hyperinsulinemia, when it persists to some time, it leads on to the beta cell fatigue, and as we know that the entity that is glucotoxicity, which leads to this impairment, and this function of beta cells thus impaired, this leads on to diabetes, which is labeled as hepatogenous diabetes. But since it has not got any certification or any accreditation from any international classification systems, so it remains a relatively unknown entity. So if we are discussing the differences between the type 2 that we generally see in patients with cirrhosis versus hepatogenous diabetes, so these are the few of the differences, right, starting from the onset. So if we talk about hepatogenesis, it usually starts when the liver disease is very advanced. And in type 2 diabetes, of course, we know that it's present many years before. Clinical presentation, again, in many of these hepatogenous diabetes, because the liver disease is very advanced, hypersplenism has set in, there is alteration in the red cell turnover, so we don't get very true values of HbA1c in these patients, but this can be detected by abnormal OGTT. But in type 2 diabetes, we know that we have very clear-cut markers. So if we talk about the metabolic risk factors and vascular complications, they are lesser common in hepatogenous diabetes, but liver complications, of course, they are more when we are talking about hepatogenous diabetes. Very important point is that why are we distinguishing between these two is, once you put the patient on OLT, by OLT it's orthoptic liver transplantation. So the patients, those who had hepatogenous diabetes, once they undergo this liver transplant, the chances of them reversing back to normal or euglycemia without the aid of medication is very high as compared to the normal type 2 diabetes. Now we'll discuss very briefly about the complications which are associated with diabetes and when it is associated with chronic liver disease. So as we know that hepatic encephalopathy is one of the manifestations of decompensated liver disease or advanced liver disease. And here, the role, various prospective studies, where retrospective cohort studies, they've all shown that once a patient is diabetic, his incidence and as well as the severity of hepatic encephalopathy, it increases tremendously. Similarly, the other complication being the variceal hemorrhages. Again, there is a link between this hyperglycemia, which leads on to splanchnic hyperemia, and which further leads on to hepatic venous pressure is increased. So again, these patients tend to have more of hemorrhages. Their hemorrhages are more severe as well. And this entity has got a very interesting relationship with your postprandial hyperglycemia. Interestingly, increased fasting plasma glucose levels, they had not much of relationship with variceal hemorrhages, but increased postprandial levels, patients showed more tendency towards variceal hemorrhages, and once they had it, they were more severe, leading on to increased morbidity and mortality in these patients. And similarly, the patients, those who were ligated, again, in those patients, again, the risk of rebleeding was increased in these patients. As expected, again, infectious complications, and in particular, if we want to talk about liver cirrhosis, as we know that decompensated cirrhosis is accompanied by ascites, so spontaneous bacterial peritonitis is again, its frequency is increased, and again, it takes longer to resolve the manifestations of this entity once the patient has diabetes along with the CLD, and this eventually leads on to increased mortality as well. Hepatocellular carcinoma, again, there have been reports which say that those patients who are diabetic vis-a-vis compared to non-diabetics, they tend to have increased risk regardless of the prevalence of liver cirrhosis. So we come to the treatment part, and in treatment part, again, we know that it's going to be dependent on a lot of factors on what stage of liver disease the patient is, what comorbidities the patient has. But one thing which stands is the lifestyle management, as we call it. and which includes your diet and physical activity. And in patients, especially those patients who are developing your NASH, these tend to be overweight or obese patients many a times. So here, as we know that approximately 10% of weight loss, it makes a very huge impact in the outcomes of NASH or NAFLD as well. But this problem is that if on the other extreme spectrum, the patients are very asthenic, they are sarcopenic, they're very weak. So you can't, apply all these similar to both the groups. That is, to those patients who are in the early stage of the disease and the patients who have advanced stage. So we have to have a balanced approach in either cases. So those patients with NASH, they need very good amount of weight reduction, which may not be applicable in patients with cirrhosis. Similarly, in patients, those who have NASH, we might need to do some caloric restriction, but in these patients, again, we have to supplement proteins, these patients, those who have cirrhosis as well, because their muscle mass is not that good. And so these patients, the training in form of resistance training and aerobics in moderate intensity can do some benefit to their muscle function as well as mass. So in terms of pharmacological therapy, we'll very briefly touch upon this. Again, as discussed, depends on these two factors: how much is the liver damaged, and what are the other various comorbidities that are seen in these patients. So non-insulin agents, if we talk about, so it's alpha glucosidase inhibitors. They have very well established safety, especially in childhood class A and B. So they can be very safely given, and they have shown to reduce not just A1C, but they have also decreased incidence of hepatic encephalopathy in few of the studies as well. Secretagogues, as sulfonylureas and glenides, they are red flags, as we know. They can only be used in patients who have mild disease because they are metabolized by liver, and the chances of hypoglycemia go up tremendously in this patient population. Insulin sensitizers, metformin, again, it's not metabolized by liver, but it has been associated with risk of lactic acidosis. But though these are very few anecdotal reports, especially in patients who have concomitant alcohol intake. So it's not much of a problem as it is highlighted to be. In fact, metformin's chronic use has shown to have reduced the liver-related complications. It has also shown increased survival in these patients, and also these patients have reduced.
Okay, Hitesh, you can conclude, please.
Yes, sir. It's just 2 minutes. And another sensitizers that we were talking that is available to us is TZDs. And TZDs, again, we have seen that these are one class of drugs which has shown very good benefit in hepatic clearance of fat. So these are used if they're used in patients with NASH, they're found to be useful. But again, they're metabolized entirely by liver. So use is restricted in chronic liver disease or advanced liver disease only in patients in class A of childhood. And again, fluid retention and decrease in bone mineral density is a problem. DPP-4 inhibitors, again, we know that we don't need much of a dose adjustment unless and until CKD is accompanied. But the problem is that though they have shown they have been used in all liver disease patients, but there is this very important meta-analysis which showed that the rate of decompensated cirrhosis was significantly increased in patients those who were on DPP-4 inhibitors. This is GLP-1 receptor agonist. So this is one class of drugs where we want to highlight again, because we were talking a lot about NAFLD and NASH today, and this is again one class of drugs which has been found to be extremely useful. And liraglutide, dulaglutide, and sema, which we are using, dulaglutide and sema in Indian settings. So again, they have been found to reduce your hepatic fat clearance by almost 50%. And now we have triple agonists where we have GLP-1 receptor, GIP-1 receptor agonist along with a glucagon receptor agonist. And there again, not just the weight reduction, but hepatic fat clearance is reported to be as high as 80%. So this is a very, very promising class when we are talking about making an impact in terms of the outcomes or the long-term results in patients who are in NASH or early NAFLD stage, where once the introduction of this molecule can make a big difference. SGLT2 inhibitors, again, a brief mention here, class A and B, they can be used. and because of their diuretic impact, so at times they potentiate the impact of mineralocorticoid receptor agonists, which are used in these patients along with diuretics. And last slide is that insulin, we know this drug of choice, but again, there are 2 points which I would like to highlight. Human insulin, again, because it's being metabolized by insulinase enzyme in liver, it leads to hypoglycemia in these patients, so it should be used with caution. Analogs are safer option in this set of patients. And again, in a very interesting recently published cohort study, the insulin use was also found to be associated with increased risk of CV events and liver-related complications as well. So again, it's not just that insulin is a blanket this thing, but in patients, those who are compensated, even drugs like GLP-1 receptor agonists and SGLT2 inhibitors or pioglitazone, they can be a useful this thing. Once the decompensated, then we don't have any other choice. That's it. Thank you so much.
Thank you, Dr. Hitesh. Dr. Shalini, we have 10 minutes, 9 minutes already.
Yes, sir.
So
yeah,
can we have a little discussion?
Sure, sir. Sure, sir. We have about 6 to 7 minutes for discussion.
Okay. So Rajiv, are you there?
No, Rajiv had to log out. He
Rajiv
has a
has
flight
left.
to catch.
Okay. So we want to interact with Dr. Jyoti and Dr. Hitesh. Dr. Jyoti, what do you think with the new technology and everything? Most of the people will adopt all these technology. It is possible at small places and the rural places, I mean, because we have to address the primary care physicians also, and you are talking about the urban elite. So how you make intruding those rural population or even semi-urban population?
I believe, Arvindji, the answer is within embedded in your question itself. So we are skeptical about our rural population adopting technologies. But I have actually gone through some of those digital solutions, which are simple and some of them are really complex. And I will say that 780G is very, very complex, and even an affordable person will find it slightly difficult to use it properly, the artificial pancreas. But the other technologies, whoever is using a smartphone, most of them can use it. And what I have said is, if you are using a mHealth application such as My Sugar, or an mHealth application for weight management along with a coach, it invariably results, along with the help of the doctor and the dietitian in the same hospital, in maintaining the targets. So I think reaching a target may be probably possible for many people, but maintenance of target. Dr. Hitesh was discussing about fatty liver, and he discussed about the triple agonist and all the remedies. But ultimately, it depends upon maintaining what you have achieved. And for maintaining what you have achieved, I think technologies are definitely helpful. And for rural people, I think cost makes a difference rather than use of a technology. And if a application is available at no extra cost, because most of these mHealth applications comes with no extra cost as a value added along with the device, which is also probably provided free of cost. Type 1, they get it free of cost. Most of the poor people are getting it free of cost. And when you compare with the expensive medications and the A1C reduction, it happens at the expense of a hypoglycemia, or they may discontinue medications, but medication adherence also can be ensured if you are using a mHealth application. So the ulterior objective is whoever is using a smartphone, whether they are in urban or rural population, we doctors should be promoting the use of mHealth application with a proven evidence.
So it is actually the government assistance will require to provide these type of new technology services to our semi-urban or rural population. And just I want to inform, in the Rajasthan government, it will be a free of cost insulin pump very soon.
Oh, wonderful, wonderful,
So,
wonderful.
Okay.
Yeah.
Hitesh, Dr. Jyoti has just instigated the question of about the body weight, especially in the setting of chronic liver disease, or especially in the NASH or NAFLD. So what do you think? It is very, I think it is very difficult for a person to start the weight loss lifestyle interventions. Any drug you promote, or it is first line is always the lifestyle intervention?
So yes, I think both things. I think first is apart from patient, a physician has to be equally motivated to do this for his patients. So first is that our awareness of this weight burden, which is leading on to these complications, is also very important, because then we can emphasize a lot more. Otherwise, the topic of weight discussion in our clinic chambers is very brief. It's we just touch upon it. Patient also finds it's boring. Doctor also finds it's little boring, and then it's not being discussed in detail. And that's the reason that that motivation is not being taken forward by the patients as well. So as you said, yes, I mean lifestyle modification is very important. And I personally feel that these additional drugs, and we are in very interesting times these days, because we are getting every 3 weeks we are getting something new which is coming up, dual agonist, triple agonist, and now it's almost they're saying that 25% weight reduction, 28% weight reduction with these triple agonists. This is very encouraging, but this should come, first with the lifestyle modification. Unless
Okay.
and until you are doing that, I think it doesn't make much of a sense to use drugs straight away.
What do you have any saroglitazar or pioglitazone or vitamin E? They are class 2, class 3, or class 4 evidences for management. Even
Yes.
the enzymes, ursotic oxycholic acid, UDCA.
So again, I mean vitamin and
Are they useful or not? That is first thing.
So again, pioglitazone is definitely useful, especially if you identify the patients little early, and as we discussed, so they don't have relative contraindications for the drug, and this is something which is proven in non-diabetic patient population as well. And second is again vitamin E. For vitamin E, there have been some reports, which are suggesting that they might not be, and they have been linked to some prostate cancer in few of the studies as well. This high dose of vitamin E, but still, I think these are the two, vitamin E, and these are very useful drugs. But I'll say, we'll jump the guidelines, and if patient can afford and patient is a candidate, GLP-1 receptor agonists are doing a wonderful job here.
Saroglitazar of late has been implicated for use in NFLD.
Yes.
Yeah.
I think a lot of gastroenterologists, have started prescribing saroglitazar for a lot of patients now. Vitamin E and saroglitazar.
Yeah, few new evidences have come just now.
Yes.
I
So
think,
I think-
Stanley, living examples are very important. Living examples of determination in weight loss and weight maintenance. Dr. Stanley, it is very important.
Absolutely. Okay, yes.
Thank you, sir.
Yeah, you have already pointed out the right person.
Yeah.
Okay.
So thank you so much.
Yeah,
Thank you so much, speakers and chairs, Dr. Gupta, Dr. Hitesh, Dr. Jyoti Dev, Dr. Rajiv Kovil, for this wonderful session. I think we've had a great start. We started with a sixer, and I'm sure we'll continue our innings exactly same way. So thank you for your deliberations, and thank you for joining us. With this, we move on to the next symposium. Again, a very important symposium to be chaired by Dr. Hitesh as well as Dr. Madhusmita Mishra. Dr. Hitesh has just been introduced. Dr. Madhusmita Mishra is consultant, Mishra Diabetes and Endocrine Center, Cuttack. So over to you, chairs, for the next symposium. Dr. Hitesh, you can introduce Samar, sir.
So the next session, let me just go through the topic as well. So I think Dr. Samar Banerjee needs no introduction. He has been such a big shot in the field of diabetes. So without wasting any time, so I'll just pass on the baton to him. Over to you, sir.
Welcome, sir.
Yes, could I start?
Yes, sir, you can start, sir. Dr. Samar will be talking on MASLD, a new entity in diabetes. We just heard Dr. Hitesh talking about CLD. So Dr. Samar is going to take us further and give us what's the latest when it comes to the metabolic associated liver disease.
Thank you, Salini. I was just listening to the discussion. Probably I'll not differ much. I've got some points also. I'm going to today discuss about the MASLD, a new entity in diabetes. Let me clear at the beginning that these are actually, so long we called it as non-alcoholic fatty liver disease. Recent from the 2023 American Association of Study Liver Disease, they have given the name MASLD, which means metabolic defect associated steatosis and liver disease. They wanted to clear the stigma of fatty. That means that even it can occur in lean person and also can occur in person who are having permitted amount of alcohol. To come to the next point, I regret that there will be some overlapping of terms of NFLD, MSLD, as the initial name is more familiar with all of us. What is the definition? Hepatic steatosis, either by imaging or histology, no cause for secondary hepatic fat accumulation, such as significant alcohol consumption, use of steatogenic medication, or hereditary disorders. And these, by the alcohol, means ongoing or recent alcohol consumption, more than 21 drinks on average per week in men, and 14 drinks on average per week in women is a reasonable definition. So below this, we will not call it as an alcoholic fatty liver disease. The question is that non-alcoholic fatty liver disease is a cause or consequence of type 2 diabetes. This is not yet settled. Sometimes we see MSLD earlier, then diabetes, in some cases diabetes, then NFLD. Additive effect of non-alcoholic fatty liver disease on the development of diabetes in individuals are also we are coming across. And let me see what is the incidence group. And it has shown that if I compared between the non-alcoholic fatty liver and type 2 and follow up, we see that with improvement of the non-alcoholic fatty liver disease, there is definite improvement in the incidence of diabetes. So NFLD we are treating at that point, not diabetic. With treatment, incidence of diabetes is coming down. What is the actual incidence? For last 2 decades in USA, 4-fold increase in adolescent and obesity rates have more than doubled. Indian data by Mohan et al. Diabetic patients are 54.5%, pre-diabetes 32.4%, and normal glucose 22.5%. So if we combine together, we come to a figure of near 87% who are either diabetic or pre-diabetic. Another study, another Indian study, Singh et al., prevalence of diabetes 24.8%, pre-diabetes 22.9%, and all these patients had higher blood pressure, serum, higher triglyceride, higher obesity, central and resistance. All this indicates presence of the metabolic syndrome. It is also common in type 2 diabetes, present in 50 to 60% of type 2 and up to 45% of type 1 diabetes. We are very much reluctant for screening type 1. Biopsy-proven NASH in asymptomatic type 2 with normal liver function test is 20%. So liver function test 20, biopsy shows the abnormality 20%. 80% of the patient, any one of the metabolic risk factor, with 1/3 of individuals having the metabolic syndrome itself. And if I compare between its manifestation in type 1, pre-diabetes, and type 2, steatosis is gradually increasing when I go from type 1 to pre-diabetes to type 2. Similarly, NASH, which means inflammation, also fibrosis, and also development of cirrhosis. These are all higher in type 2 compared to pre-diabetes than compared to type 1 diabetes. And even non-alcoholic fatty liver disease is prevalent in women with prior gestational diabetes and independently associated with insulin resistance and waist circumference. This is a liver outcome in patients with type 2 diabetes. 501 patients studied, non-alcoholic fatty liver disease, advanced fibrosis and cirrhosis seen in 65.3%, 14%, and 5.9% patients respectively. So very high degree
of fibrosis or cirrhosis. Obesity and insulin use were significantly associated with increased odds of advanced fibrosis. Another study shows that fibrosis progression in diabetic is more higher than the non-diabetic patient. This is the curve which is showing diabetes has significantly higher incidence rate of fibrosis if you have compared for the 4-year follow-up, or even if you compare up to 12 years when it becomes about 76%. What are the structural alterations? These are our study from Calcutta NRS Medical College, that hepatic fat accumulation is a well-recognized complication of diabetes with a reported frequency of 40 to 70%. At initial diagnosis, diabetes, 40 to 70%. And we found that fatty changes present in 43%, inflammation 40%, and more advanced disease in cases of 23%. And this patient even had atherosclerotic changes in the carotid intermedial thickness. And so we label MSLD not as a disease of liver. It is a marker for metabolic syndrome. It is a multi-system disorder. I am showing how 45% increased risk of future cancer adenoma and subsequent colonoscopy. So colon adenoma higher, and also higher incidence of gastric and prostate cancer. Significant coronary artery disease present in 84.6% of those with fatty liver and 64% of 1% of those without. So this is statistical significant. MSLD people are having higher coronary artery disease occlusion. The established association with MSLD, obesity, type 2, dyslipidemia, and metabolic syndrome. Emerging association, polycystic ovary, hypothyroidism, obstructive sleep apnea, hypopituitarism, hypogonadism, and pancreaticoduodenal resection. One study has also shown that vitamin D deficiency is also associated with non-alcoholic fatty liver, independently associated with definitive diagnosis of NASH and increased histological severity. These are also associated with cardiovascular diseases. And NASH with liver fibrosis increases mortality by 70% due to an increase in CVD mortality by approximately 300%. So NASH, more and more chances of cardiovascular disorder, and also more chances of chronic disease. Again, chronic disease may inversely trigger the NASH procedure. NFLD is also related to increased arterial stiffness and independent cardiovascular risk factor that further raises cardiovascular disease. Associated with ventricular arrhythmia in patients with type 2, associated with myocardial structural changes and load-dependent indices of left ventricular function indicating subclinical heart failure. For patients with diabetes with ST segment myocardial infarction with percutaneous coronary intervention, NFLD independently predicts impaired myocardial function and adverse hospital outcome. These are also associated with 42.5% of acute ischemic cerebral stroke. This is about the problem, about the situation. Now I'm going to how to diagnose and manage. Majority are symptomatic. Some may report a malaise, abdominal discomfort, fullness, constipation. Hepatomically, in many of the patients, acanthosis nigricans is a marker of metabolic syndrome. And some cases may present with total hypertension. These are the stage 4 cases. Ascites, splenomegaly, spider nevi, in a small percent of patients who present with NASH-related cirrhosis. So briefly speaking, we come across obesity, central fat accumulation, impaired glucose regulation, hypertriglyceridemia, hyperuricemia, low HDL, hypertension, and cardiovascular disorders. Diagnosis, definitely liver function test, and by liver function test, at advanced we come across with hyperalbuminemia. Early cases, liver enzymes are altered, SGOT, SGPT, and GGT. More marked is GGT, and more important is the ratio between the SGPT and the SGOT. Even in some cases, they may not have any changes in the liver enzyme. Imaging, ultrasound, which first indicates fatty liver but cannot say anything about the stages, whether there is fibrosis or not, fibroscan, CT scan, nuclear MRI imaging, and magnetic resonance spectroscopy. Liver biopsy remains the gold standard method to diagnose NAS, but not possible to do in all the cases. I will come to what are the indications. Enables a confirmation of the diagnosis and also a grading of fibrosis. Few imaging studies are available for assessing the severity, liver stiffness, as measured by ultrasonographic techniques such as fibroscan or acoustic radiation force impulse, or with the less available MR elastography. These are all useful to finally decide whether there is fibrosis or not. Indication of biopsy, an increased risk with patients who are at the increased risk to have steatohepatitis and advanced fibrosis, which we decide from the fifth force score. Liver biopsy should be considered in patients with suspected NFLD, in whom competing etiology for hepatic steatosis and coexisting chronic liver disease, when we cannot differentiate whether other liver diseases are there or not. Let me advise everyone to be very acquainted with the fifth force score. I'm coming how to do it. Fifth force score normal up to 1.3. If it is 1.3 to 2.6, indeterminate risk, and then you think of doing the scan for the fibrosis by visit. What are the very useful scoring? One is the NFS, and but very easy is fifth force score. This you can do easily, or you can go to the web, download the app. This is by age in years into AST level divided by platelet into square root of ALT. So I remember as AAPA, I call it as APA, age, AST, platelet, and ALT, square root, to give the fifth force score. And fifth force score, I'm coming to the details, how to tackle. What is the steps for diagnosis and approach? Patient at risk of chronic liver disease. Check for liver risk factors. You check for the alcohol, metabolic syndrome, hepatitis B, hepatitis C, familial history. Test for the enzymes and the platelet. If it comes as viral hepatitis or other causes, refer to liver specialist. But if this goes in favor of the non-caloric fatty liver, you go for the fifth force scoring. Fifth force scoring, less than 1.2, low risk, just go for follow-up, do the fifth force score by every 1 to 3 years. And if the fifth force score is above 1.3, you go for transient elastography or the hepatic elastic scan. If this scan value is below 8 kPa, low risk, above 8, intermediate, high risk. So what you do? You go for some serum test available combined, and also go for passenger serum test which are not easily available. And all these cases, if it is of higher risk, you better consult a hepatologist and go for the treatment. Presence of non-alcoholic fatty liver, go for risk assessment. If FIB4 is less than 1.3, repeat non-invasive test. You advise lifestyle modification. But if it is more than 1.3, go for the vision control transient elastography. And if the value is more than 8 kPa, then you go refer to the liver clinic, and they will think of liver biopsy, hepatocellular carcinoma screening, lifestyle modification, and others. The diagnostic approach is something like this. Management strategy, like a pyramid, you must start with lifestyle modification, target components of metabolic syndrome, liver-directed pharmacotherapy, and if cirrhosis is there, to manage the complications. Till date, this is a recommendation of Government of India, Director of General Health Service. No effective medical intervention exists that can completely reverse the disease other than lifestyle changes and dietary alteration to reduce weight and possibly bariatric surgery. Few studies have suggested that weight loss may be associated with regression of fat and resolution of fat-related inflammation within the liver. Therefore, the most important recommendation is lifestyle modification, prevention of alcohol, etc. Till now, FDA has not recommended any medication as guideline, but some drugs like pioglitazone or vitamin E are very much helpful. So what we do? How is the process? First is to go for losing weight, take some methods for anti-steatotic, lipid metabolism improvement, lipid lowering agents are helping. You go for inflammation improvement, cardiovascular risk reduction, you go for the possible inhibition of antifibrotic. There is fibrotic growth factor 2 inhibitor, which are in the pipeline. Briefly, diet, calorie restricted, 600 calories less than the daily requirement. Aim to lose 0.5 to 1 kg per body weight, and as usual, fat restriction. Target 7 to 9% loss of body weight. Exercise, I am not going to details. Orlistat, little bit improve the enzyme and steatosis. Bariatric surgery, improves steatosis. Pioglitazone reduces hepatocellular injury and fibrosis. Up to fibrosis level, pioglitazone is useful, even in non-diabetic person, but it cannot prevent or retard malignancy if started. Vitamin E, this is well recommended for diabetics, non-diabetics. They are showing very improved result, improving steatohepatitis. But in diabetics, it are also acting, but if you use more than 6 to 9 months, there are chances of hyperlipidemia and hyperglycemia. Vitamin E, I just discussed. This should be used as an 800 milligram per day. And there are also some effect of omega-3 fatty acid. UTCA is not recommended by any recent studies. Statin independently and negatively associated with both NAS and significant fibrosis. But above all, they improve the cardiovascular morbidity and mortality. Omega-3 fatty acid dapagliflozin combination has shown some improvement in type 2 diabetes. Ezetimibe also inhibits fibrosis and ballooning of the cells. Semaglutide, GLP-1 analogs, both oral and injection, are also producing very much good results. And this is about managing diabetes and NAS, patient with indeterminate risk and high risk. I am not going to details. The GL Gold dietary recommendation, lower the A1C. I'm coming which anti-diabetic are prepared, and metformin, sulfonylurea, D4 inhibitor, acarbose insulin are of choice. The next important point is this can occur in lean and NAS also, and the treatment is more or less same. There the weight loss is not any of help. Manage dyslipidemia with statin, but regular exercise and some weight loss will also help. Newer drugs are lanifibranor, rosmetirone, and efruxifermin. And regarding the drugs which are used very commonly available drugs, pioglitazone reduces liver fat content. It also raises the plasma adiponectin level. Improving adiponectin level means suppression of the inflammation. One study showed that 58% of the patients with pioglitazone achieved the primary outcome of reduction of at least 2 points in non-alcoholic fatty liver disease. Pioglitazone treatment correlated with improved histological scores up to fibrosis. Over 30 months of therapy, all 18-month metabolic and histological improvement persistent. So when you stop after 3 years, the results are persisting. These are the studies which assessed the effect of glycoside, liraglutide, and metformin. And this is the first study to provide evidence of efficacy and tolerability of glycoside sulfonylurea lowering intrahepatic fat content. Of course, with liraglutide definitely, to metformin to some extent. Vildagliptin treatment showed significant reduction in intrahepatic triglyceride level, and in 6 months the reduction was independent of any weight change. It also showed reduction of plasma ALT level over 6 months. In an experimental model of high fat induced NFLD, losartan significantly decreased the hepatic expansion of plasminogen activator inhibitor 1, which is an inflammatory marker. Similarly, studies have shown SC inhibitor and statins also improve both cardiovascular outcome and liver fibrosis. What are the newer innovative strategies? Emerging therapies for NAS include obeticholic acid, a synthetic effector agonist, GFT505 insulin sensitive liver targeted dual PPAR alpha and delta agonist, PPAR alpha and gamma agonist, chemokine receptor agonist, numerous fatty acid, bile acid conjugate conjugates and antifibrotic agents have been investigated. Simtuzumab, a humanized anti-lysal oxidase to monoclonal antibody. RO5093-151, an inhibitor of 11-beta hydroxysteroid deoxygenase type 1. Finally, there are few and controversial data about the use of prebiotics and probiotics. The other drugs which are also there, Tropic-support, Cilofexor, Nidufexor, Elafibranor, Saroglitazole, Lanifibranor, Aramcol, Fibrocoastal, and liraglutide and semaglutide. In the conclusion, I like to mention that metabolic defect associated liver disease has become the leading cause of chronic liver disease worldwide, causing considerable liver-related mortality and morbidity. I routinely do one ultrasonography for all patients at diagnosis and every year to look at whether there is fatty liver or not. Together, we also get problem with the pancreas, problem with the gallbladder, problem with the kidney, problem with the bladder. During the past decades, it has also become increasingly evident that it is a multi-system disease. Again, I repeat, fatty liver is not a disease of liver. It is a manifestation of multi-organ disease of metabolic syndrome. The current liver-centered approach of NFLD should therefore shift to a more holistic approach, including specific assessment of cardiovascular disease that should be limited to the treatment of concomitant cardiovascular risk factors, but should ideally include permanent parameters of subclinical cardiovascular disease. As a metabolic memory negatively impacts our potential treatment-induced survival benefit, early treatment might be warranted, challenging the currently defined target population for clinical trial in this NAS. For the diabetic treatment, the drugs of choice, which also help in NFLD, are number 1 pioglitazone, number 2 GLP-1 analogs, and number 3 is SGLT inhibitor. ELIP study has shown proof beyond doubt SGLT inhibitor removes the fat, inhibits inflammation, but its role on fibrosis when established is not yet established. During the past decade, it has also become increasingly evident NFLD is a multi-system disease that affects many extrahepatic organs. As metabolic memory negatively impacts the potential treatment induced, we should keep it in mind that any diabetic or any non-diabetic obese, even lean diabetic, may develop NFLD. Weight loss, optimal management of diabetes and dyslipidemia would improve hepatic histology and also improve cardiovascular morbidity with the care whether the patient is developing hepatocellular carcinoma or not. I express my thanks to you for peaceful listening and also making this 10 books successful. Thank you for your patient hearing.
Thank you. Thank you, sir. Thank you, sir. Thank you so much. So now I request Dr. Madhusmita to please introduce Dr. Astha Chawla. Dr. Madhusmita is there? You have to unmute, ma'am.
Yes, Dr. Astha Chawla. She's from Department of Skin and Vidhi Sardar Patel Medical College, Bikaner. She has 5 publications in index journals. She has authored 3 chapters in books on diabetes, and she's the winner of GSK State Quiz and International Aesthetic Asia Quiz. So, please, ma'am, Dr. Astha Chawla, can you please start your deliberation?
Yeah, sure. Hi, everyone. Good afternoon. So, can you see my screen?
Yes.
Okay. So I'm going to be talking about the dermatological manifestations of diabetes mellitus. Now, before proceeding, I would like to ask, do you think integument can be a curtain raiser for systemic diseases like diabetes? Well, the answer to that is yes, and let's see how. So the incidence of different cutaneous manifestations in studies have shown to be between 30 to 70%, and it can either precede the development of clinical diabetes or it can happen post-development of diabetes or the diagnosis of diabetes as well. The prevalence is similar in type 1 and type 2. However, in type 2, cutaneous infections are more common, whereas in type 1, autoimmune-related lesions are much more common. Now, we can classify them in 4 major groups: the cutaneous manifestations of diabetes, the cutaneous concurrences of diabetes, diabetes associated with dermatological pathologies, and then diabetic therapy itself causing some cutaneous complications. talking about the first group, the cutaneous manifestations. As all of you would have seen in your practice also, one of the most common manifestations in skin we come across is acanthosis nigricans. Now, this typically presents as a velvety or a verrucous plaque, commonly seen on the skin folds like the neck or the axilla, sometimes even in the groin. The important part to remember here for a physician or an endocrinologist is lot of times we come across acanthosis nigricans not just in the folds but also on the face, which is called as facial acanthosis nigricans, which is mistakenly treated as a facial melasma or other pigmentation. So this is also a spectrum of acanthosis nigricans, which in recent years has shown to have a predilection of involvement of the perioral area and the perinasal area. How do we treat it? Obviously, we need to have a good metabolic control. And as far as the cutaneous treatment is concerned, we need to give depigmenting agents and keratolytic agents. Then we have acquired perforating collagenoses. Now, these predominantly present as perifollicular, dome-shaped reddish to yellowish nodules, commonly seen on the legs, and they present with central keratin plugs. Besides metabolic control, we need to give topical retinoids and topical corticosteroids along with emollients. In some cases, we might also have to proceed with phototherapy. Diabetic bulla. Now, an important thing to note is diabetic bulla is almost always sterile and it presents on a non-inflamed skin. You would not see much redness in a diabetic bulla as compared to a bulla which is arising out of an infective condition. Treatment would be simple sterile drainage and followed by topical antibiotics. Diabetic dermopathy, also called as shin spots or pigmented pretibial patches. This is one of the most common manifestations that a physician would be coming across as a skin manifestation in diabetes. Now, this is usually asymptomatic and it does not require much treatment besides the symptomatic control of itching if it is present. It is important to make the patient reassure that it is not something which is infective or something which is going to spread on to other family members. And pigmentation often persists in these cases and can be very resistant to treatment. Diabetic foot, this predominantly arises on the pressure areas because of diabetic neuropathy. It may present as a callus, it may present as an ulcer. The major treatment here would be ensuring a good metabolic control along with healing promoters, which could either be in the form of topicals, orals, or even platelet-rich plasma or PRF therapy. Eruptive xanthomas. Now, this is something which is seen commonly in triglyceridemia along with diabetes. So good metabolic and control of the lipid levels, cholesterol levels is required. These present predominantly on the trunk and the buttocks, and you would see a group of papulonodular lesions, which is reddish to yellowish in color. Coming to necrobiosis lipoidica diabeticorum, they present characteristically bilaterally symmetrical, and they present as reddish plaques. They can have ulceration in certain areas and can also present without ulceration with fine scaling. Treatment would be glycemic management, topical corticosteroids, and topical tacrolimus. This is diabetic scleroderma. Now, this is something which can often be mistaken for a cellulitis or even subcutaneous infection. Now, this predominantly would present symmetrically and in a diffuse pattern wherein you would see a reddish swelling and thickening of the skin predominantly involving the neck and the upper shoulder area. Sometimes it can even involve the hands where we have a characteristic namaste sign. The treatment here is not with any topicals or orals. It usually requires phototherapy, and if not treated, it itself will also resolve spontaneously within a span of around 6 months to 1 year. Now, these were cutaneous manifestations. Now, talking about cutaneous concurrences of diabetes mellitus, the first one is acrocordons. They present as dirty, warty looking papules or skin tag, commonly seen over a background of acanthosis nigricans. Again, the common areas would be your neck folds, your axilla, and even your groin folds. Treatment is not with any topical, but we need to remove them either by cautery or by radio frequency or even by a surgical CO2 laser. Finger pebbles, this is an extension of diabetic thick skin, wherein it involves the dorsum of the fingers. It is also called as the Huntley's papules. They're typically hypopigmented, and in certain areas, they can also conglomerate and form plaques. They're usually asymptomatic, and all that is required is a simple keratolytic agent with a good metabolic control. Pigmented purpuric dermatosis. Now, this is one condition which is a little difficult to see in the Indian skin type. It is commonly seen in skin type 1, 2, 3, which is the Caucasian race, and tends to present late in the elderlies over the shin bones. It is typically non-blanchable and can present with crusting and also scaling. Reassurance and topical emollients and antihistamines is all that is required. A lot of times it can be mistaken for a diabetic dermopathy, but usually a diabetic dermopathy wouldn't be this confluent and would present to be in a little brownish color. PPD is predominantly in the whiter races. Now, periungual telangiectasias, these present as reddish discoloration around the proximal nail folds. You would see these thread-like capillaries. They are almost asymptomatic always. Sometimes they can be associated with tender fingertips and with ragged cuticles, in which case you need to give them non-steroidal anti-inflammatory agents. Then coming to rubeosis faciae, again, one of the conditions which is not very commonly seen in the Indian races. It is commonly seen in the whiter skin type, wherein there would be flushing involving the cheeks and the chin and the nose area. One of the predominant triggers for this condition is caffeine and alcohol. So it should be avoided at all costs. And along with that, a good metabolic control and a good sun protection and emollients is all that is required. Now coming to infections, which is predominantly one of the most common manifestations that physicians would also be coming across. Talking about viral infections, we commonly see herpes zoster in diabetics to be much more fulminant than in the non-diabetics. It would present either in a bilateral form or a multidermatomal form, as opposed to a unidermatomal unilateral distribution in a non-diabetic. An important point to notice or consider here is that if you see a herpes zoster which is not following the usual norms, always screen them for diabetes and HbA1c. One of the newer developments in herpes zoster is that there is launch of a vaccine called as Shingrix, which can be given in 2 doses, 1 month apart, subcutaneously, above 60 years of age group for diabetics, and has shown to decrease the post-herpetic neuralgia predominantly very well, and also helps in an earlier healing if at all zoster is to happen. Fungal infections that we commonly come across in diabetics is Candidal balanoposthitis and dermatophytic infections, also called as Tinea cruris or the Tinea corporis, where it involves the body. I've often seen patients being prescribed by physicians fluconazole for it, and at a suboptimal dose and for a lesser duration. My sincere request would be to move to higher agents like itraconazole and to give a therapy as long as there is a complete clinical remission, and to continue it even beyond 2 weeks of that. And of course, to be given with topicals. Alone, just giving topicals in such infections often leads to resistance and an increase in the lesions, especially in the diabetics. Then coming to bacterial infections, we commonly see this axillary fold infection, which is called as erythrasma, caused by Corynebacterium bacteria. Then we see impetigo, and in severely diabetic hospital admissions and ICU patients, we often see this ecthyma, which is caused by Pseudomonas infections. Again, treatment with high IV antibiotics or oral antibiotics along with a good metabolic control and topical antibiotics is the treatment for these infections. Now moving on to diabetes mellitus associated with dermatological diseases. Now this is predominantly a dermatologist's domain. Now, these are autoimmune conditions, so you would expect them to be more commonly associated with type 1 diabetes, granuloma annulare. This presents as asymptomatic skin-colored lesions, wherein there's a central clearing, and some of them may even coalesce to form a plaque and can have broken circles. A lot of times, this is mistaken for a tinea or a fungal infection. The major difference being this is going to be asymptomatic, and a person with fungal infection is going to complain of severe itching. psoriasis vulgaris. It is a papillosquamous condition which presents as plaques studded with these silvery scales commonly over the extensors. They have something called as a Kobner's phenomena, wherein you see extension of these lesions along the sites of trauma. And also they have a seasonal variation, wherein winters are months where you commonly come across these. One major thing that is to be remembered is please do not prescribe any sort of oral steroids for these conditions, mistaking them for eczema, because that just leads to exacerbation of psoriasis and is completely contraindicated. Lichen planus, these presents as violaceous itchy papular lesions predominantly along the trauma prone sites, and also follow again the Kobner's phenomena. Then we have vitiligo, which presents as depigmented asymptomatic macules over the extensors and over the joints. One of the poor prognostic factors, if you come across this case and you can tell the patient is presence of this white hair, and it should require an urgent treatment to first stabilize the disease and then to work on the pigmentation abnormality. Now talking about the diabetic therapy induced cutaneous complications, the ones which are caused by oral hypoglycemics include generalized pruritus, urticaria, non-blanchable erythema, erythema minor, and then lichenoid drug rashes. What we see with the gliptins very commonly is bullous pemphigoid. So if a person is coming to you with bullous lesions, multiple lesions which does not look like a diabetic bulla and is an elderly and is on gliptins, make sure you rule out a bullous pemphigoid. Then insulin-induced lesions include lipoatrophy, wherein there would be dimpled skin-like depressions around the umbilicus. And this usually happens because of a single site of insulin injection. Similarly, lipohypertrophy, wherein you see these pendulous folds of skin along the sites of insulin injection. One of the ways you can prevent these conditions is by using a cyclical rotation of the insulin injections and using more skin and humanized forms of insulin. Now, these are the predictive indicators and the affirmative indicators that we have devised for diabetes. Predictive, when you come across these lesions, you should screen the patient for diabetes, candidial melanocystitis, diffuse alopecia, extensive dermatophytosis, fulminant zoster, and recurrent bacterial infections. And affirmative indicators, wherein if these are present, we for sure mostly know that the patient has an underlying diabetes, acanthosis nigricans, acquired perforating dermatosis, diabetic dermopathy, diabetic foot, and sclerodema. One of the studies we did in 2016 with Dr. Sanjay Kalra was on diabetes and melanocystitis. The review was basically to sensitize the diabetes care providers to take a history and perform a physical examination in any person who comes with penile symptoms, and also to encourage the dermatology care providers to screen for diabetes in such persons. Similarly, for zoster and diabetes, we had done a review wherein we found that herpes zoster makes a strong case for screening for diabetics in all patients and for using insulin to achieve optimal glycemic control in patients who have concomitant diabetes and zoster. So the takeaway points would be diabetic dermopathy is considered to be one of the most common dermatological manifestations. And there's a list of predictive and affirmative indicators that we should not ignore, wherein predictive is your majorly infections like candidial melanocystitis, herpes zoster, extensive tinea infections, and recurrent bacterial infections. Affirmative indicators would be acanthosis nigricans, acquired perforating dermatosis, diabetic dermopathy, diabetic foot, and sclerodema. Thank you.
Thank you, Asta. Dr. Asta, that was very, very crisp. She actually, it was a very comprehensive coverage, and she did it in very brief time. And actually, I really enjoyed it because it made many things clear to us as well, which we are struggling in our clinics in a day-to-day practice. Thank you so much, Dr. Asta. So now I would like to introduce Dr. Arvind. He's our next speaker. Can we have his slide, please? Yeah, so Dr. Arvind is, as you know, he again is a stalwart and does not need any introduction. He has been working in Mahavir Jaipuria Rajasthan Hospital, Jaipur, He's a senior consultant physician and head there. And he has fellowship, as we can see, of Fellowship of American College of Endocrinology, and lots of awards and orations to his name. So without wasting any further time, so I would like Dr. Arvind to start his discussion and talk further.
Thank you. Thank you, Dr. Hitesh, for the kind introduction. And at the outset, I thank Dr. Rajiv, who is here, Dr. Shalini, for putting me into this very important program conference. Thank you very much. Can I share my screen just now? Just yeah. Do share. See my slides. Are my slides visible?
Yes, sir, visible, visible.
Okay, okay. Thank you, Dr. Hitesh again. And after hearing a very elucidating talks of Dr. Samarda, Dr. Astha regarding the dermatological things, and now I'll be talking to you about the very important aspects of the patients coming to us with the snoring. They usually the attendants say about the snoring. Most of the time it is obstructive sleep apnea. So how it is related to insulin resistance, diabetes, cardiovascular disease, and dear friends, I can say right at the outset that don't ignore these obstructive sleep apnea or snoring in a diabetes patient, because it is, again, as Dr. Samarda said, that fatty liver is the sign for overall cardiovascular disease, is a multi-system disease. Similarly, OSA or snoring may be a sign, it is a sign of insulin resistance, and of course, it is related to diabetes and cardiovascular disease. These are my disclosures. Okay. So let us see what is the prevalence of obstructive sleep apnea in the country. It is the really most common of the most of the sleep disorders at present. And the prevalence may range from 8 to 19%, which is associated with the comorbidities regarding the diabetes and higher body mass index, overweight people, which is also increasingly prevalent in our country. I cannot remove, yeah. So let us see some of the definitions. We should not be confused with so many definitions regarding apnea. It is an airflow suggestion. More than 10 seconds is apnea. What is hypopnea? It is airflow which is reduced by 30 to 50% below baseline. OSA, which is the talk of the topic today, it is actually AHI. It is the apnea hypopnea index, which is very, very important. If it is more than 5, it is mild. 5 to 15 is moderate, and 16 to 30 and severe, it is more than 30. So this is a real obstructive sleep apnea. Sometimes there are certain positional OSA where the supine AHI is more than 2 times than the lateral AHI, and then it is known as positional OSA. CSA, it is absent respiratory effort, and likewise, we should not be confused. So we should be very, very clear that we are talking about today the obstructive sleep apnea. So what are the characteristics? I'm not going to detail about the OSA, but I'll be giving you the details of the connection between OSA, diabetes, and cardiovascular disease. What are the, for a brief thing, the event duration is more than 10 seconds, the airflow absent or less than 20% of the basal value, and it is a continuing effort through the event termination. And if I can say this, saturation, oxygen saturation is more than 3%, or if EEG arousal, this is again very, very important. When you go over the EEG and arousal, if you see there, definitely it is a OSA. So how it is connected? Insulin resistance, glucose intolerance, or it is a diabetes. Dear friends, there is a very close link between insulin resistance and OSA. How it is there? It is well-known fact that snoring and OSA are essentially seen in overweight and obese patients. We know all this. The recent investigations have shown the insulin resistance also linked to OSA, especially in patients with polycystic ovarian syndrome, elevated insulin levels, and impaired glucose tolerance. We have seen all the studies have shown the clear link between all this. So what is the pathogenesis? How this is all linked together? The simple pathogenesis of obstructive sleep apnea is the hyperventilation. So if it is a sleep transition from wakefulness to REM sleep, which is a rapid eye movement sleep, which is very, very important thing. If a person aroused from that, hypoventilation occurs, obstruction occurs, there is a brief duration of apnea or hypopnea, and then there is an increasing breathing effort of hypoxia and hypercapnia takes place. This leads to the arousal of the patient, and there is a hyperventilation, and then this is a vicious sort of cycle. So what was it in 2005 when it was presented in the Principles and Practice of Sleep Medicine that glucose intolerance or the insulin resistance is directly related to diabetes. Obesity is also related to obstructive sleep apnea and so it is a sort of a vicious cycle. So what is that vicious cycle? How the OSA, actually, if you see here, actually there is a multiple aspects of the causation of OSA linked to the inflammation and diabetes. If you see here, clearly either the CPAP or the sympathetic neuronal activation occurs. There is a HPA axis activation occurs because of the OSA. Sometimes there is an increased adipokines, and through the central respiratory control, what happens? It relates to the health-related behavior, causing more inflammatory cytokines, more inflammation, and we know that it may lead to diabetes or glucose intolerance. Dear friends, this is how the pathophysiological pathways link between OSA and diabetes. What are the typical symptoms? We all know about that. The cardinal symptoms are just a history of habitual snoring. That's why most of the patient or their attendants come with these type of complaints. A record of witness apneas, the excessive daytime sleepiness. This is a very, very common. The person comes to us and sometimes in front of us, they are drowsy. Fatigue, sleepiness during the day and loss of energy. They are all fatigued people. Irritability is there. The poor memory is there. The depression, mood changes are headaches. When the person wakes up in the morning and says that I had a severe headache in the morning. Sexual dysfunction is very, very common with the OSA people, the OSA, and of course the nocturia. So these are some of the cardinal symptoms and associated symptoms of the OSA. So how to deal with this? Does OSA have effect on glycemic control? Yes. Again, a published study and consensus statement is there. And these studies reports to us that people with diabetes, sleep duration and quality were affected, linked with glycemic control. Definitely, your uncontrolled diabetes occurs with the persons having regular OSA and snoring. How the sleep apnea and type 2 diabetes is related. This is very, very important thing. And if you see, this is again published in 2018 in Diabetes Investigations, the effect of OSA on type 2 diabetes. This is important thing here. The PF found was more than 3% ODI levels. And how it is there? If you see here, hazard ratio is around 0 to 1%. ODI level, if it is less than 5, if it is 5 to 15 and more than 15. That is the important thing about it. So proportion of excessively developed diabetes, if we say ODI level is less than 5, incident diabetes is around 117, 5 to 15, it is 68 and 25. I mean, the hazard ratio, I mean, the important thing is this, diabetes is associated with sleep-related manifestations. So this is very important thing. So once, don't ignore these type of things. OSA dynamically increases the nocturnal plasma fatty acids, glucose and cortisol. So this is also known, and this is also published in Journal of Clinical Endocrinology Metabolism in 2017, that OSA is associated with diabetes and cardiovascular disease, and the recurring exposure of these metabolic changes regularly may foster diabetes and cardiovascular disease. Dear friends, you see here very clear relationship. The OSA and CPAP here, and the people with OSA, the dark ones, if you see whether the glucose intolerance, whether it's insulin levels, whether it is the curve of the glucose, and all are definitely increased or intolerant when the person is having CPAP or without CPAP in the OSA. So what this study, very important study, concludes, this study clearly concludes that OSA increases overnight free fatty acids and glucose in association with sympathetic nervous system and HPA activation. And because of all these things, as a clinician, one should be aware of vulnerability of the OSA patients to metabolic dysfunction. That's the typical thing, the take-home message right at this point of time. And the cardiovascular effects are in short-term OSA exposure. So I think OSA is the very important marker for the cardiovascular disease and diabetes. And of course, we know that diabetes patients are particularly susceptible to nocturnal glucose elevation. How this sleep apnea, there are two types of effects. A person is having regular sleep apnea, non-cardiovascular effects, and the cardiovascular effects. What are the non-cardiovascular effects? There is an altered sleep pattern, cognitive impairment occurs in the person of life, and motor vehicle accidents. Very commonly we found these type of things with the non-cardiovascular events of sleep apnea. However, the cardiovascular effects are typically seen like hypertension, congestive heart failure, coronary artery disease, stroke, arrhythmias, pulmonary hypertension. We all see day and night of these type of effects of OSA. Dear friends, the prevalence of OSA in the patients of cardiovascular disease, if the person is having OSA, there is more 30 to 83% chances of hypertension, 12 to 53% chances of developing congestive heart failure, 40 to 90% more stroke, and 30 to 50% acute coronary syndrome. So that's why please do not ignore OSA or snoring patients when they come to us. So what are the components? The sleep, apnea leads to hypoxia, the pleural pressure increases, and hence the sympathetic activation occurs, patient aroused, hyperventilation occurs, the reoxygenation, the sleep disturbed. So this is a vicious cycle a patient goes into almost on a day-to-day basis. So what happens? What is the mechanism of OSA and of the CVD? The most important thing is the repeated hypoxemia, more hyperventilation leads to carbon dioxide retention. Consequent sympathetic activation occurs, marked blood pressure rises during the sleep, and this all leads to association between neural, humoral, vascular, inflammatory, and metabolic abnormalities related to OSA. Similarly, simultaneously, after the even cardiovascular exposure, autonomic nervous system also affected. Both parasympathetic vagal tone and decrease in the sympathetic nervous system manifested by lower heart rate, blood pressure, systemic vascular resistance, stroke volume, and leading to cardio output. So this is a typical apnea hyperpnea cycle of the OSA, which disrupts this all balance, leads to more cardiovascular disease. Not only this, inflammation occurs. Thus, repeated again hypoxemia, stress may also play a role in activation of systemic inflammatory pathways. Most of the inflammatory cytokines increases, and in fact, most of the OSA patients have increased levels of plasma cytokines, adhesion molecules. Very importantly, they also lead to some of the very severe atherosclerotic cardiovascular disease. Serum amyloid A and C reactive protein, which is again an inflammatory marker, increases with the people with OSA. And that's the reason the C reactive protein is increased in moderate to severe sleep apnea patients, clearly depicted here, this inflammatory marker, the CRP. And this whole gamut, which we have seen, whether the free fatty acids, whether the inflammatory markers, they all lead to endothelial dysfunction. So these increased oxidative stress and systemic inflammation together with reduced nitric oxide availability and cell apoptosis might contribute to the endothelial dysfunction. This is the primary mechanism of OSA, leads to cardiovascular disease and endothelial dysfunction. And this is very well depicted here, how OSA leads to dyslipidemia, insulin resistance, high blood pressure, and ultimately increases with the reactive oxygen species. What it does, arterial lumen gradually and chronically constricted, the arterial intima media thickness increases, and it leads to progression of severe atherosclerosis. Atherosclerosis leads to myocardial infarction and stroke. What are the acute causes of hypertension in obstructive sleep apnea, which is very, very common here? A person is having obstructive sleep apnea with obesity, increases the sympathetic activity, inflammation, oxidative stress, and reduces the baroreflex. This is again very important. This all leads to more blood pressure, more hypertension. Patients with OSA are basically non-dippers. We know that diabetes per se causes non-dipping of the blood pressure in the night. And if the person is having above and over the diabetes and OSA, then the non-dipping is deepened out. And it is clearly shown here the increased risk of CVA, end organ damage, and worse prognosis once the patient is having diabetes, insulin resistance, obesity, and OSA. So to summarize my talk here, which is a very brief thing, is that I told you right at the beginning, please do not ignore snoring or OSA in the diabetes patients or obese patients. It is maybe a marker of that. The growing evidence clearly suggests the strong link between OSA and markers of glucose metabolism, insulin resistance, and cardiovascular disease. All clinicians, including those in Asian, should be aware of this clinical relevance of OSA and diabetes. And dear friends, increasing evidence definitely suggests that the patients with type 2 diabetes and severe OSA who are highly adherent to CPAP therapy here may have a greater likelihood of deriving metabolic benefit. Here, I have not shown few of the studies because of the time constraints, but CPAP, I have got several studies which clearly say that if you apply CPAP very early, CPAP or BiPAP very early in the OSA patients, you can be benefited not only the patient's quality of life, but also the glycemic control, less atherosclerosis, less inflammation if you apply CPAP right at the beginning when you see these type of patients. So dear friends, my take-home message very clear here. Prevalence of OSA is likely to increase partly because of the epidemic obesity. Obesity is increasing like anything. Similarly, the OSA and all the signs and symptoms of obesity will be increasing. there is a definite interaction between sleep apnea and established cardiovascular disease. There are multiple pathophysiological effects of cardiovascular significance demonstrated in the different studies. I have shown you a few studies. Patients who are tested and treated treated with CPAP especially, had a significant better 2-year survival than those who are not tested and not treated. So please diagnose these patients and manage then and there. Don't wait for the things. Dear friends, my total here, my message here is to all of you, the better awareness, including us, high prevalence of undiagnosed and diagnosed but untreated OSA. It is likely role on CVD incidence and outcomes. Definitely the OSA management benefits not only the quality of patients, but reducing the cardiovascular outcome of the patients. Thank you very much for the patience listening. I am here for the question and answer.
Thank you so much, sir. We had very interesting 3 talks back to back, and they were all very spectacular in their own sense. So let me. So we have Dr. Rose. So let me put my first question to Dr. Sarma Banerjee. Sir, if a patient comes to us in a clinical practice and you do the 5-4 score, which is very easy to do with the online calculators or apps, and score is somewhere between indeterminate, that is between 1.3 to 2.6. So what's your next line of action? Do you refer these patients for enhanced liver fibrosis panel test, or you do the fibroscan? What's actually the your line of action in patients with the indeterminate score?
The recommendation is you just observe the patient and between 1.3 to 2.7, you do one fibroscan. Because if fibroscan is positive, then you will have to think for the treatment. It may so happen that FIB-4 score is not that high, but there may be hepatic fibrosis that you will have to stop. So you must do one at least fibroscan before other tests you do.
All right. So
can I have Hitesh? Can I have one question to Dr. Samartha, and especially I wanted to ask you also at that time. If patient is coming with the ultrasonography with the fatty liver, which is very common. If you go over the ultrasonography fatty liver, patient comes with a report of fatty liver. Now, can we go with the all the imaging to diagnose properly, or this is sufficient to manage? Because we know that management is very, very important for fatty liver. Here, just simply ultrasonography.
No, my opinion is fatty liver does not mean anything. If the fat is within the hepatocyte, it is not producing damage. Next step is the cellular infiltration. Next stage is the elevation of the enzyme. Next fibrosis. Finally, malignancy. So all fatty liver, if comes, you will do one test for the liver function test, and you do one platelet count, go for FIB-4 scoring. Depending upon the FIB-4 scoring, you decide whether you will go for the scans, etc. or not.
Yes. I think the point is that because it's not the steatosis which is important, it's the fibrosis which is important. And FIB-4 score is basically more indicative of fibrosis than the fatty liver. So even if you have grade 2 fatty liver, as they mention in many patients, and you do the FIB-4 score, it might come out to be less than 1.3 in few of those cases. So basically, because it shows steatosis, and then we are looking for fibrogenesis, that is actually the main difference. As sir has put it, that is something which is more relevant in that. So,
Arvind, can I ask you one question?
Yes, sir. Yes, sir. Sir, not difficult question.
No, very witty question. I don't know any difficult question. The question is, in my practice, I have seen that snoring is detected by partners. It is not complained by the patient. So your advice to prevent OSA, should all diabetic marry? So that the partner can complain that his husband or his wife is snoring, and sometimes children, they raises their parents that you get up, you go out from the bed, you are disturbing my sleep. So whether
I'll answer you one of the
marry for early detection of OSA, yes or no?
Sir, I answer you one of my patient. He is the sitting High Court Justice. He was living in a big bungalow. उसको एक ऊपर कमरा दे दिया था पूरी फैमिली में. Sitting High Court Justice, living in a single room somewhere alone there because of that snoring and all these things. So this is what I have seen in a very common thing कि उसको अलग कर देते हैं पूरे घर से because he is disturbing all of them. I put him on CPAP at that time and now he is living with his family. That is the only answer I can give.
So another complication of OSA is marital separation. This has happened. These are reported also.
Yes. I think Dr. Rajiv Chawla and Dr. Shalini has put very specifically this. When the topic came to me, it is really, I know that one should not ignore. Every physician must be aware of this particular aspect, the OSA link with CVD and diabetes.
And the role model is Shalini. You do not know how much body weight he has reduced. I'm not going to ask whether he had OSA or not, but he has become so young. I'm very afraid how much age I will call for her, 20, 25 or less. I don't know. But one thing I routinely ask a patient when it comes to us, whether there is any sleep disturbance, particularly snoring reported by other members, or if you feel daytime sleepy or not. And
Yeah,
this is a very neglected part, very neglected part.
Yeah, exactly. On a serious note, this is a very, very important aspect of management of diabetes.
Any specific anti-diabetic for that purpose?
No, I don't think so. Because
GLP-1
the only thing with the GLP-1, SGLT2 and GLP-1 receptor agonist, which can actually have the good role on weight reduction, and the weight reduction clearly will be depicted for the less OSA, definitely.
Now, there are some reports that intra-abdominal fat, intra-oral fat is also minimized with GLP-1 SGLT inhibitor.
Yes.
In that case, ARA becomes clearer rather.
Yeah. So semaglutide, and now some studies are already there.
Yes. And what about the lean OSA people? I have got some patients who are not that obese, ideal body weight or lean, but having snoring.
Snoring, I think, maybe some of the local problem in those lean people. It is something related to something glottis or something, which I don't know.
Nasopharyngeal obstruction.
Yes, it is the pharyngeal. It is not the metabolic
Okay.
aberrations.
So I think Dr. Madhusmita, any questions?
Madhu is not here.
She's not around, I think. So
We still have about 5 to 6 minutes, so we
Dr.
can probably have some more discussion before we start the next
My
symposium.
question is to Dr. Astha.
Yeah.
yes,
Hello.
ma'am. Yes,
Yeah.
ma'am.
Dr. Astha, when the patient comes with acanthosis nigricans,
Hmm.
so how should we manage the patient? Because a
Okay,
lot of patients come, obese patients, and we have to explain to them that it is a complication of diabetes. But what can we do to alleviate her stress?
Okay, correct. So first you need to make the patient understand that before any cutaneous treatment works, metabolic control is absolutely essential. So control the weight, control the sugars, make sure the fasting insulin is fine. After that, when we talk about the cutaneous treatment of acanthosis nigricans, the first aspect is keratolytic, since we know it's a velvety hyperpigmentation. So the velvety aspect needs to go first. For that, we use keratolytics, predominantly retinols in a very low concentration, like a tretinoin 0.025%, that too mixed with an emollient. Why? Because most of these acanthosis sites are usually folds. So if you're giving something as irritant as as a topical vitamin A derivative, you cannot give it just alone. It needs to be mixed with a emollient or a moisturizer that can be given almost alternate. Now coming to the pigmentary aspect of acanthosis nigricans, that can easily be managed by daily application of a combination of glycolic acid 6% along with lactic acid and a few other skin brighteners. However, we can also tell them that in case this acanthosis nigricans is involving the face along with the keratolytic and the depigmenting. Sun can be a major deterrent to the treatment. So a sunscreen protection in the morning is also extremely essential. What I have come across in my practice is most of these acanthosis nigricans patient by default also have some sort of underlying, dryness in the skin. So I also orally prescribe them ceramides and ceramosides, which really helps them with correction of the dryness as well as the pigmentation and the thickness aspect of acanthosis.
Astha, can I have one question?
Yes, sure, sir.
I have got recently one patient. He's a doctor. He's the nephrologist. And he is having dermopathy, what you have shown just now.
Diabetic dermopathy
for last 6 months. It is really, he is so depressed, he is so stressed that he has consulted almost every dermatologist here. And as you have shown that reassurance, how can we reassure a nephrologist of having diabetic dermopathy?
So if the diabetic dermopathy is symptomatic, as in if there is some sort
Only
of
itching.
Oh yeah, so itching and burning that is usually associated with diabetic dermopathy can easily be taken care by application of topical corticosteroids and emollients along with a sedative antihistamine at night and a non-sedative antihistamine in the morning. As far as the pigmentary aspect of it is concerned, you need to tell them that this is not something which is going to show an immediate effect. Once the itching has been controlled and once the anti-inflammatory steroids have been given and the activity of the disease has gone down, then perhaps after a month or 6 weeks or 8 weeks, we can also start them on a depigmenting therapy. But that pigmentation is not going to get corrected by 100%. A residual 20 to 30% pigmentation will remain, which will also depend upon what is their base skin type. If there is somebody who's really fair, we can tell them an improvement of 70 to 80% can happen. If somebody who's darker, then the pigmentation is automatically much more resistant. So then at least 50% of the pigmentation will remain and the rest 50% will also get corrected over a span of around 6 to 8 months.
And why I am asking here is because his endocrinologist actually initially he was very well controlled. His HbA1c was around 6.1 or so, but he was on DPP4 inhibitors. Most of the endocrinologists thought that it is the because of the DPP4 inhibitors that was stopped. He became uncontrolled diabetes, and now he's put on SGLT2 inhibitor. He lost the weight. Now he's depressed again. So I mean, DPP4 inhibitors.
DPP4 inhibitors per se do not cause any form of
depression first. I think that will solve all the problems.
That's true. It's a vicious cycle which he's entrapped in, but DPP4 per se themselves do not induce any diabetic dermopathy. What they have been shown to be associated with in majority of the cases is bullous pemphigoid followed by more blistering condition and lichenoid rashes. Dermopathy is purely because of a long-standing diabetes, which also affects only the shin. You can reassure them that it is not going to spread beyond the shins or to any other areas of the body. Once the itching is controlled, yes, the pigmentation, if he's extremely bothersome, can also be managed by lasers to a great extent. We do come across such females who are, cosmetically conscious about the pigmentation that dermopathy leaves behind. So that can be managed with lasers then.
Yeah. So I think reassurance, you have already mentioned about that.
Yeah.
So thank you so much.
I want to know from you regarding the scalp hair loss in diabetes, very frequently reported. Hair loss.
Hair loss.
In the scalp.
So hair loss is something which, if we talk about autoimmune diseases, the first disease that it is associated with is hypothyroidism. The next is diabetes. Now, why it happens is because diabetes is inducing a stressful state in the body. Hair being the most non-essential organ in the body is something which is going to show the first response. So hair fall is something which will happen in a patient who has uncontrolled diabetes or also has an associated hypothyroidism. The treatment in these cases is a little frustrating because of the length for which we need to give these treatment. We usually supplement them with oral amino acids and combination of biotin and borage oil, along with a few growth peptides which are given for topical application. That does take care of the hair, but ultimately if it is arising from diabetes only, then a glycemic control is very, very important. Because if we stop the patient of these medicines, again, after 2 months, they're going to complain of the hair fall. So once this is under check, the oral and topicals will help.
I'm sorry, but we need to wind up.
Zinc supplement.
Zinc supplement is very good, not that much for hair, but for bacterial infections and other eczematous conditions of the skin, zinc works really well, especially in dry skin individuals.
Right.
Thank you so much. So I think we've just had some very stimulating discussion, and I wish I could allow it further, but I'm sorry, we really need to stick to time because we have a lot of international speakers from different time zones who are joining us. So my thanks to all the speakers and the chairs, Dr. Arvind Gupta sir, Dr. Astha Chawla, Dr. Samar Banerjee sir, and my chairs, Dr. Hitesh and Dr. Madhusmita, for that very, very enlightening session. Thank you so much.
Thank you.
Thank you. So now we move on to another very, very important symposium, and this is something which is very, very close to my heart as well. The diabetes and pregnancy, gestational diabetes. And DIPSI is a partner with us. We've all been associated with DIPSI, trying to take the cause of gestational diabetes mellitus awareness, prevention, management forward. And it's an honor to chair this session with Dr. Bijay Patni, consultant physician and cardiodiabetologist, HOD Diabetes Wellness Clinic, Kolkata. He will be joining us very soon. So without much ado, let me start this very, very important symposium. And I can see Dr. Balaji sir, Bhavtarini ma'am, everybody is logged in. So welcome all of you, my DIPSI team, my DIPSI family. Dr. Bhavtarini is Honorary Professor Diabetology, State Coordinator of IMA Diabetes Course. IMA National has won the IMA National and State Award for Academic Contributions, Governing Council member of RSSDI and DIPSI. She is also faculty at MGR Medical University, lot of work in diabetes and pregnancy, and my go-to person when I have a doubt in what to do and how to manage. She's Joint Secretary DIPSI as well as Tamil Nadu RSSDI, and she's a reviewer for IJDDC, organizing chairman for Track 28, and very, very much into academics and grossly engrossed into DIPSI and GDM. Bhavtarini ma'am is going to talk to us on pathogenesis of GDM. Welcome, ma'am.
Thank you. Thank you.
Welcome, madam.
Good evening, sir.
Please click here to join us and put on the link.
Immense thanks to Dr. Rajiv Chawla and Shan, who laid the seed in the soil of India about the importance of GDM, and with which all are flourishing. And coming to the pathogenesis of GDM, a new structure arises de novo during pregnancy, develops and matures till it is expelled at the completion of the gestational period. This time there occurs metabolic adaptations in feto-placental maternal unit. If you take the fuel metabolism in normal pregnancy, it's characterized by facilitated insulin action during the first half of pregnancy and diabetogenic stress in the second half of pregnancy. And first we'll see what happens in the first 20 weeks. It's all about facilitated anabolism. You know, in pregnancy, there occurs increase in estrogen followed by progesterone, which is compensating. There occurs along with that compensatory beta cell hyperplasia and increased insulin secretion. This brings about increased tissue glycogen stores and decreases the hepatic glucose production and improves the peripheral utilization of glucose, and net result, it brings down the fasting plasma glucose. So overall, we have the metabolic changes, anabolic, due to the estrogen and progesterone increase and also hyperinsulinemia. Hernandez has studied the pattern of glycemia in normal pregnancy, and he has told that fasting is always less than non-diabetic, diabetes, it is less, pregnancy, it is less than normalcy. Why this reduction 10% in fasting occurs during pregnancy? It's because of the net effect of anabolic changes, and due to the increase in plasma volume, there is dilution in early gestation, and there is increase in feto-placental And again, there is a fall in the amino acid alanine, which is needed for gluconeogenesis. So there is substrate deficiency syndrome. All these put together reduces the fasting by 10% compared to the non-pregnant state. You know, in every normal pregnancy, we have elaboration of estrogen followed by progesterone, then the human placental lactogen. All these are diabetogenic counter hormones to insulin, but still every pregnant woman do not develop gestational diabetes by the over secretion of insulin during pregnancy, which put down the effect of all these hormones. For example, if you want to maintain the blood sugar in non-pregnant to maintain this level, they need this much of insulin, that's adequate. But in pregnancy, it has to increase further to this much, from 80 to 180 to maintain blood sugar at this level. We'll go to the later weeks, that is beyond 20 weeks. Again, there are hormonal challenges like increased human placental lactogen with increased prolactin and increased bound and free cortisol, causing more insulin resistance and diabetogenic stress, decreasing the glucose tolerance, increasing the insulin resistance, and decreasing the hepatic glycogen stores, and increasing the hepatic glucose production. So the net result is we have facilitated anabolism during feeding, which ensures adequate glucose and amino acids to the fetus, and catabolism during fasting, that is accelerated starvation during fasting. You see, to maintain the glucose, when you give a mixed meal, the glucose and a variety of substrates act in a coordinated manner to regulate the insulin and glucagon secretion. To maintain the glucose in normalcy, there non-pregnant insulin is secreted and glucagon is suppressed. In pregnancy, there is extra insulin secreted. This extra insulin secreted in response to meal blunts the gluconeogenic potential of glucagon. And immediate postprandial hyperglycemia, and so spares the ingested amino acid for the fetal access. And after the disposal of this carbohydrate, the responsiveness of the alpha cell to the persistent hypoaminoacidemia could stimulate enough gluconeogenesis to prevent reactive hypo in the mother. There is facilitated anabolism in the fed state because of the perturbations that are observed in normal pregnancy, which are just adaptations to ensure adequate delivery of nutrient to the fetus. Insulin resistance physiologically plays a key role here, bringing about changes in carbohydrate, lipid, and amino acid metabolism that facilitates anabolism. And there is accelerated starvation in the fasted state. The maternal metabolism shifts rapidly to catabolism when exogenous fuel is not available, using fat as the sole fuel source. And here the placental hormones help in the metabolic shift by producing ketogenesis, a state of accelerated starvation. So the metabolic changes, which should normally occur after 72 hours of food deprivation in a non-pregnant state, occurs within 18 hours during pregnancy. So in the fasting state, what happens? There is persistent removal of glucose and amino acids to the fetus, and the hormones of pregnancy, particularly the superfemale placental elaboration, causes diversion to fat metabolism in the mother to spare the glucose and amino acids to the fetus with accelerated starvation. If you take the hormonal balance, the insulin increases during the fed state and decreases during fasting, and the glucagon remains the same. To sum up, in the fed state, the enhanced beta cell response, that is extra insulin to glucose, leads to facilitated anabolism from mixed meals, and in the fasting state, the preserved alpha cell response, glucagon, promotes glycogenolysis and gluconeogenesis from liver and adipose tissue to maintain euglycemia. So in the fasted fed state, what happens? From the mixed meal, the glucose goes straight to the main two organs, that is the fetus and the brain. Then the excess glucose goes to the liver and stored as glycogen. Again, in the skeletal muscle, it is stored as glycogen. And in the adipose tissue, of course, as triglyceride. Then the free fatty acids from the mixed meal goes to the liver as well as the adipose tissue. And this free fatty acid again gets converted in the liver to triglyceride and goes to the adipose tissue. All are stored. Mainly, first it is packed to the brain and fetus. What happens in the fasting states? There's no fuel. There occurs lipolysis during starvation, supplying free fatty acids to the peripheral tissues, and liver takes up the free fatty acids and forms ketone bodies and again supplies further, whereas amino acids are released from the muscle for the gluconeogenesis to produce glucose to supply the fetus and the brain. This is what happened in the fasting state. So the fetus is continuously fed by a mother who is an intermittently heating host. And the placenta is a temporary endocrine organ which is specially formed only during pregnancy. And pregnancy is considered as a tissue culture experiment, implementing that placenta and fetus develop in an incubation medium that is totally derived from the maternal fuels, consisting of glucose, amino acids, and lipids. So the glucose, amino acids, the ketones, everything crosses the placenta and enters the fetal site. Triglyceride gets converted to fatty acids and enters the placenta, whereas insulin and glucagon cannot cross the placenta. The placental glucose transport is dependent on the glucose transporter, the GLUT family. And here, the glucose transporter, one is the principal transporter, which is located in the syncytial trophoblast. The fetus takes both glucose and amino acids from the maternal circulation. Glucose is taken by facilitated diffusion. Amino acids are actively transported across the concentration gradient from the mother to both the fetus and the placenta via energy requiring amino acid transporters. Coming to the etiopathogenesis of GDM, first, the genetic factors plays a role, but the relative importance of genetic factors has not yet been established. But the increasing maternal age and obesity are very significant in contributing and compounding factors. Coming to the gestational factors, if you see the islet secretion in non-pregnant women and pregnant women, in the non-pregnant, the insulin secretion is according to the insulin resistance, both are equal and there is no diabetogenic stress. Whereas in pregnancy, we have the placental hormones, which increases the insulin resistance, and the women who are fit, their insulin secretion is adequate to overcome the stress, and there is no glucose intolerance. Both are equal. This extra insulin compensates for the 60% reduction in the responsiveness of peripheral tissues to insulin action. The basal and glucose stimulated insulin release is enhanced during pregnancy. Here you see, to maintain this normal glucose level, normal pregnant women, this amount of insulin is secreted. If you see in GDM, the significantly lower insulin response occurs at 30 and 60 minutes after oral glucose compared with the glucose tolerant controls. You can see in this picture clearly. And due to this, as the pregnancy progresses, the time to reach the maximum glucose concentration increases. And the first problem which occurs in GDM is the loss of first phase insulin response. You can see before pregnancy, which is normal, as the after conception, it comes down. The first phase insulin response comes down further and further, and it progresses further in the later weeks compared to the normal. You can see in this. Then in normal pregnancy, of course, there is insulin resistance due to the diabetogenic stress caused by the placental hormones, but there is adequate insulin secretion by the pancreas, and it compensates, and net result is blood sugar is maintained normal. What happens in gestational diabetes? There is insulin resistance, but there is not adequate insulin secretion to meet this insulin resistance, so the glucose level goes up. The glucose intolerance that develops in women with GDM could be the result of their inability to increase the insulin secretion enough to overcome the insulin resistance, that occurs even in non-diabetic pregnancy. See, again, the insulin sensitivity also goes down. In these women, already they are not fit. They may be obese or they are genetically prone. So what happens? Their insulin sensitivity is less even before pregnancy. And after conception, again, it goes down further. The sensitivity comes down compared to the normal. Where is the site of insulin resistance? Of course, this is a post-receptor defect in the insulin signaling cascade. Insulin receptor substrate 1 expression is decreased in all pregnant women compared to the non-pregnant controls. And the factors affecting this insulin receptor substrate 1 function in the signaling cascade is mainly due to the cytokine tumor necrosis factor and other adipokines. So pregnancy induces a progressive change in the maternal carbohydrate metabolism. As pregnancy advances, the insulin resistance and diabetogenic stress due to the placental hormones necessitate compensatory increase in insulin secretion. Here you can clearly see, to maintain normalcy, what happens? The insulin level, which is 12.3 initially, increases up to 27.0. That is, progressive increase in insulin elaboration enables the blood sugar to be maintained following glucose load. Where this compensation is inadequate, gestational diabetes occurs. So to summarize, pregnancy is normally attended by progressive insulin resistance that begins near mid-pregnancy and progresses through the 3rd trimester to levels that approximate the insulin resistance seen in individuals with type 2 diabetes. The insulin resistance appears to result from combination of increased maternal adiposity and the insulin desensitizing effect of the hormonal products of the placenta. How we know this? The fact that insulin resistance rapidly abates following delivery suggests that the major contribution to this state of resistance are the placental hormones. The pancreatic beta cells normally increases their insulin secretion to compensate for the insulin resistance of pregnancy. As a result, changes in circulating glucose levels over the course of pregnancy are quite small compared with the large changes in insulin sensitivity. Robust plasticity of the beta cell function in the face of progressive insulin resistance is the hallmark of normal glucose regulation during pregnancy. So to conclude, the metabolic adaptations that occur during pregnancy ought to accommodate the rapidly growing tissue transplant, the conceptus. For its own normal growth and development, the conceptus brings about alterations in the maternal fuel, metabolism, and hormones. The placenta facilitates embryogenesis, growth, maturation, and survival of the fetus. It has the capacity to synthesize steroid and peptide hormones and to modulate and transport metabolic fuels to the fetus. So the maternal hyperglycemia with relative hypoinsulinemia and fetal hyperinsulinemia as a result of this maternal hyperglycemia are the kingpins of pregnancy metabolism. This differs a little in GDM type 1 and type 2. In GDM, in the non-pregnant state, the beta cell function is totally normal. In pregnancy, insulin resistance of the placental hormones leads to relative insulin deficiency occurs, but postpartum, there is a greater chances of remission with the delivery of the placenta and its diabetogenic stress. If you see in type 1, they are insulinopenic, but insulin sensitive before pregnancy. Inherent ketosis is prone, but in pregnancy, the insulin resistance increases further. So they need 1.5 to 3-fold increased insulin. And they easily go for accelerated catabolism, develop DKA more rapidly, even at normal blood glucose levels. And when you give IV retardant, the beta agonist, that time they easily go into DKA. In type 2 diabetes, the insulin resistance with the relative insulin deficiency is present even in non-pregnant state itself. With pregnancy, the insulin resistance increases further. So there is an increase in insulin requirement than even the type 1 diabetics. There again, there is accelerated catabolism. They are prone for fasting ketosis. And this leads to cognitive dysfunctions in the children. And for obese type 2 diabetes, it's reasonable to go for hypocaloric diet. Thank you. Shalini, you have to unmute.
Thank you so much, ma'am. You have so beautifully set the context for what we are going to discuss, the pathogenesis of GDM, that all of us need to understand before we actually deal with the problem. So I'll request you to stay back for the discussion, which we will have at the end of the symposium. And now it's an honor and pleasure to invite Professor Dr. V. Balaji, who is the person in DIPSI, the Secretary General. He is, just to introduce to everybody, you can see all his achievements. He has all the 3 FRCPs, Fellowship in Diabetes from Sweden. He is Chairman and Managing Director and Senior Consultant Diabetologist at Dr. V. Balaji, Dr. Seshia Diabetes Care and Research Institute. He sits on the expert group committee on GDM, Ministry of Health, Government of India, and the ICMR, and also has been awarded a number of very, very prestigious orations both in India and internationally, and is the Indian representative to the IADPSG. Welcome, sir. It's a pleasure and honor to have you. And sir is going to talk on the diagnosis and targets of control in pregnancy.
Welcome, Professor Balaji.
Thank you, sir. Thank you for the kind introduction. At the outset, I'd like to thank you and Dr. Shalini for this invite to be with this august audience. So my topic today, yeah, the diagnosis and targets of control. I think I'm audible.
Yes, sir.
Yeah, okay. So let me come on to the diagnosis and targets of control in pregnancy. So gestational diabetes, as everybody knows, any glucose intolerance with onset during pregnancy. Now it's got multiple names based on whether you recognize early or late as hyperglycemia in pregnancy, HIP, and so on and so forth. But the concern being it represents a chronic beta cell dysfunction, and it's a stage in the evolution of type 2 diabetes. And it may play a crucial role in increasing prevalence of diabetes and obesity. When we talk about ethnicity, Indian women have 11-fold increase of developing glucose tolerance during pregnancy compared to Caucasians. And among ethnic groups, South Indian women has the highest frequency. So have now advocated universal screening. You can see on the screen the IADPSG and the other task force, and they all advise universal screening. Early screening, again, so in spite of reports between 40 and 66% of GDM early pregnancy, there have been conflicting studies on the usefulness. But some of these women may represent a high risk of subgroup within GDM, especially if we take our ethnicity, the Asians. What happens? So this is a study from Japan where you can see they picked up the 100% first trimester 63 and second trimester 36%. This finding suggests the importance of screening for glucose tolerance as early as possible. So why the implications? Why do we have to screen? Does severe macrosomia manifest as 11 to 14 weeks of gestation? Yes, severe macrosomia manifests as early as 11 to 14 weeks. Why? If you see the pathophysiology, each islet cell functions as an endocrine organ, and it differentiates at 10 and 11th weeks of gestation. And it can recognize and respond to maternal glycemia at 11th week itself. So doing things late may not give you a good result. So this is what happens. The fetuses are exposed to increased amniotic fluid glucose before 15 weeks, suggesting that metabolic alterations are underway before diagnosis. An earlier screening and intervention may be warranted. So any data on that? Yes, we have data on Indian data. If you see GDM manifests on all trimesters of pregnancy, it's a study which we all did out of 4,000 and odd pregnant women. You can see the difference weeks of gestation. You can see bars, at yellow bars 22, and you have the green bar 24. And ultimately, to cut the long story short, this is what I want you to know from this slide. 38% of GDM women were diagnosed before the recommended weeks of screening. And this is what even the WHO endorses. Testing for early trimester is recommended, especially in high ethnic populations. And there's also another study which we published, and you can see here the different trimester. Here also almost 1/3 of all GDM cases were diagnosed during the first trimester itself. It tells you the importance of early screening. And some of the studies abroad have also shown that early glucose screening could avoid some diabetic related complications in women with gestational diabetes. It can prevent with women with later screening were likely to have hydramnios, preterm deliveries, premature rupture of membranes, and fetal anomalies. So early screening may be warranted. So early metabolic imprinting may affect the fetal growth, and human studies have shown that increase in beta cell mass and insulin secretion in the fetus in poorly controlled diabetic women by as early as 16th week of gestation, and increases throughout the second trimester until 26 weeks of gestation. And the priming of beta cell mass in mid-gestation may account for the persistence of fetal hyperglycemia throughout pregnancy and the risk of accelerated fetal growth even when mother enjoys good metabolic growth later pregnancy. Once you prime the beta cells in the fetus, it goes on in an autologous fashion, and it's very difficult to control it later. So the implication being early metabolic imprinting may affect the fetal growth. So this is a study we see whether it's true. This is a study which we did at a center. You can see here that the pregnant women were divided into two groups. Being a referral center, our percentages are very high. You have group 1 detected between 0 to 23 weeks of gestation, and group 2 detected beyond 24 weeks of gestation. And when they've all treated outcome birth weights, when they're treated for the same cutoffs with the same HbA1c levels, you can see the normal glucose tolerant women had the same level as normal glucose tolerant women. GDM were picked up early, whereas people who are picked up late, even though the treatment was the same, they had higher birth weights. So this is exactly what we say. Though we pick them early and treat them, definitely you get a better outcome. When we talk about repeat screening, you don't screen them once and leave them. And we found in the repeated screening, women with OGTT in the first visit, when they're screened with subsequent visits, 28% of women were just diagnosed to have GDM on repeat screening. So now we go on to the DIPSI criteria for diagnosis and guidelines. And this is exactly what the DIPSI criteria says: a 2-hour plasma glucose of 140 with 75 gram oral administered in pregnant women in the fasting or non-fasting state without regarding of the last meal, able to identify women with gestational diabetes. This is a single test procedure, and this is the DIPSI criteria. So what is the rationale for the test? After a meal, a normal glucose tolerant women would be able to maintain euglycemia or normoglycemia despite glucose challenge because of the brisk and adequate insulin response. Whereas women in GDM who had impaired insulin secretion, you heard about the pathogenesis in the last speaker, where they talked about increased insulin secretion, insulin resistance. When the insulin secretion is not able to match the insulin resistance, then you develop gestational diabetes, whereas a normal person will be able to match the increased insulin resistance with increased insulin secretion, which may go up to 70 times, 60 to 70 times normal. And this is what happens in normal people, so the levels are normal. Whereas the women in GDM who have impaired insulin secretion, a glycemic level increases with the meal, and glucose challenge, the glycemic exertion exaggerates further. So this exactly performing the single test procedure in the fasting or non-fasting state, irrespective of the last meal timing, is rational, as glucose concentration and glucose tolerance test will be affected least by the timing since the last meal in normal women, but will be affected in gestational diabetes. And this walk-in test is recommended in Diabetes as Pregnancy Study Group, India. Now, when we talk about any criteria, we need some validation to say that the outcome or the numbers are correct or whatever it is. So let's see validation, what happens here when we talk about digest GDM in gestational women, normal glucose tolerant women you see in the green bars, and you see the GDM women in the red bars after intervention. So what you see here is after intervention, there was no difference between the GDM and the normal glucose women. So normal gestational women, this shows after intervention, when you intervene, you find when you do the DIPSI criteria, pick them at 140 and treat them targets, I'll come to it later, and you find there is no difference. It shows DIPSI criteria definitely is valid. The advantages being the procedure requires one blood sample at 2 hours at 75-gram glucose load for estimation of plasma glucose. Even the test is repeated at each trimester, is 66% less than the cost of performing the IAD-PHT, which is 3 tests. Thus, DIPSI procedure is feasible, sustainable, cost-effective, and high impact, best buy for lesser resources setting. So this is exactly what we say, diagnosis and treatment at DIPSI criteria, decrease macrosomia rate, fewer emergency section, reduces serious perinatal morbidity, improve women's health-related quality of life. So the State Health Society, based on the DIPSI studies done by Professor Visesha, the State Health Society operation guidelines, all done at weeks of pregnancy, first screening 12 to 16 weeks, second screening 24 to 28 weeks, third screening at 32 to 34 weeks. And the National Rural Health Mission have taken up into the 5-year plan and to one step for universal screening during pregnancy, supply of glucometers to all sub-centers. One-step test is feasible and it is done. And now recently, it's also a task force has been formed. So also it is not only the point of not only using glucometers, now the point of care testing is also done where we have used glucometers, and a glucometer standardized for measuring plasma glucose has already been accepted. The WHO also recommends places where you do not have proper blood testing equipments, you can use this. So WHO observations in 2013, this is what says many health services do not test hyperglycemia for pregnancy. Consequently, a non-fasting test may be the practical approach. And WHO recommendation, single-step procedure to diagnose GDM wherever it is feasible. And the strategies and what they have mentioned here is diabetes and pregnancy study group guidelines to be validated for the future. And the FIGO and the other organizations, all women to be booking at first trimester using the DIPSI criteria and the IDF joint statements. All pregnant women attending health facility be tested for hyperglycemia and promote and celebrate National GDM Awareness Day, which is March 10th, which is also Rosacecia's birthday, has been now taken as GDM Awareness Day. And this is the working guidelines, which you're already aware, like how to go about. And now we come to the second half of my talk for the target glycemic levels during pregnancy. So the glycemic levels in pregnancy, what the DIPSI criteria follows, or the DIPSI follows is fasting of 90 and a 2 hour of 120 post-meal. And there are some studies which shows that, and then we'll come why this is. Again, I'm bringing back the same slide which I showed you earlier, the green bar NGT and the red bar GDM after intervention. And the intervention was for 90 and 120. When we intervene at this level, we are able to get the outcomes as similar to a normal glucose tolerant women with at the same level. Just thus you do the DIPSI criteria, treat for 90 and 120, you're getting a very, very desirable outcome. So prevention, what happens in the newborn babies, the total number of pregnant women followed up after a study, the National Family Health Fair, when we did the study at the ground level, a DIPAP project, you can find the SGA reduced from 17% to 10.45% at 41.2% reduction. And the LGL, large for gestational babies, that is reduction of 7.2%, that is 63.2%. And does not mean that everybody was required to give an insulin. More than 90 to 95% were be treated with diet manipulation alone. Less to 5 to 10% people required insulin. So a single initiative of achieving a birth weight of infants appropriate gestational age, significant positive effect on the overall health of the community. and also DIPSI guidelines. This is the studies that done by Professor Jitendra Singh, where he divided into 3 groups: control GDM with treatment and GDM without treatment. So you find here that GDM without treatment, you find the complications are much higher than GDM with treatment. This study proves our advantages of adhering to DIPSI guidelines in diagnosis and management of GDM as a positive effect on pregnancy outcome. And you can see here the birth weight at the time, postprandial birth weights in the 3rd trimester. If you can see here, as it goes, in relation to 3rd trimester, you can see from starting from 80, 99, and then you go to 120, and then you can see the birth weight of 2.5 to 3.5, which is the Indian birth weight, is reaching the upper limit of normal. And subsequently, you can see the birth weight increasing in relation to 2-second hour plasma glucose. So the occurrence of macrosomia was continuum. This is what we have mentioned in our slide also. A 2-hour plasma glucose increased from 120 milligrams. An abnormal fasting glucose, occurrence of birth weight of newborn over the 90th percentile was continuum as the fasting increased from 80 and significant above 90. And this is the glycemic targets. You see DIPSI and other criteria. DIPSI follows 90 and 120. And the study has shown here a fasting of 5 millimoles, which about 90, prevents macrosomia as well as other adverse outcomes such as preeclampsia, neonatal hypoglycemia, and women with gestational diabetes. And the pattern of glycemia in normal pregnancy, this slide was already alluded to. If you can see here, the fasting in normal pregnancy is only about 71, 2 hours, 99, and the fetal renal threshold is 110. So here are better to keep it as close to normal. So better these values. You can see the targets, what the DIPSI follows now, fasting 80 to 90, postprandial 110 to 120, mean level of 95 to 105, and a birth weight of 2.5 to 3.5 kgs. This is what the DIPSI criteria tells you, a step to prevent offspring from developing gestational diabetes. And the prevalence of diabetes during pregnancy in women according to the birth weight, you can see here David Pettit's slide, a U-shaped curve between less than 2.5 and greater than 3.5 in Indian population. They are prone to develop gestational diabetes. The goal is to obtain newborn birth weight appropriate for gestational age. So the clinical classification, you can see here the different types of classification here is GDM, IGT. What is gestational? The GGI is gestational glucose intolerance. They have recently published a paper where the GGI, even though occurrence of macrosomia, we have already mentioned, goes after 120, but the recent study has shown that even in GGI, the complications are same as gestational diabetes. The paper is accepted for publication, to be published next week. So you can see here 120 normal, 120 to 139 is GGI, which are not mounting to GDM, but having the same complications of GDM, and 140 to 199 GDM, that is in pregnancy, and IGT outside pregnancy, 200 diabetes outside and in pregnancy. So the renal threshold, you know, as I had mentioned to you, is 110, so target 120 post-glucose will be ideal, plasma glucose. So ladies and gentlemen, let me summarize. I'm sorry being very fast because of the number of slides. Indian women are prone to develop gestational diabetes. Universal screening is necessary in Indian context. You can have the customized screening of community 75-gram glucose challenge, irrespective of the last meal timing is recommended. GDM is diagnosed with the 2-hour glucose is 140, and single test that is cost-effective and reliable. In clinic, the fasting and 2-hour plasma with 75 OGGT performed if you have all the facilities. Screening for the glucose intolerance at the earliest opportunity during pregnancy. Repeat screening when negative, and intervention to maintain target glycemic control of fasting of 90 and a 2-hour postprandial plasma glucose of 120. So thank you for patient listening.
Thank you so much, sir. I think this has made it very clear for anyone and everyone on what needs to be done, when and how. Because, there's been so much confusion on, when to screen, how to interpret. And we always keep getting confused between, what is one organization saying versus what the other organization is saying, because globally there's so much confusion. But I think when it comes to India, we are all very clear. The government of India is very clear in its vision that it is the DIPSI guideline that needs to be followed, because this is something that actually suits our population. So thank you so much, sir. I will request you to stay back for the discussion.
Yeah. Thank you.
We now move on to our next speaker, Dr. Hema Divakar, who is going to talk on GDM prevention, why and how. Dr. Hema Divakar is gynecologist, obstetrician, speaker, and activist, a very, very dynamic lady, past president DIPSI, currently vice chair pregnancy and NCD committee, chairman of PICO, welfare and healthcare committee, speaker, activist, technical advisor to the Ministry of Health and Family Welfare, and a lot of allocards to her credit. Dr. Hema Divakar, ma'am, please.
This is Dr. Hema Divakar from the city of Bengaluru in the south of India, with my warm greetings both to 1.4 billion Indians and the community from Egypt, all the way from Cairo, who has been enabled to connect with us through the technology. So today, sharing more on what and how, there have been two very, very important questions raised by our organizers, and I'm thankful to them for this great opportunity. The question is GDM prevention, why and how? The why is perhaps sometimes more important than the how, because how is still evolving, because we are all wanting that ideal situation of totally preventing the diabetes. But why should we be serious about doing this? Well, we as clinicians, obstetricians, diabetes and obesity epidemic is here. Yesterday, as OBGYNs, we were handling obstetric emergencies and saving lives, both of the mother and the fetus. Today, the same mothers are evolving into a whole population of NCDs, non-communicable diseases, and tomorrow, even we as obstetricians may be grappling with the situation of very many admissions for cardiovascular disasters, hypertensive disorders, obesity, and of course, diabetes. So moving from our journey, reflecting on what we did yesterday, what we are facing today, and what could tomorrow bring us, we say that GDM today is NCD tomorrow, and that answers the question why. Because it is not a short-term problem only with getting away with a healthy mother, healthy baby at the time of delivery, but the lifetime risk of type 2 diabetes may be 20 times higher in those who develop GDM, and half of them will definitely develop impaired glucose tolerance within 10 years of having the GDM. We don't stop here, because it translates into ill effects for the offspring as well, because childhood obesity and early adult onset diabetes is a situation that we are already facing today. So once again, I repeat, GDM or pregnancy comorbidities today translates into NCD tomorrow, and experiencing a complicated pregnancy with either placental syndrome or GDM can uniquely serve as an early indicator. It's a warning sign that future maternal NCDs are on their way, and the whole of the next generation gets impacted and affected. So pregnancies occur fairly early in lifespan. A 22-year-old has delivered today. By the time she's 32, that is the 10-year span I have spoken about, she's already into a full-blown diabetic. So it's an early indicator of maternal NCDs, which again brings home the point that the mother and infant pair right at the start. If you notice on the y-axis, the risk of NCDs, if we get our handle on this cohort of mother and infant, that is the pregnancy care to its best, then the risk of NCDs is really minimal. But as the life goes along in adulthood, and beyond, if there is no intervention, you will see a peak tsunami of the NCDs. So to track and follow up this group of women who are diagnosed to have GDM, who are at risk as a mother and child pair, if they track throughout the rest of their lives, then there is a good chance that preventing GDM will prevent the long-term impact, not only in this generation, but also in the next. There is data on a 7-fold higher increase of type 2 diabetes in the first decade. The relationship between GDM and subsequent type 2 diabetes is well established. The insulin resistance of late pregnancy can be seen as providing a stress test for the beta cells of her pancreas, thereby giving us a flash, an indication what may happen to her in the future. The higher rates of stillbirths, which are noted in these because often of the association of obesity, and of course the cardiovascular diseases, the ongoing weight gain, adding to the vicious cycle of the heightened risks both of type 2 diabetes and the cardiovascular disease. As I said, the offspring developing in a hyperglycemic environment in utero carry risks of obesity developing early in the course, progressing to impaired glucose tolerance, later into the type 2 diabetes and long-term development of overt cardiovascular disease. So it is a whole journey of the morbidities perpetuating one another forever and ever in their life course. Not only this, neuropsychiatric disorders are also linked between the development of GDM in the mother and the baby, which is growing in the hyperglycemic environment. Later on, the offspring having neuropsychiatric disorder. So it is more than what meets the eye. So the important link to NCD answers the question why we need preconceptional, conceptual and during pregnancy, postpartum and in between pregnancies, the best of the care that we can provide for a situation of hyperglycemia. Better still, if we can prevent it for a long, long time, it will be good for the generations to come. The worsening of the beta cell functions of the pancreas leading to the rise of blood sugar levels over time, resulting first in pre-diabetes before the subsequent progression to diabetes, also brings home the point that postpartum testing of glucose tolerance will be very, very important, not only at 6 weeks, but also the annual checkups forever and ever during the rest of her lifespan, which in itself prevents the long-term complications. So we say, act today for a better tomorrow, because focusing only on short-term survival of the mother and the baby around the time of delivery is a very short-sighted view. The adult health, the life expectancy, the quality of life, accumulation of human capitals, and beyond, it has very many consequences. The why has been answered. How is the next question? Is prediction of GDM really possible? Maybe, maybe not, is the answer we have today, because using clinical characteristics and the biochemical tests, we could probably substratify, identify a separate group of pregnant women whose glucose levels are in the normal range in the early gestation, but they have a very, very high chance and likelihood of getting into the standard diagnosis of GDM around the 24 or 28 weeks of pregnancy. In pragmatic terms, it appears reasonable to consider women with pre-pregnancy hyperglycemia, those with early GDM, those at risk GDM, for preventing further disastrous consequences. Early testing in itself represents an opportunity to recognize some of these women of likely to be having pre-existing abnormalities of glucose metabolism. The performance of these models has recently been evaluated by Van Hoen et al., who concluded that the models, which included both multiple clinical characteristics inclusive of obesity and early glucose measurements, this combination performed the best in prediction. Recently, the machine learning and artificial intelligence methods using demographic variables and previous laboratory tests have also been applied to improve the predictive power. Sweeting et al. Associated abnormal presentation and early markers of certain biochemical parameters like the PAPA and the free beta HCG, which are the plasma proteins which we normally test for genetic disorders. They stored the serum samples of the first trimester screening programs in Sydney and reported that the use of these multiple biochemical markers in combination of certain clinical features is able to predict the GDM with higher accuracy. However, these findings need to be validated by many more centers across the world in independent cohort. Another interesting feature is the proteomic screening in early pregnancy, which has revealed that potential protein markers, including a cluster associated with screening, binding, resistance, signaling of the insulin, is a predictor for the later development of GDM. Ravensburg et al. Have reported that vitronectin, which is also associated with metabolic syndrome outside of the pregnancy, significantly augments the predictive power of maternal risk factors and may prove to be a valuable predictor in clinical use. However, the proteomic methods are way too complex and expensive for routine use yet, and must progress to something which could be automated, low-cost laboratory tests before it becomes widely acceptable, especially in countries like India, which are called the low middle-income countries. Another interesting way of predicting and preventing GDM is the microRNA space. An exploratory case control study by Yoff et al. Suggested that microRNA 223 and microRNA 23A in the first trimester of blood samples were strongly predictive of later GDM. Another recent cohort study has also confirmed the finding for the microRNA 233 in addition to the 223. These results are promising, and overall associations between non-coding RNAs and GDM have been recently reviewed by the scientific world in the detail. But to be valued for routine clinical practices, the molecular biomarkers need both to perform better than the clinical risk factors and the simple glucose measurements that we have today in predicting and projecting the pregnancy outcomes and demonstrate a cost-effective strategy in practical terms. They should also be suited to non-fasting testing, as how we do the DIPSI test, irrespective of the status of her last meal. That is one of the easy, feasible, practical, pragmatic solutions that we have proudly showcased with the DIPSI group in India, which has now been taken by the FIGO as one of the accepted methodology of screening and diagnosing, that is testing for the gestational diabetes mellitus across the trimesters. The same time, other routine pregnancy health screening tests, we should be able to integrate it with something as simple as the routine blood tests that we do. None of these tests yet have sufficiently been developed as automated low-cost assays to allow routine clinical use. However, they offer very valuable insights into the pathophysiology of GDM, and maybe in time to come, they will be ready for the use in the clinics. The last couple of points on what can we do to prevent the long-term consequences, simple things, the low-hanging fruits as we call them, the advice about breastfeeding and lifestyle, for example. Every single mother who has a GDM should necessarily be advised to have exclusive breastfeeding for about 3, 6, or 10 months. They would decrease the chances of her getting into type 2 diabetes by a whopping 57%. Screening and comprehensive care for GDM should be cost effective with such simple methodologies which do not involve any resource at all except advocacy. The therapeutic opportunities for delaying and preventing type 2 diabetes is the most important fact that we are trying to address by not only predicting and preventing GDM on the whole, but managing the GDM when it does occur and advising the long-term care well beyond the typical 6 weeks postpartum. And a German study reported in this context, the breastfeeding was associated with greater than 40% reduction and also appeared to delay the onset of type 2 diabetes for the 10 years. What does it mean to us as OBGYNs? It's a call to action, dear friends. We have to push the caregivers and the women themselves to be made aware of the risks and the opportunities that we can modulate to decrease these risks, inclusive of the cardiovascular disease risk. Strive for all women with risk factors such as obesity and hyperglycemic disorders to be offered a post-pregnancy counseling. Ensure that annual follow-up and the general practitioner's level starting from 3 months postpartum, especially for those women with previous hypertensive or hyperglycemic disorders, and educate the women to discuss their obstetric history at all routine checkups, because if you know that she is a case of GDM, when you've tapped that history, you are more careful than ever in making sure that she is normoglycemic and normotensive. Another interesting issue raised by the father of GDM care in our country, Dr. Professor Padma Shri Sheshaya, is also about the primordial prevention. This is work in progress, so watch the space for more news around this area. In conclusion, I must say that there is a great potential for reduction in NCD burden from widespread implementation of relatively very simple strategies to stem the tide of a slow motion disaster of obesity and diabetes, as how it was identified when we met Dr. Margaret Chan, the director of the World Health Organization in 2017, and we remain inspired forever with her alerts on what we could do for a healthier generation next. Prevention and intervention, both during and following pregnancies, are urgently needed to reduce the NCD burden of GDM as manifest for affected women and for their offsprings. Despite expanding knowledge in this area, the practical implementation of proven strategies remains limited. And that's why I said it's a call to action. The thought process is on, but the ideas must translate into action by implementing it right at the grassroots level. With this wholesome, synergistic coming together of all levels of healthcare providers, we do hope that we will be able to gift a life free from non-communicable diseases for the generations to come. Thank you very much for your kind attention, and thank the organizers yet again for this wonderful opportunity at the CMRE. Namaste.
Thank you so much, ma'am. That was an excellent deliberation. Without much ado, okay, so Dr. Vijay Patni is here to co-chair the session with me. Welcome, sir.
Thank you.
So I will request you to introduce Dr. Sunil Gupta, sir, for the next session.
Sure. Thank you.
Sir, we can't hear you.
Am I not audible?
Yeah,
sir, you are not audible.
Audible.
Shalini, audible.
Yeah.
So basically, thank you, Dr. Chawla and Dr. Salini, for giving me this chance to moderate this particular session. And we have Dr. Sunil Gupta, who will be speaking on pharmacotherapy of GDM. Dr. Sunil Gupta, though, is known everywhere, practically both nationally and internationally. He's the national president of DIPSI. He's the national treasurer of RSSDI 2019 to 2022. He has been awarded 19 Oration. He has to his credit 6 consecutive Best National Research Paper Awards. His name is included in Guinness Book of World Record. And he got Outstanding Community Service Award by IDF President Dr. Andrew in 2021. And he has published about various articles as well as chapters and abstract in national and international journals, and has conducted about 2,000 plus programs in last 29 years. So, Dr. Sunil Gupta, sir, are you there? Hello?
Yes,
He'll be joining us in person in a little while. We have his recording with us, sir.
Okay. So he is going to speak on pharmacotherapy of GDM. So we can start the recording?
Yes, sir.
Okay.
RX, can we have the recording, please?
Maina, please run the recording.
Thank you, Sisaya sir. Namaskar. And thank you, Madam Bhavtarini ma'am.
Good morning, everyone. And today's talk of mine is basically focused on pharmacotherapy in hyperglycemia and pregnancy. And I should congratulate International Symposium on Diabetes, which has been started almost 10 years back by Dr. Rajiv Chawla, my elder brother, and Shalini, who's our sister. And she has, both of them are doing wonderful job. And they have assigned this job to me to talk on HIP pharmacotherapy. And I'm sure that previous speakers have already covered the basic part of gestational diabetes and pre-gestational diabetes. So I'll be focusing more on to drugs. There is no conflict of interest for this particular talk. I'll be speaking on pharmacotherapy, oral drugs, insulin therapy, and our own data. And then we will have some time for discussion. So this is the FIGO guidelines or FIGO classification, which has actually shown that it is the hyperglycemia in pregnancy or HIP being labeled as a major major terminology, which actually includes two different groups, that is gestational diabetes and DIP. And when we talk about gestational diabetes, it is classically seen in the second trimester, sometimes in the first trimester also, but it does not, the blood glucose values of GCT or OGTT, they don't match with the diagnostic criteria of diabetes, and that's what is GDM, which usually disappears after delivery, and around 70% of the GDM women might do well only on medical nutrition therapy and lifestyle modification, and may achieve their target of 90 and 120, fasting 90 and 2 hour 120 easily without any pharmacotherapy. But almost 25 to 30% of these GDM women will need either oral drugs or insulin therapy that we'll look into. While diabetes in pregnancy, DIP category includes those who are pre-existing type 1 diabetes or pre-existing type 2 diabetes. So that is one, so diagnosed before the start of the pregnancy. And another group is that they have been diagnosed to have hyperglycemia or glucose intolerance for the first time during pregnancy, but it is matching with the criteria of pre-existing diabetes. So if they're clinically, they will be behaving as either type 1 or type 2, more commonly type 2 diabetes. And these individuals, most of them will need pharmacotherapy. So your third category is also there, which is called as GGI, gestational glucose intolerance, which was proposed in 2006 by DIPSI group, though not being included in the Government of India guidelines. But many of the countries in their own specific country-specific classification, they have added this category that we give glucose and it is more than 120 but less than 140. They are IGT in pregnancies or isolated abnormality of blood glucose in pregnancy or gestational glucose intolerance. Some of them, they call it as mild GDM. So even this category, 5 to 10% of the patient may need pharmacotherapy. So I'm not going to talk on the case-based discussion, but the target, as I told you, 90 should be, fasting should be less than 90, 2 hours should be less than 120. 2 hour means post breakfast, post lunch, and post dinner, and the mean blood glucose should be less than 105. Now, how to achieve these targets is by medical nutrition therapy and exercise lifestyle modification. If they don't do well with this, then you may need to go for insulin therapy, which is a preferred drug because it does not cross the placenta, but almost all the oral drugs, they cross the placenta. Metformin, sulfonylureas, and acarbose, they are three oral drugs which have been approved. But in our country, Government of India has approved only metformin and sulfonylureas. The glibenclamide is the only drug which has been approved by other organizations. So few of our own people also using glibenclamide. Acarbose also, some school of thought, they said it's a postprandial regulator, can also control blood glucose in pregnancy, but Government of India has not given it in their recommendation. That's why it will be an off-label use of sulfonylurea and acarbose in our country. So oral glucose lowering therapy, as I told you, which are the drugs which are safe in pregnancy is the drug which does not cross the placenta. And even if they cross the placenta, it should not be teratogenic. It should not cause hyperinsulinemia in the baby, and it should not cause neonatal hypoglycemia. And if you have these three properties, they can be called as good drug. But oral drugs, all three drugs, metformin, clevenclamide, as well as acarbose, they cross the placenta, and that is why insulin remains the gold standard, because insulin does not cross the placenta. One slide on metformin. Now it has been well established fact that this drug seems to be safe. There are some few papers where they have shown that the metformin, almost more than 50% of metformin crosses the placenta, and it's almost the similar concentration there in the neonatal circulation. So they might be having some issues of in the theoretical manner. But now after I'll not confuse anyone, because the most of the guidelines have actually approved metformin for its use in pregnancy, and recently European guidelines have also approved it. So this is a trial which is a MITI trial, which was conducted in type 2 diabetes individuals, and these women were having pre-existing type 2 diabetes. One arm was given metformin from the pre-conception phase to conception until delivery. Another arm was put only on insulin and non-metformin arm, and they have found that the results are comparable. Metformin-treated women have better glycemic control, less insulin requirement, less weight gain, fewer cesarean section, except there will little higher risk of having a small for gestational age babies. But on the basis of this, the European guideline have approved it for its use in even pre-gestational diabetes. What about the Government of India guidelines? They say that after up to 20 weeks, you should be giving insulin, but after 20 weeks, metformin can be used. Recently, DIPSI guidelines of 2023, now we say after 12 weeks, we can use metformin in GDM women. So these are the European guidelines. They say that the metformin can be given even in type 2 diabetes, pre-gestational diabetes, from the day one of conception, pre-conception phase till delivery. Metformin in PCO, there's some trial that metformin reduces the incidence of type 2 diabetes by around 31% compared to placebo in 2.5 or 3 years, and by around 18% in 10 years. What about sulfonylureas? Sulfonylureas are known to cross the placenta and have been associated with increased risk of neonatal hypoglycemia. Unfortunately, the concentration of glyburide or clevenclamide in umbilical cord plasma is almost 50 to 70% of the maternal circulation or maternal level. And glyburide was also associated with higher rate of neonatal hypoglycemia and macrosomia versus those who are on insulin or metformin. And it also failed to be found to be non-inferior to insulin. That means it has not shown any superiority to insulin-based therapy when it comes to composite outcome of neonatal hypoglycemia, macrosomia, as well as hyperbilirubinemia. And unfortunately, we don't have a dedicated outcome trial or safety data available on long-term basis. Like you have MIC trial for metformin, MIC tofu trial for long-term safety data of the offspring of mother receiving metformin, and metformin has found to be promising and safe. Such trials are not existing in the clevenclamide arm, and that is why Government of India has not approved it for our recommendation. So next to metformin is insulin. Insulin might be required if the women with GDM, or pre-GDM, they fail to respond to the recommended oral drugs or recommended medical nutrition therapy for maybe 2 weeks or so. So 1 to 2 weeks of medical nutrition therapy and lifestyle modification. If you fail to achieve your target, you should be switched over to pharmacotherapy. The question will be metformin versus insulin. Insulin remains the drug of choice, but there will be some cases like where you need to have absolute indication for insulin therapy, and where oral drugs might be a second drug of choice rather than the first drug of choice. In my opinion, as per our own common sense, insulin remains the drug of choice. And apart from that, there will be few cases where you need not wait for 1 to 2 weeks of medical nutrition therapy. You may need to directly start with the insulin. And what are those conditions? If you have high HbA1c, ketonuria, associated renal or hepatic dysfunction, obstetric morbidity like macrosomia, AHUJA, hydramnias, and deterioration in the glycemic control and antenatal steroid. If you're using these drugs, if you have such a situation, don't wait even for 2 weeks and start the insulin right away. Insulin in pre-existing type 2 diabetes. This is our own data, which was published in IJDDC, and it has classically shown that the insulin requirement gradually increases from the in pre-gestational type 2 diabetes from first trimester to the third trimester. First trimester requirement is around 0.5 unit per kg body weight. Second trimester and third trimester it goes up a little bit. By the end of third trimester, it's around 0.8 unit per kg body weight. Those who are interested, you can just take this picture and go through this paper, because there's a wonderful paper which has actually even demonstrated that the pre-breakfast dose is versus pre-dinner insulin doses. The pre-dinner insulin doses in women from central India, because they are our center-specific data, they require almost double the dose of insulin versus the breakfast, contrary to our belief that the breakfast dose is highest and dinner dose is least in other population. And the reason behind it, that the calorie content of population in central part of India have a high quantity of dinner portion size versus the breakfast portion size. And we have come out with different data, which is again published in different journals. In gestational glucose tolerance, GGI intolerance, the borderline case of 120 to 140, around 7 to 10% of the patient may require insulin therapy, especially those who have bad obstetric history, and they require around 0.1 unit per kg body weight of their pre-pregnancy weight. In the first trimester, GDM around 0.25, and pre-gestational diabetes type 2 is around 0.5. which went up from 0.1 to 0.15, 0.25 to 0.4, and 0.5 to 0.8, that again clinically signify that almost 1.5 times increase in the insulin doses as the pregnancy advances till delivery. Which regimen is better? Basal bolus therapy is best for insulin initiation, up titration, and dose adjustment. Your self-monitoring of blood glucose, maybe fasting, post-breakfast, post-lunch, post-dinner, as well as sometimes pre-lunch and pre-dinner as 3 a.m. blood glucose. So 7-point monitoring has been recommended, but again, it has to be individualized. Those who are on multiple doses of insulin, they should be monitoring their blood glucose on a daily basis throughout the delivery, the pregnancy till delivery. Now, people do argue that can we have pre-mixed insulin twice a day instead of giving 4 times a day, basal bolus therapy. We always say basal bolus therapy is easy because it is easy to titrate, up titrate, down titrate, and adjust the doses according to the meal pattern of a person. Like what the South India says that the pre-breakfast is high, the Central India says it is a pre-dinner dose is high. So this all can be manipulated by using basal bolus therapy versus pre-mixed insulin, and this control of blood glucose is usually much better and more easy to achieve, and that's why the data says basal bolus therapy is better rather than pre-mixed therapy. Which insulin is safe? So we have insulin, human insulin, Aspart and Lispro and Detamir. They were earlier classified as category B drugs, but this category has been removed. This label of A, B, C of the use of drug in pregnancy has been now removed, and now in November 2015, and now the classification does not say that you should be having B or B category or C or A category drugs. Now they say here you have even faster Aspart, which is again approved. And when it comes to other insulin, NPH is also approved. Premixed Aspart, premixed Lispro is also approved, and premixed regular and human is also approved. Now, few drugs which are not approved is insulin glulysin, but the glargine has also been approved for its use in pregnancy. But what they say is that the glargine can be used if clinician feels that by withdrawing glargine, someone already taking glargine, by withdrawing glargine, there can be effect on the glycemic control of a woman. In such situation, clinicians on their own decision can continue glargine. Recently, like glargine, you also have a approval for insulin degludec, and that are also shown to be shown to be okay for in type 1 diabetes in a real world setting, and they found it to be safe. So that has been approved like Glargine. Emphasis on the daily frequent monitoring is must. Insulin in twin pregnancy. There's a paper which actually opened our eyes that twin pregnancy in type 1 diabetes requiring almost double the dose of insulin versus the singleton pregnancy. We did not find that, so we did our own data collection around 40 pregnancies, Nagpur and Pune centers, and we found that GDM women with twin or singleton gestation differed insignificantly in their treatment strategies and the insulin doses. Insulin requirement need not be proportional to the number of fetuses. So if you're triplet, that does not mean they will require 3 times the insulin dose versus the singleton pregnancy. Treatment should be planned to achieve the glycemic control even in twin pregnancy like in singleton pregnancy. Insulin doses have to be individualized on the basis of self-monitoring of blood glucose. Intrapartum, try to achieve your blood glucose between 70 to 120. Insulin infusion can be used in those who are on very high dose of insulin. Most of the GDM women may not require insulin in the intrapartum phase, but pre-gestational type 1 and type 2 women may require insulin infusion. Rate can be adjusted as per this chart, but during the intrapartum phase, if your blood glucose is between 70 to 120, the chances of having neonatal hypoglycemia is less. Postpartum phase, almost 15% of the GDM may remain glucose intolerant, and these women may require diet therapy and may subsequently insulin therapy till the breastfeeding is on. During breastfeeding, insulin becomes a drug of choice, but few of the data says metformin and glipizide is also safe in breastfeeding. Insulin remains the first drug of choice. 30 to 70% of the women likely to develop GDM in the subsequent pregnancy also, and 10 to 50% of the women develop type 2 diabetes within 5 years after delivery. Breastfeeding should be encouraged. There exists an inverse association between the duration of breastfeeding versus the type 2 diabetes risk in the parent's mother. So it is also protective to mother. The longer is the breastfeeding, higher is the safety of developing type 2 diabetes in the women, in the mother of a GDM. So glycemic control should be achieved by medical nutrition therapy, lifestyle modification, pharmacotherapy, monitored properly, and so as to achieve your HbA1c very much, try to keep it less than 6, and fasting and postprandial I told you. Because if the glycemic control can be maximized to the extent that fetus no longer recognizes that its mother has diabetes, then the treatment of mother during pregnancy may become the first step in the prevention of obesity and diabetes in the offspring. And this can be a primordial preventing type 2 diabetes when the baby is in the womb, and that's what we can call as primordial prevention, on which Professor Shreya is also coming out with newer, more concepts, and all of us have to focus on fetus for the future to achieve the primordial prevention. Diabetes should not occur to anyone in future. If I imagine or dream for 3 decades from now or 2 decades from now, diabetes can be focused in pregnancy, so that after 2 to 3 decades we'll be able to eradicate diabetes. That's what is the focus of Dr. Professor Shreya, and that is why 10th of March is his birthday, which has been recognized by Government of India as a National GDM Day, and we should all have awareness program not only on the day but throughout the year. But there is certainly a specific special day where we should be doing that across the country. We have done this kind of Prega talks in around 22 languages in different part of the country. We are going to restart it very, very soon, and this is the first one which we did it. And here is your organizer, Dr. Rajiv Chawla and Dr. Shalini Jaggi. Both of them had done this program in Punjabi language during the Prega talk, not once but twice. With this, I stop here. Wishing you all a very, very happy Ganesh Utsav, Eid, and forthcoming Navratri, Dashera, Deepotsav, Deepavali, World Diabetes Day, Merry Christmas, and a Happy New Year 2024 in advance. Stay safe, stay healthy, and keep smiling. Always, 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 whenever you celebrate any occasion, instead of cutting the cake and having hydrogenated fat, better you cut the fruit to celebrate your birthday or anniversary. With this, I stop here. Thank you very much for your patience listening. I hand over this mic back to the organizer. Thank you once again for your patience listening. Namaste.
Thank you, Dr. Sunil Gupta, though he's not available here online. So we go to the next talk, and the next talk is very interesting, I would say. Do all PCOD convert to GDM? And to speak on this talk is Dr. Pikki Saxena. Welcome, ma'am. And I'll like to introduce her. She is from Department of Obs and Gynae, LHMC, New Delhi. She's a director professor of Obs and Gynae, along with a Lotson Fellowship, along with PGDR, PGDCR. She's winner of 32 gold medals, including the CS Dawn Award twice. And she also got a Book Alam Appreciation Award, outstanding contribution to the National Academy of Medical Sciences. She's the editor of 9 books and numerous citations, articles, and chapters in various national and international books. She's the expert group member of Drug Controller General of India, governing council member of DIPSI. She's executive member of Indian Fertility Society, convener of special interest group. I think she's everywhere and anywhere. So we have an Ireland speaker, Dr. Saxena. Please go ahead.
Thank you, sir, for such an elaborate introduction. And my namaskar to Dr. Sashaya, sir, Dr. Rajiv Chawla, sir, Dr. Bhavtarni, Dr. Balaji, everyone. And I thank you very much for giving me an opportunity to be a part of this prestigious conference. And sir, is my screen visible?
Yes, it's visible.
So today I will be talking on GDM. Is it inevitable? Am I audible also, sir?
Yeah, you're audible.
So PCOS, we all know, is a multi-system endocrinopathy. It is involving the hypothalamus, the brain, pancreas, liver, adrenals, skin, and also the adipose tissue. PCOS is the earliest manifestation of the vicious cycle of childhood obesity, GDM, diabetes, hypertension, dyslipidemia, coronary artery disease, endometrial hyperplasia, and malignancy in later life. We diagnose GDM, polycystic ovarian syndrome, by the Rotterdam criteria. And if any of the 2 following features are present, we say that the woman has GDM after ruling out hyperthyroidism, hyperprolactinemia, and congenital adrenal hyperplasia. The 3 features are oligomenorrhea, clinical or biochemical hyperandrogenemia, and ultrasound if you get a polycystic ovarian morphology with more than 12 follicles of 2 to 9 millimeters and a big ovary of more than 10 centimeter cube size. So as per the different features, we can categorize the phenotypes of PCOS into 4 categories. As you can see here, the first 3 are hyperandrogenic phenotypes, and the last one is having oligomenorrhea along with PCO morphology. So in Lady Harding, we conducted this study to categorize the endocrine and metabolic profile of different phenotypes of PCOS. And what we found was that all the phenotypes of PCOS had deranged endocrine and metabolic profile as compared to non-controls. And insulin resistance and metabolic syndrome were maximum in the hyperandrogenic phenotypes, and they require a strict surveillance for prospective metabolic disorders as compared to the 4th, which is comparatively less metabolically active. So many times in the clinical practice, most of the times we come across obese PCOS, but we do come across number of lean PCOS also. So again, we wanted to see what is the biochemical, reproductive, and metabolic assessment in these patients as per the BMI. And what we found out here was that among the clinical features, that is hirsutism, which we marked as alopecia, acne, and Ferriman-Galway score of 8, irregular cycles, acanthosis, and acne, all these were significantly more in both lean and overweight PCOS patients as compared to the controls. In the hormonal profile, although FSH, TSH, and prolactin were comparable in the 3 groups, LH and testosterone were significantly higher in both the PCOS lean and obese patients as compared to the control ones. In the metabolic profile, again, we found that family history of diabetes, dyslipidemia, impaired GTT, and insulin levels were significantly highest in the overweight group, followed by the lean group, and both were significantly higher as compared to the controls. So based on these findings and also corroborated by other studies, I would like to say that insulin resistance in PCOS is independent of obesity. Obese women with PCOS tend to be more insulin resistant as compared to the lean counterparts, and obesity is an independent risk factor for glucose intolerance or diabetes in PCOS. There was a threefold increased incidence of metabolic syndrome in PCOS as compared to the non-PCOS patients, and 20 to 40% of these get converted, have glucose intolerance during adolescent, and when I see them in the infertility clinic, 5 to 10% of them develop type 2 diabetes along with PCOS. So this was an interesting paper regarding the risk factors of GDM in patients with PCOS. So what they found was that nearly 24% of PCOS patients developed GDM during pregnancy. The same I'm also finding in my clinical practice. In fact, the proportion of women with PCOS who develop GDM is much higher in our study. So they found that increasing age more than 30, higher BMI, hyperandrogenism, higher insulin resistance, all these were factors which led to the development of GDM. So they all share a common pathophysiology. We all know that maternal malnutrition, which is women with GDM, hyperandrogenism, anemia, or obesity, both ends, overnutrition and malnutrition, will lead to fetal malnutrition and development of thrifty phenotype, which will lead to decreased islet cell functions and impaired beta cell growth, which leaves a permanent mark, and there is decreased adult beta cell function, and with age, as they grow up, there is catch-up growth, obesity, impaired glucose tolerance, and when they become pregnant, they develop GDM and later on diabetes. So as Dr. Balaji was showing, there is trouble at both ends. Children born less than 2.5 kg and more than 3.5 kg all have chances of developing obesity, PCOS, GDM as they grow up. These are other papers where we can see that beta cell function plays a key role in the manifestation of PCOS, and the same we have already heard from Dr. Bhavtani is the culprit in GDM. We did this study and we found these 3 gene polymorphisms which were associated with metabolic features in PCOS, and some of the novel markers which regulate the energy and glucose metabolism are implicated in the pathophysiology of all the 3. PCOS, as she grows up, GDM, and further aging, she develops diabetes mellitus. So in this study, we found the correlation of serum nisfatin 1, which was 10 times higher in PCOS women as compared to the age and BMI matched controls, and this correlated positively with postprandial glucose. 3 other markers, fetuin A, kispeptin, and copeptin, we found that they were significantly raised in PCOS subjects as compared to the BMI matched controls, and they correlated positively. These are young girls, the adolescent girls and the infertile women. They correlated positively with carotid artery intima thickness, HbA1c, waist-hip ratio, LH, testosterone, and total cholesterol levels. We did these 3 adiposity index, which is the visceral adiposity index, lipid accumulation index, and the model of adiposity index in infertile women with PCOS, and they were all significantly higher in the PCOS patients as compared to the non-PCOS patients. Coming to the international guidelines, these international evidence-based guidelines for PCOS have been recently released in 2023, and these are in consensus with the Monash University, American Society of Reproductive Endocrinology, European Society of Human Reproduction and Endocrinology, Endocrine Society, European Endocrine Society, and PCOS Society. So now they all recognize the importance, and they have recommended that 75-gram OGTT is the most accurate test and should be done in all PCOS women. And they have also gone ahead to say that this is more sensitive than fasting plasma glucose and HbA1c, which Dr. Sashaya has been saying for so many decades. Another thing they have said is that whenever a woman is coming for fertility treatment, coming to the infertility clinics, we must all do OGTT to find out her glycemic status. And if not done at that time, she should be screened at the first antenatal visit. If found negative, then again at 24 to 28. It is now accepted that these PCOS girls are also having cardiovascular disease, cardiometabolic high-risk factors even at this age, and they should all be assessed for these problems. And lipid profile, blood pressure, waist-hip ratio, BMI are a must. And they go ahead to say that cardiovascular general population guidelines should consider the inclusion of PCOS as a cardiovascular risk factor, which I'm sure many of the guidelines are already having. So progression of PCOS to GDM, this is a beautiful systematic review and meta-analysis of 21 studies involving 4,800 women with PCOS and more than 11 lakh control women. What they found was that odds ratio of development of GDM in women with PCOS with respect to controls was as high as 3.58. Another paper showing the same thing. The women who develop GDM in PCOS have a relatively high risk ratio of 2.78. Now the GDM women progressing to diabetes, this study includes 1,809 publications, more than 28 lakh women, and out of these 78,893 developed type 2 diabetes at 6 weeks or later after delivery, with an unadjusted relative risk of 8.92. So how to prevent? Can we prevent, or is it inevitable? That is the question which we all face. So first of all, it has to be a multidisciplinary approach. Whenever we come across a PCOS patient, if we are getting any cardiometabolic risk factors, we must take a dietitian, a nutritionist, physical instructor, a physician, diabetologist or endocrinologist, and even a skin dermatologist on board. Sometimes we also need a psychologist on board. And first and foremost, we all know are the lifestyle modification and other problems, that is menstrual irregularity, hyperandrogenemia, infertility, can all be dealt with either OCPs, anti-androgens, and insulin sensitizers. Metformin plays a big role. If she's a morbid obesity girl, then we can give her these two GLP-1 analogs, sibutramine, orlistat, and the option of bariatric surgery are also there. Coming to the lifestyle modification, first and foremost is the behavioral strategies, setting up the goal, continuous self-monitoring, control of stimulus, problem solving, assertiveness training, slow eating, telling them to chew repeatedly, reinforcing the changes, and relapse prevention. So the key for retention, adherence, and maintenance of healthy lifestyle is support and continuous engagement. Diet, we all know, is very important. Even 2 to 5% of weight loss is going to improve her metabolic and reproductive function. Exercise is another very, very important thing, which we all know, but we don't do. And it is easy. We have to tell the patient to do it every time we meet her and involve the family in doing all these things. So minimum of 150 minutes per week moderate exercise or 75 minutes of vigorous exercise, including muscle strengthening at least 2 times a week. For an adolescent, 60 minutes of moderate or vigorous exercise, and leisure time activity we need to increase. Daily at least 10,000 steps should be done. Physical activity should have SMART goals. By SMART, I mean specific, measurable, achievable, relevant, and time limited. And fitness tracking devices should be used, and slowly we should increase. Insulin sensitizers, we have all been using metformin for a long time. I think it is a wonder drug. N-acetylcysteine, 600 milligram, 8 hourly, which is a mucolytic. and inositols, which are B-complex derivatives and are insulomimetics. D-carinosterol and myoinositols are also coming up, and they are showing promising results. So now metformin in the international guidelines for the first time has been given the appropriate place, and they say that metformin alone should be considered for adults with PCOS having a BMI more than 25 and also in BMI less than 25, and also in adolescents if they have impaired glucose fasting, impaired glucose tolerance, diabetes mellitus, or if they have surrogate markers like obesity, acanthosis. In all those cases, we should see and we get very good results. So in PCOS patients, when we tried metformin therapy for 6 months, after 6 months of therapy, we found significant improvement in the clinical parameters, hormonal and metabolic parameters. This is a beautiful systematic review and meta-analysis where they have studied the effect of metformin on pregnancy outcomes in women with PCOS. And what they found was that if you give metformin throughout pregnancy, it is going to increase the possibility of term delivery, reduce early pregnancy loss, preterm delivery, pregnancy complications like GDM and PIH, and has no serious side effect. And they recommend that metformin should be used throughout pregnancy. I am using it, and many of my colleagues are using it, because as soon as we stop metformin, these women develop GDM, preeclampsia, and all those associated complications. Metformin has already been found to decrease or delay the development of diabetes. In this diabetes prevention program, research group has already shown that metformin reduced the incidence of type 2 diabetes by 31% compared to placebo at a follow-up of 2.8 years and 18% over 10 to 15 years after randomization. And this is more so for obese and insulin-resistant patients. Dr. Seshaya, I think, sir, has given a beautiful novel idea regarding the prediction and prevention of GDM and its sequelae by administering metformin in the early weeks of pregnancy. Sir is going to talk about it in length. And myself and Dr. Anjalakshi ma'am in Chennai are already doing this project. And when we are starting metformin, we are getting wonderful results. None of these women are developing diabetes. This is the other paper, Primordial Prevention, a futuristic approach to intervene in GDM and its sequelae. Sir is going to talk about it. So N-acetylcysteine, this is a amino acid L-cysteine. The good thing is that it is approved by Food Safety and Standard Authority of India. So in adolescents, where we are afraid to give metformin for very long years, NAC and inositol, which also is an insulin sensitizer, can be used. This one is a B-complex. It belongs to B-complex category and has all those effects as good as metformin. But I recently did a ICMR trial in which we compared metformin and N-acetylcysteine. And we found, although both improved the clinical, hormonal, and metabolic profile, but the effect was, of course, much better with metformin. And metformin is a very cheap drug. It can be easily afforded by the population. So to conclude, comprehensive management of PCOS requires a multidisciplinary approach, patient-centric lifestyle management, role of metformin in improving the clinical, endocrine, metabolic factors, and also in preventing development of GDM, diabetes, and metabolic syndrome. It is all evidence-based. Optimization of health of the woman with PCOS before conception will prevent the disease and prevent her from developing diabetes, and also prevent the disease in next generation and reduce intergenerational transmission of disease. So we need to catch them young. And I thank you all for a very patient hearing.
Thank you, ma'am. Excellent insight which you have given, I think so. And we have really able to capture probably the ways and means of at least preventing a person from going from PCOD to GDM. And we will be taking the questions further during the time of discussion. But now we have the most important talk, a keynote address by none other than Professor Seshaya. So, Dr. Chawla, would you like to
Yeah, sir, it will be my pleasure, my proud privilege to introduce our father, actually, Professor V. Shishai. He's not only father of gestational diabetes in this country, he's a Bhisham Pitama and living legend in this country, and he's like father to us. He has been a honorary distinguished professor of Tamil Nadu, Dr. MGR University for lifetime, established first department of diabetology in the country, Madras Medical College, as early as 1978, founder patron Diabetes in Pregnancy Study India Group. He is a vice chair executive board at International Association of Diabetes and Pregnancy Study Group, recipient of Dr. B.C. Rai National Award, also recipient of 2 civilian awards, of course, Dr. B.C. Rai and Padam Shri Award in Medicine in 2022, and had Lifetime Achievement Award conferred by International Diabetes Federation in 2017. I think this is very brief about him. If you keep reading about him, his contribution in the field of gestational diabetes itself will take 20 to 30 minutes. So I'll not stand between his keynote address, which is an oration for us, and the audience delegate, those who are very keen to hear. Professor Visheshai, dais is yours. Thank you. Thanks for being part of this symposium.
Thank you. Thank you. I'm very happy to see President, the chairman of today's symposium, Rajesh Chawla, Charlene Jaggi, and other members of the International Symposium on Diabetes. I'm grateful for them to give an opportunity to talk to share with me my ideas on this topic. And I'm very happy the very good speakers, Bhavdani, Balaji, Anas, Sunil Gupta, Wiki, and myself. I thank myself for talking here.
All giants in the field of gestational diabetes.
Yeah. Now, see, I'm giving another title for my talk today. Will be like this: path-breaking concept. It's a concept for primordial prevention of diabetes. What I thought I would share with the audience here, based on epidemiology, embryology, endocrinology, and whatever I'm going to speak, as some are all based on the science. So looking at the first, let us discuss about epidemiology, estimation and projections of the number of people 20 to 79 years with diabetes in different editions will be like this. In 2019, we had 463 million. 2021, it was again 537 million. Now it's going to go out 783 million in the 2045. Now, again, period is approximately 380 million, which is likely to increase to about 480, an epidemic of unprecedented magnitude, but now it's considered as a pandemic. Andrew Bott, I met you about a few days ago in Chennai. So this is what problem which you are facing and what we should do to prevent this particular problem. Now, friends, ladies and gentlemen, please do not think detection of diabetes is over. Does not mean prevention of diabetes. So I am concentrating only on prevention of diabetes. Detection of diabetes anybody can do, but how to prevent diabetes? So what we need is primordial prevention of diabetes. That is, disease should not develop. How is it possible that we can avoid disease? I will not develop. How this God-given disease we can prevent it? Is it possible to achieve diabetes-free generation? Then whom to focus? It's interesting. Scientists in the UK had David Barker, 19 conceptualized that body's susceptibility to lifestyle disease was programmed intrauterine. He's the first man who told this all started from the mother, the intrauterine. And then he also made a beautiful statement here. This is summary of what I'm going to speak now. Gestational programming, the process whereby stimuli, that is metal fuels, at critical sensitive period of feed development, permanently change structure, physiology, metabolism, which predispose individuals to this adult life. That's a summary of what I want to speak today. These are already given here. That means what Dave said was fetal origin of adult diseases. That shows you have to concentrate more on the fetal development because this is where it starts. Starts from the uterus. Friends, now, as I told you initially, detection, that is diagnosis, is possible. You can do anything you want. You can do IDPHG, you can do DIPSI, or any other guidance you can do for diagnosis or detection of GDM. But what I am telling is here, what we are concerned is prediction of GDM. How to predict that woman, antenatal woman going to develop GDM, prediction. That is what I am going to concentrate here so that we can prevent development of GDM and its consequences. And Ahmad Devakar told about this also, about the prediction of GDM, mentioned about that. So I'm following what she also told and other speakers also told. Now, embryo, now epidemiology is over. Now I'm going to talk about the embryology of disease. This is a very, very interesting part. I think that Balaji put this slide there. Here, islet cell functions as an endocrine organ. This is an interesting embryology. And here, the consumption, and first insulin deposit can be found, but in weeks 7 and 8, pancreatic islet differentiates the 10th to the 11th week of gestation. That's so early that beta cell starts in the pancreas or the female fetus. And then this is what happens. It recognizes that fetus recognizes and responds to maternal glycemia at 11th day of gestation. Of course, Bardhani was telling, but this is very. So now I've already given enough evidence what is going to happen now. This is now I have to epidemiology, embryology. Now you're going to endocrinology. So this is again how it's going to happen. Friends, now this is very, very important slide. You'll see in the world, all these people have used the guidelines to screen the GDM and diagnose GDM. So different countries, can imagine, different countries have different guidelines. If you go to state, there are two, ACOG is there, AD is there. Different countries have different guidelines for the diagnosis of GDM. Even the same country has two guidelines which will lead to confusion among healthcare professionals. Fortunately, our government of India, medical health department has given guidelines. Hope all of us follow the guidelines. That's a DIPSI guidelines. Anyway, here, this is what happening in the world. So I said, this my drastic step I have taken. Review all these guidelines. Nothing is possible. All guidelines are not effective for us to prevent diabetes or for primordial diabetes. Whatever guidelines you say, it is not possible. So what we should do, therefore, consciousness and early gestational glucose tolerance takes us towards the primordial prevention of diabetes. There is a pathway to go on that. What is that pathway? Now, we have done this study long time ago, 2008 itself, that blood sugar level in the pregnancy by using CGMS, that is maximum 1 hour, 130, and 2 hour, it will be 112. That is the important number, 112. We already told in 2008 and got it published. Now, what happened is after 3 years, again, pattern of glycemia normal pregnancy, which again Dr. Balaji showed this slide. Here, this very, we already told, unfortunately, we published it, but nobody recognized it. Now I have to recognize this tablet, this one, 2011. Is again, same thing, 2 hour less than, that is normal value of glucose in the human at pregnancy. This only, not 140, not 120, not 200 or 150. Now you have to please close your eyes. As far as I am concerned, I close my eyes. I only look for the 2 hour PG more than less than 10 is the ideal value. More than 10, I will be very careful because I will see is going to develop GDM. So if you are convinced about this, I will go further. This is some very nice message I want to give. Any value about normal is abnormal. I don't know whether you believe in this. It's in Hinduism, it's called Lakshman Rekha. If we cross that Rekha by Lakshmana, unfortunately, Sita didn't follow it. She was taken by Ravana. So same thing, any value above normal is abnormal. So none of us should cross abnormal value. Anything above normal is abnormal. So now that is over. Now I am going to come to a very, very important message. Blood test may identify gestational diabetes risk in first time. I am very happy that United Nations has given very good suggestion, suggests early screening could allow for lifestyle change before condition develops. So what happened? What they did in 2018 was very important message. Unfortunately, further progress was not made. So what happened here? If you look at the previous slide, NIH, he said first time National Institute of Health of United States study in 2018 suggested A1C of 5.3. That is, fewer PPPs, as I told you earlier, already proved that 110 milligrams at 10th week predict GDM. So this is a very important message. At 2 hour PPG 100 milligram at 10th week predicts GDM. So now at least we know one particular part predicts. Having known the 10th week prediction is going to be GDM, what we can do. Here is the important point again once more. But so far, no explanation has been given for prediction. Why it occurs at 10th week, no is given, as well as prevention. Both has to be answered now. I will discuss with you how to predict and how to prevent. Both will go together. So this particular message that 2018 also told, but unfortunately, see now in 2023, still USA has not come out with suggestion. They told in 2018 what further progress, nothing has happened. So they go on following IADPG, this guideline, that guidelines. So please remember, anything above normal is abnormal. So 2 over PPBG is the hallmark of diagnosis of any abnormality. So I am suggesting conceptualization, maternal 2 over PP blood sugar should not cross 110 milligrams at 10th week. This is the guidelines. As quickly but start secreting insulin around 11th week of pregnancy. The two numbers important. 10th week and 10. Because once it crosses 10th week, now next week itself, secretion of insulin starts from the fetal beta, which I told you previously about embryology. So this is the fulcrum of all our talk we're going to take up. That's why conceptualization. Now we're going to use, please, again, many people use the different type of glucometer. Do not use. You have to use only. I'm not believing this company, but I've done number of studies. I found this best thing is to use AHUJA instant or Performa glucometer. Other, if you do any of the glucometer, you are not going to have a correct value. So we've done thousands of people, and I got it published also international. Any glucometer should be used standardized for the venous blood, and we found AHUJA instant or Performa are very good. So please use only this glucometer, otherwise your study will be failure. Scope for prediction of GDM, PPBs at 10th week, more than 100 milligrams, predict GDM, which I told you earlier. Now, yes, blood glucose has to be brought to less than 100 milligrams as fetal beta cells start secreting insulin around 10 to 11. It's difficult to say. It's 1 week time, either first day or Monday or Tuesday, any day. But the most important is by first 10th week itself, when you check the blood sugar, it should be less than 10 milligrams. With fetal insulin secretion, changes in maternal metabolic starts. So unfortunately, if you go to cross 110 at 11th week, your problem started. Now this beta cells start functioning in the fetus. The fetus start changes in the maternal metabolic starts. The fetus is such a good thing. It wants to support its mother. This unfortunately, the mother supports, it gets into a problem. I'll see. I'll tell you next in my next slide. So fetal, this dossier is come to India a number of times. Fetal handling of maternal glucose. How fetal handling as previously told 10th and 11th week here. Fetal handling of maternal glucose very, very important here. Now I will give an example. It's just easy to follow. If BPBS blood sugar level. Imagine at 10th week, you got a 10th week you tested, it's going to be 126. How many people know that is abnormal? They said, okay, it's 121, nothing wrong with that. They will usually ignore them. Then what happens? 12th week, it so happens, it comes out and oh, very happy. This lady in antenatal clinic came at 126. Now, 12th week, it is done and tell why should I bother? Left it like that. This is what happening in the world. The PBS comes down without any intervention so that antenatal women are not taken care of. They are allowed to go back and come back with GDM at 24th week. Now, why this occurs is here. Why? How this has occurred? For 126, 112, this is very, very important message. Otherwise, all things will be little problematic to understand. This particular slide, very, very important. And 11th thing, as I told you, 11th thing what happened, secretion of fetal cell starts. This brings down metal glucose, which is not desirable. Finished, now over. I'll give 1 second. So 11th week is a problem, so desirable. Now what could happen because of that? Maternal blood glucose does not go up due to fetal insulin handling of maternal glucose. This is a very nice child, a baby inside. This maternal blood glucose does not go up because the fetal insulin secretion handling at 10th week, which is deceptive. Because of that, what could happen? When maternal postpartum blood glucose more than 100 gram is recorded, immediate action has to be taken to bring PPBS less than 10 milligram, lest she will develop GDM and consequences. Very simple answer, very simple message. Always remember the numbers aren't 10. If that is crossing, then going to be as a problem. So guidelines to screen glucose tolerance at appropriate research weeks. Having told previously about physiology, now imagine after 10th week, 11th, 12th weeks goes on, and 20th week onwards, as Bhavani was telling about insulin and other hormones there, insulin resistance starts due to hormonal changes. Factor alpha, immune plus lactogen, progesterone, leptin, low output, all these things will produce insulin resistance, but not awful. This is necessary so that fetal feeding can occur. So anyway, so after this it goes on. So what we should do is what we are supposed to do. The usual recommendation for screening is 24th, 25th. That is what a cutoff starts. Every textbook will say 24th week. What are already now they get started, what was gone. So this is very late. 24th is very, very late. Now what will happen here? 10th week, as I told you, PPBS more than 100 milligrams, you must take action. It is 11th milligram, 11th week, fetal beta secretion starts, and after that, nothing can be done. So 24th week, what is the use? Don't know. It's a waste of time giving insulin as what Sunil Gupta was telling me. What to do? Nothing can be done. That lady will become GDM. So what I am telling you here, the problem will be here. Presently, to test for the glucose tolerance at 10th week is not yet followed. I don't know how many people would follow unless the government of India is going to make a rule like a GDM guidelines. Presently, to test for glucose tolerance at 10th week is not yet followed. As a matter of why not be earlier also? So 10th week itself is late. I will tell you how 10th week itself is late. So it is physiological, it is still late. Now, hence, maternal hyperglycemia, again, the first pathology she is told, that's maternal hyperglycemia and fetal hyperinsulinemia promote fetal adiposity, results in the offsprings. What is going to happen? It is a male child, obesity, IGT, and diabetes. If a female child, obesity, GDM, and diabetes. That is what is going to happen. Ultimate problem. That means this lady, mother is going to have GDM, the child will become diabetes ultimately. So the unfortunate thing happened, that's because a wrong diagnosis, wrong time diagnosis, that is what's happening. So we have to very, very careful that way guidelines to be followed. So that is what I am suggesting is particular phenomenon activation. I'll give an example. Suppose my son or daughter has to go for exam in December. I should take care in the month of October itself, even September itself. Please prepare yourself for examination. You don't prepare in December, you may pass or may fail, but success won't be so good. So that is why I got anticipation. What you are supposed to do here, the ideal is to test for glucose tolerance at 8th week, that is 2 months. Why 2 months, 8th week? Because, as I told you, phenomenal anticipation, your prediction of GDM is 2 or ppbs more than 100 milligrams, I told you already. This is a known point. Then what we should will be here, hence, at 8th week itself, PP blood sugar has to be estimated. So what is, as I told you, December examination, October itself must prepare yourself. Like this, 10th week, instead of 10th week, go to 8th week itself and find what is going to happen. Anticipating 10th week, what may happen, we have to screen on 8th week itself. Here, because this is very important message. In case a ppbs is more than 110 milligrams percent at 8th week, a grace period of 2 weeks available to attain ppbs less than 110 milligrams at 10th week. That's what a guidelines I'm giving here. So you have given enough information. Take a precaution. And 8th week, 2 months, 2 weeks time you got, you can bring it down so that the fetus will not able to see the maternal hyperglycemia. This particular point important of the phenomenon of anticipation. Now, having done, then goes, having decided, then we have to do what treatment you should do with them will be, I call that endorsed drug. In this endorsed drug will be here, because number of times question me, why this thing, that I will give the why endorsed. At PP 8th week is more than 110 milligrams, as I told you. So we will have to give intervention, MNT and metformin. So what happens as they go proceed further, at 10th week, 100 less than 110 milligrams, and then 11th week, grace period 2 weeks is over, so it continues to be less than 110. That is important message again here. 8th week, we've taken the intervention, so 10th week it maintains less than 110 milligrams. Now, as it goes up, as it further weeks will be, once it established control, even 11th week it will be less than 110, and it continues to be like that. Nothing will happen. No increase in vital beta cells, insulin secretion, because already taken care of, giving a 10th, 8th week itself, intervention with medical nutrition therapy and metformin, and following weeks it will be always less than 110. This is what happening. I'll show you what happens. Now, in case if you see only on 10th week instead of 8th week, 10th week is okay. But you go to more than 110, we won't have any time. Because within a week, what would happen? There's not enough time available to achieve less than 110 milligrams per deciliter. So your attempt is over. That means that lady is going to become GDM. That means fetal beta cells secretion starts increasing and all product will start. So you have to stop. I told you 10th week, action should be taken as the very, very important prevention. So now coming to drug, what you used to be here. If you see here, what you call 8th week is the development of the fetus, organogenesis. After that, this got germinal, it's 8 weeks, 3 to 8 weeks embryonic, then fetal development. So most important will be till 8th week. As I told you, 8th week. See the embryology. 8th week is over. Then you can give any drug you want to give to the mother, because it is not going to harm the fetus, to developing fetus, because all organ development is over 120 milligram. MNT, metformin, 200 milligram BD has to be sorted and continued. Target or glycemia to be obtained will be always. Do not get worried about value. We have seen number of pregnant women, normal women, it never crosses 99 plus or minus 10. So that is obtained, that value should be reached.
I think sir got locked out.
So something has happened. Please, the event people.
Mahima,
Metformin is safe for use throughout pregnancy because
Mahima, can you help him out?
we can use.
So the event people, please see to that.
RX people, Mahima,
So you have to unmute.
Yes, ma'am. Yes,
can
ma'am.
you help him out? There is some problem.
Sir,
Either
Chawla, sir, you have not unmuted.
Ma'am, because of connection problem, he got locked out. Just a second, I'm calling him.
Event people, please see to that.
Yes, ma'am.
I think we are unable to connect him or what?
I think there is some issue at Shashai sir's site only because his voice was also breaking in between.
Sometimes it does.
We can still hear him sometimes. Is he logged in and not able to like?
Yes, ma'am. He has logged in.
Shalini, even you are not audible for us.
He's joining. He's joining.
Yeah, he is joining.
No, sir.
He's joined now.
So unmute yourself, sir. Yeah.
Screen is not visible.
Yeah, now it is visible.
It's awesome.
It always happens to me, Shalini. Never ask me to speak on the webinar. Call me to Delhi. Send me a
No
plane.
problem, sir. We're waiting.
You must send me a plane, yeah. Rajesh.
Please continue.
I'm going to share
Continue,
now.
sir. Please continue.
Okay, well, continue. I'm not able to continue. See, it is not the first time. I had number of times this type of problem is when I go to Nagpur, I could not go, neither speak from here. And you see now, let us see.
Please share your slides again, sir.
Yes, we are trying, sir. Screen screen you just move further. Stop.
Yeah. Now,
yes,
the crucial time is going to come now. So I told you about the use of metformin, which many people fear. Now it is very, very safe drug. It can be given. And metformin is safe as embryonic stage is over by 8th week. And metformin is safe for use throughout pregnancy. So it's absolutely safe drug to be used. And sometimes they ask us, if it give metformin, the child will be microsomia. This is not thing. The PCOD, when Picky was speaking, that they all give so much of metformin, nothing happens. So please do not, we are not going to give more than 500 milligrams. So it will not do any harm to the development. So the message I want to give, this very, very important message. Administration of metformin after 12th week will not be effective in permanent GDM. So by chance, we think, oh, only 12th week I will give metformin, no use. That lady will develop GDM. So hence for prevention, now I'm coming to the final stage. Hence for prevention of GDM, PPBS less than 10 milligrams at 10th week is the crucial time during pregnancy for prediction of GDM. Hence for prevention, intervention has to be started 8th week itself. Because of fetal beta cells do not start insulin secretion at 8th week, embryonic stage, and metformin is recommended. So now finally, concept. Please, this is very final important slide. Shalini, all of you should be there. I am checking for Shalini, Rajesh Chawla, are there?
They are there.
Okay, now I've been talking, coming to final message, concept. So far, concept. This is first time I'm sharing with Rajiv Chawla what has become a reality. From concept, I have gone on to reality. So what is the reality here? The outcome of pilot study. This is which proved now that reality. What happened here? This is published already prediction and prevention of DDM and sequelae by administration of metformin in the early weeks of pregnancy. Now, this is what happened. This is what I showed you from concept to reality. Group A, 8 weeks, 2 ppg less than 10 milligram. No intervention was given, just less than 10. So everything is over. DDM negative 100% in first and second trimester. What happened is, unfortunately here, only one anti-woman developed GDM at third trimester. You don't know how. She has developed this type of third trimester. Whereas another group, this is one positive for GDM in third trimester, 4%. Whereas in group B, the 68 pregnant women, GDM negative in all trimesters, either first, second, or third, or negative. So that it seems to be very, very safe drug. Now almost 32 weeks over. A few more weeks, we will get the excellent normal children. So terminology, please. This again, final message. Terminology for glycemic status during pregnancy. Many people use wrong word. Diabetes in early pregnancy is wrong. DIEP. I have seen people talking. And then EGDM, early gestational diabetes. Where is DDM? I am not going to put to GDM at all. She will not become GDM. So EGDM also is not correct. If at all, if you want to call EGI, early gestation cause don't call GDM at all unless she crosses the criteria. At present, early gestational glucose intolerance, and then anti-woman and relatives will not be scared. We tell this word EGI. We tell the EGDM or DIPEP, there's a chance that they get scared. So finally, early gestational glucose tolerance and tons of EGI, 2 ppg more than 10 milligram postprandial blood glucose is going to be a problem of GDM, and GDM diabetes will be more than 10 milligram if female, if male, IGT diabetes mellitus. So summing up, pre-pregnancy planning is ideal for a better outcome. It is necessary to optimize metabolic control early pregnancy, and then this is
she's going to be discussing about the
prevention PPPS less than throat pregnancy, momentary throat pregnancy, do not stop metformin, continue metformin, and then aim to maintain metal 2 PG glucose 19 plus minus 10 milligram throat pregnancy from conception to confinement. We use maintain blood sugar 99 to 100, and that is target value, and weeks to screen will be 8, 9, 10, 11, 12. After that, 16, 20, that is how you must screen the parent woman. Prevents transgeneration transmission of diabetes. So, my friends, here, all of us should know the home is more important than the home.
Can you allow me to share the screen, please?
Pardon?
Please. Yes, you can share your screen. Yeah.
It all starts in utero. It all starts in utero. Hence, for diabetes-free generation, focus on the fetus for the future.
Designing insulin type 1. So let me do justice to the topic.
Oh, so somebody confusing us anyway. It's okay. GDM is the mother. I think Emma also was telling about GDM is the mother of non-communicable diseases. Okay, we accept. What will happen? Premortal prevention of diabetes is feasible provided GDM development is prevented. That's what I am telling for the past 20-30 minutes. It is possible to prevent GDM so that the GDM won't develop. There's no development of diabetes or any problem of the NCD problem. So my friends, chairperson, ladies and gentlemen, my prayer to you all, my message to you all is be Yes, carry home message will be here. Let us all pledge to save humanity from diabetes. All of you stand up and say, we will take this, save humanity from diabetes. This is my message. I don't know what's going to happen. My message for you people will be save humanity from diabetes. It is possible, provided you follow what I have discussed so far. Thank you very much, Raju, Shalini, and other people for giving me this opportunity to share with you. We're taking a few more minutes. I know that I will go no other way. It takes that amount of time. Thank you very much.
Thanks a lot, sir, for a wonderful oration. And over to Dr. Bijay Patni.
Thank you, sir. And obviously, we learned a lot from your talk, as always. So, do we have any query or question? I don't see anything in the chat box.
Dr. Picky, anything you want to? Yeah, we have got 7-8 minutes, 10 minutes before we close. Dr. Bhavtarni is there.
Would you like to add something? Dr. Saxena and Dr.
I wish
you can unmute yourself.
I am telling you now openly, I am really pained to know what these people sitting in the, what do you call them? Ministry. At least that, I don't know who was that minister when we came out with the guidelines. Minister of Health for Management of GDM, long 2014. Now, I feel so sorry to see. For the past 2 years, I've been asking the government to look at the matter and see that people take up this study. And what is the use of becoming 30% diabetes, 40% diabetes, Picky is saying 60% diabetes. What is the use? And all of them, your money goes up. By the time people grow up, 60% of the population is going to be diabetic.
Sir, have you published this pilot study yet?
Not I sent a message. It will come. It will send to you only.
Yeah, because once we have a published data, it will be easy to go back to ICMR or DGHS to have this implemented.
ICMR, see, again, I am a very crude fellow. I don't know how to. We sent about 6 months ago ICMR. What happened to them?
Yeah, twice we met. Dr. Picky knows. Twice we met and they were as ruthless as always. And they said, you come out next year, you come out with a bigger data and then we will look into that. Picky, you're muted. Picky, you're muted.
Sir, same status with ICMR, and I would like to inform you, I shared with Dr. Sashaya, sir, I was checking the health information management data from Delhi. All the different hospitals and small district hospitals and PHCs. In our institute, we are having GDM prevalence as high as 60%, varying from 30% to 60%.
Unless our endocrinology, I'm very frank with that. I find that many of the endocrinologists don't accept our DIPSI guidelines. They Yama tells, Vada says, everything they are telling. But this, everywhere I see this endo, they say IDPG. IDPG is finished. I have got another slide. I don't have time to speak that. Why Mercer himself says you have to stop using IDPG criteria. Who? Why Mercer? You want a slide? I'll send to Rajiv Chawla and Svalini. We can put it everywhere, DIPSI message. That fellow has open. Some people are very open. He said, we will not follow IDPG because countries can't allow 3 tests in a day. How many women can wait for you?
Unless otherwise they step down into the field and do things they'll not realize. We are seeing in reality.
Not just fields, Dr. Bhavtani, in our OPD, we have 400 women, who are coming for antenatal in one day. So how it is possible to do IADPSG? And they cannot be fasting. So this is the only test which is possible.
Correctly, but you go to see IMS, see the doctor names.
Sir, in names also, obstetricians are doing DIPSI only. It is the endocrinologists who are following. You are saying that we should do the IADPSD criteria.
How to ignore them? Get them married to endocrinologists. After we can. No, I'm telling you, Patni, Dr. Patni.
Vijay Patni.
This is a fact, sir. I agree with you, sir. This is a fact.
I feel so bad. How these fellows don't understand their product. You know what happened? I tell you what happened. 2012, I think one of the undergraduate, somebody in the National NCD department, daughter had a GDM. So he woke up, he got so panicky. Then he called all of us and we sat with them. Then we gave guidelines. Unless somebody in the, I don't want to say who was there, their daughter or son gets into the GDM, then only people will become woke up.
That time it was immediately accepted.
But sir, most of us do accept, most of us, even lots of endocrinologists do accept the DIPSI guidelines. Presently, presently at least.
That's because you people go on spreading these messages. Spreading messages. What else you can do? I'm telling you, the Karta of IDPG, Boyd Mercer. I have sent the slide to Rajesh Chawla. You circulate to everybody what Boyd Mercer said. Can you have no time? I give him 1 hour time, I'll speak.
I think we heard your talk being spoken by Dr. Salini Jagga in our conference, Dr. Rajesh Chawla, sir. She spoke on the same thing, primordial prevention.
I am very happy. My followers are following. I am a Guruji.
In Dr. Patni's meeting, we highlighted that primordial prevention topic in greater detail.
I am very happy to spread the news, spread the information.
And that was extremely, I mean, eye-opener for us for the first time. I mean, the way your slides were presented, I mean, your whole study was presented by Dr. Jaggi. And she covered, I think, everything what you have obviously strengthened those study today. And this was very well accepted that day also. And I think we all are following that.
We call Raghavendra.
Good thing is that now the primordial prevention editorial is already published in IJJD.
Published, I know.
So I'm sure it will be cited. It's a very creditable journal of RSSDI.
Yes, also an IJDDP.
Even the IJGDC also, and even the guidelines are already getting cited now. So
you've done a wonderful job.
So we are quoting it, sir. Before
And
that,
here in Tamil Nadu, we have extended the study to a large population.
only thing is, I think only thing BGHS people or ICI people will ask probably little bigger data. That is the only thing. And if it is multi-centric,
That's what, sir. Now we have extended the study.
Yeah.
We are going to do what I'm telling. Yes. Wait. Please allow me to speak. In the rice, when you rice is cooked, how to test is a boiled well or not? How many? Just one rice. Why you want to give so many public? I have given already indications what is happening. I see that the data I have given, entirely proved that that DDM figure that called, I can't call GDM, EGG. We give metformin, she will not become GDM. When she doesn't become GDM, we can't get any diseases. That's all. India can avoid. Now, what is the use of fighting with that stupid fellow, Canada fellow, wasting their time? And all this, what do you call this, TV, they start talking on this Canada and India. They should talk about this. I asked Rajesh Chawla, is there any channel where they talk about health issues?
Yes.
Primordial issues? What is that?
Yes, sir. There are some channels in the on TV where they are always talking about that.
I openly told when on August 15th, when Amitabh Bachchan was interviewing me, I told him this is what happened. Now, tomorrow, Monday, next week, Doordarshan is going to interview me. I'm going to give bullshit. I'm going to tell them this is bad. Luckily, Government of India, the Doordarshan, wants to give my opinion on this. I will give.
Very good.
We'll see what happens.
Dr. Picky, you're already doing at your place one thesis. We have also
doing two. We are doing.
We are also doing one already. Same on primordial.
No, please. see, more data accumulated.
Yeah, we
can even send a WHO.
Maybe in 6 months, 9 months time, we'll be able to collate the data, entire data, and then we can have a joint publication.
I'm sure about that. I can show 6,000. We'll definitely have.
Then probably we'll be on firm footing.
We have, as a 5 pairs we all bought. Rajesh, I never knew. I thought about this premodern diabetes till about 2022. Suddenly it occurred to me what I'm going to do. Teaching 40 years I'm working on that. Never thought about how to prevent diabetes. Prevent diabetes is simple, but primordial is difficult. So this having that Raji called me Guruji. Raghavendra is known as Guruji. Remember?
Your Guruji is of all Gurujis, sir. You guru of all gurus.
I'm seeing the TV.
Today, we are lucky to have Professor Dandona also logged in for his oration towards
I will keep
teaching, and
Guruji.
he's again one of our mentors. Yeah, mentors from Buffalo. The one with whom I worked almost 20 years ago. Yeah, Bhishma Pita.
And I'm very happy. Rajiv, Shalini, and other people gave me an opportunity to speak. And of course, Dipsi, Dr. Balaji, Nodharani, Kema Devakar, who was the president last time. So a number of people are working on that.
That's your modesty. It's our pleasure that you are with us on this important symposium, and this is being live streamed across Middle East and Egypt and Southeast Asia. So we are very lucky that we could have you for such a long time, sir. So thanks a lot to everyone. And with that, we can close this session. Thank you, Dr. Piki.
Thank you very much.
Dr. Patni.
Thank you, all the speakers.
Dr. Bhavtharni and Dr. Balaji. And I'll now request Dr. Alka and Dr. Alka Gandhi to please take over for the next session. Over to you, Dr. Alka.
Thank you.
So the next session is going to be chaired by Dr. Alka Gandhi. She is a founder, director, AHUJA Diabetes Clinic, consulting diabetologist at Namaha Hospital, and Dr. Mahua. She is a founder and chairman, Dr. Mahua Chennai Diabetes Clinic, West Bengal. So over to you, Dr. Alka.
Good evening, sir, and good evening, everyone. First of all, thank you, Dr. Rajiv and Dr. Shalini, for this invite. And of course, it is a wonderful session. We had very great talk by Dr. Shashaya. And now we are moving on to another wonderful session, which is going to be technology in diabetes. We have understood the importance of technology more so over the last 3 to 4 years after COVID. And this technology is helping us in conducting this Zoom meet. So of course, we have understood the importance very well. And considering the importance of implication of this technology in our practice, we have a great technology guys in diabetes with us. So to begin with, we have Dr. Amit Gupta. Dr. Amit Gupta is an MBBS, DNB, MMS, and he's a fellow Diabetes India. He's director, Center for Diabetes Care at Noida, and all of us know him very well. He has many presentations, and he's program coordinators for many of the programs. So we would like to invite Dr. Amit Gupta for his talk. The talk is going to be digitalization in diabetes.
Thank you, Dr. Thank you, Dr. Alka, for the kind introduction. And at the outset, I would like to thank Dr. Rajiv Chawla, sir, and Dr. Shalini Jaggi, ma'am. It is important to mention here that I happen to be a student of Dr. Rajiv Chawla, and it is really a proud moment for me to present at this meeting. Unfortunately, I couldn't come to Delhi because I'm in Bhubaneswar for the ACP meeting, and my really, sir, I apologize for that. And with your permission, I would like to share the screen. And just give me a minute, sir. Is my screen visible to you?
Yes.
Yes. Just give me a second. So I'm going to talk about digitalization in diabetes, and actually it is a way forward and how it is going to happen. So let me start by saying that digitalization is happening in almost each and every aspect of our life. If we go back almost 15 years and 20 years, you will find that how the banking was happening, how the admission to the school and colleges they were happening, and what was happening to the shopping when we were going to the markets, and how we were booking our tickets and all, whether it was for the railways or the buses or for the travel. But everything has changed now. We know the banking has moved on to the a lot of things now. We are doing online. Every transaction we are doing digitally, and it is now has become an accepted norm in diabetes care. Second, we know that the school admissions. Now the admissions, almost each and every portal is available online, and we need not to go to the school and colleges just to fill up the applications and all. Similarly, the shopping has also changed, and a lot of it's being done now online. And this is how the online booking of the ticket is happening. This is the state of affairs in most of our hospitals. If you look at how the busy the OPDs are, how the queues are there, and this is how the records we keep. But and we know that the problem of diabetes is ever growing now. We have more than 100 billion people living with diabetes in India. There is a lack of trained staff. There is lack of awareness, lack of resources, and most of the expenses, they are happening out of pocket. So what is the solution? So there are different digital solutions which are available, like telemedicine, online EMR, patient education portals and apps. Different apps are available for carb counting, calorie counting, even insulin dosing. Exercise activity trackers are there. The drugs like pill reminders and compliance and answer apps are also available. So just to give you a brief overview, because we are talking about digitalization as a way forward. So there are three important terms. One is digital health. Second is digital medicine. And third is the digital therapeutics. So if we go by definition, a digital health product includes any technology or platform or system that will engage consumers for any lifestyle, wellness, and health-related purposes. And they capture, store, and transmit health data, and they support life science and clinical operations. And some of the examples, like user-facing technology, like lifestyle apps, fitness trackers, nutrition apps, they are actually digital health products. Health information technology, like electronic medical record system, electronic prescribing, and order entry systems, they are also digital health products. So whenever we are using an EMR, it is actually a digital health product. Then the consumer health information sources, any online repositories, personal health records, patient portals, information databases. For example, we have now AHUJA ABHA ID. A lot of Indian patients, they have ABHA ID. So it is a digital health ID which is there. Now there are digital medicine products. So what is a digital medicine? So it includes evidence-based software or hardware products that measure and or intervene in the service of the human health. So it can be a digital diagnostic, it can be digital biomarkers, or it can be electronic clinical outcome assessment technology. For example, digital diagnostic, you talk about the software-driven connected technology that detect or confirm the presence of a disease or condition of interest, or to identify individuals with a subtype of the disease. Then we also talk about the digital biomarkers. Digital biomarkers are actually the tools which measure patients' characteristics that are objectively measured and evaluated as an indicator of normal biological process. So by evaluating certain digital markers, we are actually developing an algorithm which can talk about the different biological processes. Then electronic clinical outcome assessment technology. These are the digital measures of how patients feel, function, or survive. And the third term is the digital therapeutics, or the digital products. So they deliver evidence-based therapeutic interventions to prevent, manage, or treat a medical disorder in case diabetes. And for example, this a digital therapeutics, an application which can calculate insulin doses, is actually a digital therapeutic tool. So this is one of the paper from Dr. Jyoti Dev and Dr. V. Mohan, and this talks about digital health and diabetes experiences from in India. And recently, the use of continuous glucose monitoring system, insulin pumps, various mobile apps, various trackers which are available, various telemedicine platforms are available. So these are digital diabetes technology which are available in India, and their usage is progressing, but there are certain challenges which remain. So just to give you an overview of digital diabetes technology which is available, one is the CGM, we all know. It is a groundbreaking advancement, and it can provide real-time continuous measurement of the glucose levels, eliminating the need for frequent finger testing. And these devices consist of small sensor which is placed under the skin and which measures interstitial glucose levels and transmits data to a receiver or smartphone. We can get very good insights into the glucose trends, patterns, and alerts for high or low glucose levels, and enabling individuals to make informed decisions regarding their diabetes management. These are various devices which are available globally. Some of them are available in India, but not every device is available in India. In India, we have Libre devices which are available. We have Medtronic sensor which are available, but the Dexcom, the sensor, the Eversense sensor, they are not available in India. The GlucoRx is another sensor which is not available in India, but is available in the European market. This is a comparative chart where different types of glucose sensing devices which are available in other parts of the world, they are compared. I will not go into the detail of these devices because I will be just talking about overview of digital therapeutic tools or digital tools which are available to us for patient care. Eversense needs a mention because it is an implantable glucose sensor. It can be applied underneath the skin, and once it is applied, the sensor can record glucose levels for up to 6 months. And recently, the Eversense has come up with a sensor which will be able to record blood glucose data, interstitial glucose data for at least 1 year. Insulin pump is another major advancement, and it is an essential component of diabetes technology and digital diabetes care. And it is a small device which delivers a continuous supply of insulin to the body, mimicking the natural insulin secretion process. And it provides precise and customizable dosing options. And automated insulin delivery systems like 780G, insulin pumps, they are integrated with CGMs. So it almost a closed loop system is created. And these systems, they automatically adjust insulin delivery based on real-time CGM readings and optimizing glucose control. This was the first insulin pump, which was invented almost 50 years before. And now you can see the size of the insulin pump has become very, very small. These are different types of insulin pumps which are available globally. In India, we have Medtronic devices. The Ipsomed pump is also available in India. But the other insulin pumps, they are not available. For example, now we have a Omnipod, which is a patch pump, which is available. So there's a tubeless pump which is there. And there are other companies which are also having some insulin pumps. Teleconsultation is very, very important because during the COVID era, we have learned that the continuity of the care can still be maintained even if the patient is not able to visit the clinics or the OPDs. And we know that a large number of people with diabetes, they do not visit the clinics very often and very regularly, and it may be because of some other reasons. Even if they wish to, they may not have time to do that. But because of the availability of the teleconsultation, digitalization of the healthcare record, it is very easy to follow these patients, and online consultations is really helping the chronic care of people living with diabetes. Electronic medical records is again a very, very important tool, and now it has almost become indispensable because of the integration of a lot of things which are together. For example, it includes the pharmacy, it includes the lab services. It also makes your prescription easity readable, so anybody can read prescription and give medicine. So the chances of error, they get reduced. And also the data is there. So it is very common for the patients that they tend to lose their prescriptions which have been given to them in a physical mode, but EMR is able to store all these data, and this digitalization is actually helping in chronic care. The online labs and pharmacy, again, we know that a lot of our patients now are coming with the lab reports, and these lab reports, they don't bring the printouts because the reports are easily available on their smartphone in the form of a PDF. Drug delivery is again, a lot of it is happening now through the online services. Patients, they can order drugs or the medicines easily by uploading their prescription through various pharmaceutical service provider applications or the companies. So this is how the medicine delivery of medicine is also getting digitalized. The lab booking of the lab test, delivery of the lab results is also getting digitalized. So these are the different tech solutions which I have talked about. It is important to mention the time-tested, the glucose monitoring, and now we are talking about the connected meters. So these connected meters, now they are able to maintain a logbook. It is very common problem with the patients that whenever they check their blood sugar, they are not able to manage the logbook of that sugar charting. But with the help of these advanced tools like a glucometer which comes with a Bluetooth and an app, there are glucometers which can be directly connected to a smartphone. So they directly store the data. So the patient need not to maintain the data in any copy or in any other notebook. So it can be maintained easily, and it is available anywhere. So even if the patient forgets to bring the chart, if the data is digitalized, the glucose monitoring is digitalized, you can always have access to the record. And another important thing that it is not easy to tamper with this record because it is recorded directly from the glucometer. We are all digitalization is also changing the way the insulin is getting delivered to the patient. So this brings in the concept of the connected pens. So these are the connected pens. Now they can remember the dose which is taken by the patient, and again with the help of the app, the patient can see the entire doses they have taken over a period of time. And with the help of this digitalization of the insulin doses records, it is more easier to titrate the insulin in these patients. We know that a lot of apps are available which talk about the food tracking and the carb counting. And these are different, quick and easy therapeutic tracking can be done. And a lot of them are now approved and validated. One of the study was also done by Dr. Rajiv Chawla sir himself and Dr. Shalini Jaggi, where I was also the co-author, where we actually checked whether any intervention with the help of a digital tool can improve diabetes care in patients or not. Activity tracking, this is also something which is now becoming a fashion as well, but it is helpful for a lot of patients because it gives motivation. It is able to see what actually is happening. Is the physical activity they are doing is enough or not? Are they meeting the goals or not the target? So there are nudges, there are reminders, there are motivation kind of things which are happening in these apps. So activity tracking is again digitalization of our day-to-day activity. So this is helping in modification of the lifestyle. Glycemic profile, again, it is very, very important to, we know that now the tools are there where you can scan a continuous glucose meter sensor and you can see the glucose readings on your phone. At the same time, it is possible to share these readings with the care providers also. So the patient, once the reading is there, it automatically goes to somebody who is taking care of the patient. For example, a senior citizen may not be able to interpret the data and take adequate action, but if the data is transmitted seamlessly to some of the younger member of the family who understands the data and can guide the patient, then it is really a good tool for the patient. Insulin dose calculators, now they are apps which are FDA approved, and this comes into the category of digital therapeutics, where if the patient is able to feed the exact data of the carbohydrate intake, exact data of the glucose, then and the previous history of insulin intake and hypoglycemia, the calculator can predict and advise the patient that what kind of dosing should be adopted in these patients. And there are different digital therapeutics, and many of the pharmaceutical companies, they are also working in the segment of the digital therapeutics. Diabetes reversal is again something the people are talking about, and this is a lot of Internet of Things and AI is coming into play, and the machine learning is coming into play, where with the help of digitalization of behavior, digitalization of the lab data, digitalization of the medicine data, and digitalization of the food intake also. So an artificial you can say a twin kind of technology is created where the patient is actually assessed by different type of sensors, different types of modalities, and this is helping patients for the diabetes reversal also. We know that digitalization has helped us in using AI for the detection of the fundus, using fundus camera in detecting diabetic retinopathy. Also, there are different types of devices which are there for the sensing the pressure mechanics or sensing the pressures in the soul. So these are the devices which are helping patients in preventing the development of the foot ulcers. So these are just few examples like Siren Socks. And this is again a very interesting app where you can see AI-based multispectral imaging of the wound can actually identify and predict with a great prediction whether it is a gram-positive infection or a gram-negative infection. Two important terms before I conclude is health literacy, and equal importance should be given to digital literacy as well. So health literacy is something it is an ability to understand and act upon health-related information. But digital literacy is that it refers to the skills and knowledge required to use digital technologies effectively. So a patient may be very well health literate, but may not be knowing how to use the technology. So it is important to emphasize the use of digital literacy, and we should educate our patients regarding the adoption of these different technologies which are available. And this is just an example that how the NHS is doing this, and they are trying to create digital literacy partnership, and so that building digital health literacy into existing services as a partnership approach. Last slide, it is important to have acceptance and trust in digital technology. So acceptance and trust influence adoption and utilization. Some individuals may have reservations or skepticism about relying on technology for their diabetes management, concerns about technology malfunction, over reliance on devices, or doubts about their accuracy and effectiveness may hinder the acceptance and willingness to adopt diabetes technology. But digital literacy and health literacy can solve these problems, and we can find a possible solution for all these challenges. This is just to show that our Union Minister, Dr. Jitendra Singh, who also happens to be a diabetologist, recently in a diabetes technology meeting said that India is ready to lead technology-driven diabetes care. And just to mention that we have Diabetes Technology Conference coming up next year at Kochi. And with this, I would like to thank again Dr. Rajiv Chawla sir, CMRE, and Dr. Shalini Jaggi ma'am for giving me this opportunity.
Thank you so much, Dr. Amit, for the wonderful talk. And yes, as you rightly mentioned, the technology is changing. AI, chat GPT, everything is coming up. So along with the knowledge of technology, as you said, digital literacy is very important. And I think we have a discussion session at the end of the sessions. So I would now like to invite Dr. Manoj Chawla for his talk. Dr. Manoj Chawla is MBBS diploma in diabetology, practicing in Mumbai, a very well-known figure in diabetology. I don't think I need to introduce more Manoj. I think I'll give him more time to talk. So inviting Manoj here.
Thanks, Alka, and a big thank you to Dr. Rajiv Chawla, Shalini, and team for having me here. Pleasure seeing Dr. Dandona join in. Hope you're doing well, sir. It's great to see you after a while. So I'm going to be speaking on future technologies in diabetes, and my disclaimer is that a lot of that I'm speaking about, reasonable part of that has also been introduced by Amit to all of us. So let me find my slides here. Okay. And I'm going to quickly take through what's changing and what's coming in this field ahead. As I said, a lot of things that we talk about in technology is actually here. So the future is actually here, so to say. So let's see some of the finer aspects in terms of CGMs, pumps, what are we using, and some of the personal experiences there. I hope my slides are seen in full screen mode. Okay, right. That's seen, right? Alka, my slides are seen?
Yes, Manoj.
Yeah,
yes,
okay,
Manoj.
thanks. Okay,
Yeah.
so let me start with talking about in the CGM section, what's changing. So you have the Dexcom 1 sensor, which is what Dexcom has created for let me put it, the self-pay markets, or where this is where cost is an important aspect. So the Dexcom 1 sensor it measures sugars like any other CGM, can be used for up to 10 days, water resistant. You have the transmitter, and the glucose is being transmitted every 5 minutes. And you have the Dexcom 1 app on most compatible smartphones. We do not have Dexcom 1 sensor yet in India, but hoping that it gets launched in the next few months. Then, of course, in terms of the Abbott series, we are still stuck with the Libre 1 sensor. There was the 2 which was used worldwide and moved on to 3. And I deliberately removed the 2 because I'm hoping that we move directly to 3 and we don't get the 2 coming in, which is kind of redundant now. The difference with 3 is that it's genuinely real-time CGM. What we use in India, the Libre 1 is still an intermittently scanned CGM system. This is genuine real-time, where the data gets transferred to the app on the phone, accurate, discrete, easy to use, and as we know, the most preferred CGM in today's times with patients amongst the variable where choice is open. What's actually happening when we talk about future, and in the very near future, is the launch of the Libre View. It's kind of funny and ridiculous that we did get the Abbott Freestyle Libre launched in India, but without the software for some technical reasons. And as a result, the patients have been struggling to share their reports. They are using the real-time CGM, but it's suboptimal use. So you have the Libre View, and this is snapshots from our demo mode as one of the centers in India, which is using it for demo in the beginning. But by 15th October, this will be available for use for all centers and patients across, where the patients would be uploading their data, and you can see that in the LibreView, in the software, in your clinics, on your PCs, and so on. And this is going to give you all the aspects of the data that you want to see in terms of the daily glucose reports, the AGP, the hypo events. You're going to see the typical time in range for your patients. You will also see their sensor usage, the average glucose, the GMI for those who want to start seeing that. Also looking at specific considerations in terms of time, the statistics, and certain patterns which can be thrown up by these software reports. You will also see the daily logs, which continues to be important. As of now, let's remember, patients using the real-time CGM, the Abbott Libre Freestyle couldn't share the data officially. Very often, they would just take snapshots of their reader and share it with the clinicians. And hence, getting this software is going to kind of close the loop and make it ideal for us to view how the patients are doing and even correspond with them and do handholding on a telemedicine module. So these are all the separate aspects of the LibreView reports, which, as I said, is what our colleagues in the West have been using, and we should be getting our hands on very soon. What else in terms of the future of technology? A lot of work has been done in the non-invasive glucose monitoring and alternate physiological fluids, and that seems very exciting. So you have the ocular fluid, you have smart contact lenses, which would pick up the glucose sensor data which comes through electrical signals to an LED. Patients can transmit data in real time using the wireless antenna in these lenses. This has been an experimental model. We don't have anything out, but principally it sounds pretty good. You also had Google lenses, which they gave up, but there are other attempts looking at trying to use the ocular fluid as a means of glucose measurement. Then you have a lot of efforts in using saliva, a great deal of research there to look at intraoral dental sensors as a non-invasive CGM tool, realizing the fact that the tooth has the potential to serve as a CGM device as it's constantly in contact with the patient's saliva, and you can actually measure the glucose content in the saliva, which runs parallel to the plasma glucose. Then you move to looking at needle-free glucose monitoring. Glucomodicum is one such product. You have a reusable device which can be used up to 2 years. It's rechargeable, a consumable biosensor, which is a plug and play. The data gets again transferred to an app on the phone. And I think that's the future. Today, to have a third device to scan and to see your sugar readings is no longer acceptable. Any kind of invasive, non-invasive glucose monitoring, you should have the data transferred to your smartphone, because that's what we all live with. So the needle-free glucose monitoring is based on principles of measuring glucose through the skin using what is called as the MHD technology. Biosensors, which are used in these technologies, have become significantly more sensitive over the last few years. And then you have the integrated MHD, which is the magnetohydrodynamics technology with ultra-sensitive biosensors, which are enabling accurate needle-free glucose measurements. Then you've also had some earlobe devices, again, approved and used in some parts of the world, not FDA approved. This is intended for indoor use as the readings are affected by wind and temperature. So within certain care homes or within the housing, this can be used. You will have fluctuations when the temperature is less than 15 and more than 35 degrees. However, a simple, easy means, which is putting the sensor clip onto the earlobe, which is going to give sugar readings continuously onto the device, which is handheld. Ever since Amit spoke about the implantable sensors, which is not actually future, it's a reality in many parts of the world. The US and the EU now approved everywhere for 6 months. Again, a great device, but does require a small procedure where it implants the sensor in the forearm, and then you wear the transmitter on top of it. Accuracy has been good. There are a lot of believers in this, especially in the US. Well, not yet launched in India, and we await the same. These are the components of the Eversense system. Then you have what is called as BioLink. It is a profound new experience for glucose monitoring, again powered by micro biosensors. So something which is again non-implantable, non-invasive. It's more like a patch which is going to stay on the skin. Patients uses themselves. You have other efforts in the non-invasive CGM, something called a Sugar Beat, claims to be the world's first non-invasive real-time continuous glucose monitoring system. So a lot of different technologies being worked out, a lot of startups, a lot of tech companies doing this. But I must say they are all in the developmental phase. Some of them have a little bit of, when I say a little bit, it's actually the Eastern European CE mark, which is different from the Western European CE mark for those who know this regulatory approvals, but they are being used in some parts of the world with caution. You also have K-Watch. You had an earlier attempt, the Gluco Watch, launched from California, had its little own issues with skin burns and pricking sensation for patients who wore it. Some patients who got it to India didn't find it very useful because of our humid climate here and the sweat interfering with the glucose sensing. It wasn't too accurate. So there are attempts again to look at watches which may look like just any of your digital watch, your Apple and Samsung watches and so on. Very discreet, but the data is getting transferred again to your smartphone. Insulin pumps, well, again, Amit spoke about the journey of insulin pumps. Today, we are happy to have the automated insulin delivery systems, the MiniMed 780G, even in India, which has real-time insulin adjustments. It's a great tool, especially for people with type 1 diabetes who are on basal bolus with experiencing fluctuations, not reaching target A1Cs, or even those who are using earlier pumps are now taking the advantage of the complete automated system, because the fact remains that the basal insulin rate is not constant. The earlier pump therapies were based on the fact that you're keeping basal rates constant and asking the patients to do their carb counting and keep adjusting their boluses. But even the basal requirement changes, and hence not all patients on the pump would reach very good control. So this pump has auto corrections, no finger sticks, with smart guard technology, because this is ideally to be used with the Medtronic CGM itself, which is transmitting the data continuously to the pump, and it has self-adjusting rate technology. I'll just show one case here, which is of an individual, a young man who was on a Medtronic pump, but yet struggling. This is the data for this individual. This is as recent as last month. And we look at the real-time CGM, and you can see that in spite of using the pump and being pretty diligent, we see sugars all over the place. The estimated A1C is high. You can see that the time in target is just 17%. And this is the point we spoke to the patient that probably needs to shift to a 780G. The patient started the 780G on 7 September, which is about 2 weeks back. And this is the data that we downloaded yesterday for this individual after getting onto the 780G. And you'll be able to appreciate the flatter lines which are coming in within the first 2 weeks. Simple to see that the time in range, which was only 17% till last month, within 2 weeks of the 780G has improved to 81%, 5% still dropping below 70, and about 13% to 14% in the above range. But super results in day 2 and in 2 weeks, which can be further improved on. Well, multiple pumps which are available in the market. You have the X2 insulin pump with the T-Slim pump, which has been around in the US. It can be used as a standalone insulin pump, or it can be integrated with, again, the Dexcom G6 CGM systems. Those who've been using the T-Slim technology have been very happy. You get the data very easy. Reporting is made simple. Remote software updates, has predictive insulin dosing, and so on. So T-Slim is another great pump which gets integrated with the Dexcom system. Then you have patch pumps like the EO patch. Again, you'll see a burst of patch pumps, including many makers looking at India as probably a patch pump market because the conventional pumps, though we are using it, hasn't been a large number pick up by the physicians or the patients. You then, of course, have dual hormone pumps in the future, which is going to have essentially sensing, and then you will have delivery for both insulin and glucagon as means of keeping the balance, reducing the glycemic variability, and keeping your patients in target range. Connected pens, Amit introduced the aspect of connected pens. You have the NovoPen 6 or the Echo Plus. You have the Diacon from a company called G2E. You have the Bigfoot Unity, which actually can fit onto a lot of other pens and make it into a connected pen, which will record the data of the daily dosing. And if the patients want to enter their carbs and insulin dosages, other aspects will not only be recorded onto the smart pens, but will be then transferred to the app on the smartphone. You also have smart insulin patches in the making. These are going to be based on smart insulin technology, which is glucose responsive technology. A lot of work for smart insulins, whether it's going to be through patches, it's going to be through oral route, or even injectable, is based on glucose sensing and the release of insulin only when required, and hence called as smart insulins. But a lot of this work is still in the animal models. Sounds excellent that you will have smart insulins ahead, but some while to go before this becomes reality, but that's what the future promises. Finally, let's quickly look at the glucagon delivery devices. Again, this is not the future for the world. Again, some parts of the world already have this. The Gvoke HypoPen, which is available as means of easy injectable glucagon delivery, especially for type 1 patients who may experience hypoglycemia, or the Baqsimi nasal glucagon, again launched and available in the West by Lilly for easy treatment of hypoglycemia, as we can see in the picture, as it's a nasal spray and will raise the sugar where required. Some other use of technology, well, this is for erectile dysfunction. So you're getting shock wakes for erectile dysfunction. You're also getting platelet-derived growth factors. All of this, again, sounding promising for treatments that we've been struggling with through means of vasodilatation and improving the blood flow. The shock waves may be able to improve the penile vascular flow and reduce the problems with erectile dysfunction. We spoke about technology for foot care. Seren socks is one of those. How does it work? You wear the Seren socks daily. Nurses monitor the foot health, and these are trained nurses. And on the basis of the data that you are able to get from these socks with sensors, you're able to provide feedback and manage patient care. You also have AI-based multispectral wound images today. So it's simple. Through your smartphones, you're taking photographs and pictures of the wounds, and it's AI which is going to actually help the physicians reach a diagnosis and even offer a solution in terms of what kind of treatment should be offered. And that's, again, the future of wound care. Finally, 4D bioprinting for diabetic foot ulcers. Well, this is again based on a computer-aided motion. Extrusion-based 4D bioprinting precisely dispenses living cells and biomaterials layer by layer, generating structures that imitate human native tissue and biological systems. Essentially, it is sensing and bioprinting of dressing material, bioprinting of protective devices, which is going to be like your 4D printing of protective material and even dressing material, which is specific for that individual with a diabetic foot ulcer. So exciting technology. My job today in this time has been to give you an overview of what the future holds. And I'm happy to take questions when the time comes up. But let me also remind, while I have shown these different technologies, that only some of them are reality as of today, but the future seems extremely exciting with what the technology has to offer us. And as Amit said, we will be showcasing a lot of these new technologies at the DTech Con in May in Kochi, India next year again. Right? Thank you so much.
Thank you, Manoj, for a wonderful insight. Too many technologies, right from diagnosis to management to complication diagnosis and its management. Along with that, lot of lifestyle apps. So I'm sure the technology has a lot to do in managing diabetes, and we will discuss and take more questions later on after the talk of Dr. Mithun. So here we have with us now Dr. Mithun Bhatia. Dr. Mithun is an MRC GP as well as MRCP, and he is an founder secretary for Association of Clinical Endocrinologists. Welcome, Dr. Mithun.
Thank you.
He's going to talk about good, bad, and ugly of diabetes monitoring.
Thank you. Thank you, Alka, for introducing me. Thank you, Shalini and Rajiv Chawla, sir, for the kind invitation. It's a pleasure to have Dr. Dandona here with us. It's very difficult to give a talk after two eloquent speakers. It makes it very difficult, but it also makes it very easier for because they are my very good friends and they've completely set the stage. So I'm going to put a different tangent to my whole talk. technology has been done it. I'm going to talk about the good, bad, and evil of sugar monitoring. Let me get my slideshow up. Is my slide visible and moving, Alka?
Yes, Dr. Mithun. Yeah.
Yeah. Okay. Okay. So I'm going to start with a bit of a tangent here, and I'm going to go with a bit of a past, a bit of the struggles in my journey understanding monitoring, and hopefully echo some of the thoughts that I have gone through for somebody to take home some clear messages out of this talk. Now, I've been fortunate or unfortunate to have trained in two different parts of the world. I did my graduation in India and all my studies in UK, in West Midlands and London and Canterbury. And while I did my endocrine and diabetes training there, we used to do 4-point monitoring and 8-point monitoring and 6-point monitoring and structured SMBGs. When I came back to India, I had to retrain myself in what is popularly known as fasting and postprandial blood sugar in India. Very commonly used, very cheap to use. People get their fasting blood sugar done in the morning. Then they have their breakfast and take their medications, and ideally should have their test done between 1.5 hours to 2 hours. But what things taught me was that there's so much of a variation when it comes to fasting and postprandial sugar in India, because patients will stop their medications before they come for a fasting and PP test to see whether the medications they were actually taking is now working without, and what are their sugars are without the medications. They would have a smaller diet or a bigger diet, manipulate to get their readings better, to actually keep themselves happy or keep the doctor happy or keep their family members happy. And very often this causes discrepancy between the HbA1c and the fasting and PP sugar. And I used to have a little bit of a difficulty because trying to explain people to do HbA1c and other things were difficult, because they would do all that to please me, but they would do still this because that has been embedded in them, how to check a fasting prandial sugar right from the day of diabetes. So easy, very cheap tool, does give us an indicator of what it is, but one has to understand the flaws by which the people correct it, and the biases needs to be very, put in place before the patients are doing it. Now we are in the world of glucometers. Long ago things have changed, and when we look at the glucometer readings, we need to know whether the glucometer readings are low accuracy, high precision, high accuracy, low precision, and high accuracy, high precision. By what I mean, if you look at the darts here, if they're all together, means if I check 5 times or in 10 of my fingers, even if their ranges, the sugars are not matching with actual regions, they will all be similar. That is high precision. And high accuracy means, they're very close to what it should be. So ideally, we need a glucometer which is high accuracy and high precision. And the meaning of analytical accuracy is very important, because this is how close a blood sugar actually matches the true value. This takes into account a combination of a total analytical error of precision and bias and interferences that can be there. It's very important to understand the Parkes consensus error grid, because what we need to have the values in between A and B. That means these values that a blood sugar is more clinically accurate. So it's very important to know your glucometer. The potential interfering substances, be it environmental, be it physiological, be it operational, be it drugs, and interfering substances that may interfere with your glucometer. Very commonly made mistake is not looking at your expiry date of your glucometer. And the other common thing is how your healthcare assistant or your nurse holds the glucometer strips with their hands while they're inserting in the glucometer. Because all these can create bias for the results, and which can cause wrong treatment or wrong treatment decisions for the patients. Now, in India, we need to understand that we used to have the ISO 2003 certified glucometers, and the 2013 is the newer, which is a much stricter criteria. But even if you look at the much stricter criteria, you must understand what they're trying to say here. And very often people don't understand this. That means if, say, I'm getting a blood sugar checked, it will tell me that I'm in South Delhi, somewhere in South Delhi, where the posh offices of Dr. Shalini Jaggi and Dr. Chawla sirs are there, or in North Delhi, where their clinics are. Doesn't exactly tell me where it is. And they allow a variation of 15 milligram if the sugar is less than 100, that is, if your sugar shows 100, it may be anything between 85 to 115. And if it is higher than 100, say it is 150, then the variation is 15% plus and minus, which is acceptable. You can imagine the wide variance that comes with 15% that comes. If your blood sugar is say 200 for simplistic purpose, it's somewhere between 170 to 230 is what you might get on your blood sugar readings. So take it with a pinch of salt when it comes to it. People worry, there is a tendency in India for people to say, well, I do minus 20 to actually measure, or minus 15 to actually with my lab values. But one needs to understand, we are looking at apple and oranges. Don't try to mix them up. It causes more confusion. And I try not to encourage this minus 15 or minus 10 and minus 20 calculation, because often it has a lot of problems for the patient. Now, what is HbA1c? That is the new thing that came around, and most labs do it, and all the trials do HbA1c. Two things, I think. One, I'm very clear, when Samuel Reber made this discovery, and I think that's the biggest discovery that has been done. And it took him time to understand this, because it's an intracellular process and it's influenced by the concentration of glucose within the RBC. If I have to simplify HbA1c, I would say, if I take a hemoglobin, which is a ball, and put Fevicol in it and put in our body, how much sugar is touching or getting stick to this ball is what the HbA1c is. And D10 graph is often used, but one needs to understand the graph. You must see the total area that is there in the graph, which should be between 20 to 40. You must look at the variant window. You must note the unknown quantity. So the unknown quantity should be less than 6%. And if it's more than that, it's abnormal. So various things needs to be understood rather than just go by the report of the HbA1c that is there. We are very well aware of the factors that influence HbA1c, increase and decrease HbA1c. In a country like India, where anemia is preponderance, you have to understand that it has an effect. So if your hemoglobin is not in the normal range, HbA1c kind of becomes a little irrational. While I was in UK, a lot of things, the new biochemistry people started, and all the millimole reporting started in UK. It became very difficult for me to understand. And then I just did -2 and -2. So if it's 6% is 4, -2 is 4, and then -2 is 2. So 42. If it's 7% is -2 and -2, which is 53. The ranges are in between that are there. Now, my colleagues have talked about a lot on this. So I'm just going to briefly talk to you on this. HbA1c, the same HbA1c may have different moving up and down of the graph, and the HbA1c might look very nice, even though the patient feels crappier if he's at 300 and if he's at 100, that is there. So one needs to understand to be, as Manoj has very nicely shown, the CGMS is the mantra of the day, and that is the time in range that we are talking about. I was fortunate to be at the right place at the right time in my world, and trained with Roger Maggi while he was doing work on the CGMS pathway, and that made me understood a little bit to take things when I could come back in India. One common mistake that people made, and one common mistake that used to happen when CGMS or Libripro first came in India, was that people were a little difficult to understand how the blood sugar is not matching with the Libre that is there. Because there is a lag, this is interstitial fluid, and that is blood glucose. And there's a lag of around 17.27 minutes, which is an instrumental lag of 13.5 and a physiological lag of 5 minutes. And especially if the sugar is moving very high or very low, this lag can change. So one has to take that in concussion with other things like HbA1c for you to understand when the sugar is very high and very low. Now, most CGMS will talk about their MARD score and say lower the MARD score, it is better. It's a common metrics to use at the performance of CGM that is there. But if you look at the papers which has been there, you have to take that with a pinch of salt. The MARD values are not always a reliable indicator of CGM accuracy. And one needs to look at the MARD reliability index as well, which looks at the bias in a MARD due to error in reference instruments. Now, when we look at the AGP, when it came, we look at the diagnostic, the reference, the intervention, and the clinical outcomes. But in India, when we started doing, first we got the Libripro, and we did the Indian Jugaad system, in which we tried to take out the maximum buck for the value, because it takes 4 days to create the AGP curve. And so the first 7 days, you can, after 7 days, they would call the patients, change the settings, and after 7 days, you can get another graph. So people used to get value out of it. And a lot of people used to stick it and send the patient away, and the patient used to send it by post after 2 weeks to see what things were. That has changed significantly with the Libre that is there, which helps you understand what your sugar readings are and helps you understand to get your time in range. When we talk about time in range, which is the new, I would say, the talk of the town, but that has always been the case. We want glucose to be in a narrower therapeutic index. We don't want it to be very high. We don't want it to be very low. And that is what we were doing with SMBGs. But yes, it has made us think better when we talk about time in range and looking at, because even with the glucometers, you can do at point in range and point below range and point above range to look at glycemic variability if you do it in a structured way, which was shown by Kudrozola in his paper. Now, as Manoj has said, what has changed? See, the change has been previously, if we used to have a glucometer, or we used to have, now we have a Libre scanner that we give to our patient. This Libre scanner, patients would then scan it, what is there. Sorry, I've got one now, but I've had a lot of ice cream and my sugar is a little high. But now this is not possible. As Manoj said, patients have gone away. They can upload it on the Libre view, and we can do a true distant consultation of diabetes that is there with real data, which is not, patients cannot falsify, because if they have to come and write their glucometer readings, we often find that things do not really match. Real time, we can have a discussion, and that is the future, as is clearly shown. We are not yet there, but on coming 5th October, we are going to be there. So overall, no monitoring system, I would say, is perfect. Be it the fasting TB, be it the HbA1c, be it the CGMS, be it the real time. There's good, bad, and ugly in every monitoring system. But practicing diabetes is an art, not a science. And keeping in view, knowing your patient and finding what works for that patient will help us achieve and help the patient get the optimum care. With that, I end my slide set. I'm happy for any questions. Thank you.
Wonderful talk, Dr. Mithun. Definitely, yes, there is good, bad, and ugly in everything. And we need to make a wise choice about it. And as you rightly threw some light regarding, the glucometer, the fallacies that are there, so many times patients, when they monitor at home, and if the glucometer is not standardized or the strips are expired, they end up with false readings, and they stay in the hallucination that the reports are very good, but it does not happen. So rightly said, we need to keep a check on all these things while we are into the technology. And when we are introducing new technology, it is again very important to keep right education to the patient regarding using the technology or the fallacies with the technology which may be seen. So definitely, yes, we need to teach our patients to use the technology wisely, and only then it will be very useful. Any more questions if anybody wants to ask?
Good evening, Chawla sir, I've just seen.
Good evening, Ji. Wonderful presentation from all three. I think for we conservative people, it's a overhead transmission. Talking of technology, Manoj Chawla, Amit, and Dr. Mithun Bhartiya. And I think, but your sessions are really very, very impressive. You talk about Indian Jugaad and how to practice diabetes, which is more of an art than science. And Manoj also very in detail, great detail, alluded to current technologies which are already in practice and which can help getting diabetes a much better control and a sort of dream which could come true, especially in type 1 diabetes practice. Amit also talked about the connect through internet and how we can have telehealth helping out, especially we are fortunately now post-COVID, but COVID has been a very, very tough time and it's a huge challenge what we have all faced. I think this type of technology, telehealth and portals have really helped a lot to all the Indian patients. I think that was exemplary. Me, Dr. Amit and Dr. Shalini, we had two good data shared amongst us where we worked through a mobile app and we could get within 3 months a good glycemic control, and both those papers are already published, Amit and me, and it was a wonderful, I mean, really good to hear in such a greater detail about technology and its usage in in practice, more so in type 1, but also it is helping us out in type 2 diabetes management also. So I think it is the way forward. Recently in IJGDC, we had 4 or 5 papers getting published in the last edition. That was, I think, May, June. And there I wrote an editorial that probably telemedicine or telehealth is going to be a way forward. So I'm sure that with all those devices, gadgets, which you people have already discussed, and many of you are really using it, the practice of diabetes in India is going to surely change. Sir, Dr. Dandona, will you like to comment on that?
I think I first of all, I must congratulate all the 3 speakers, especially Manoj, for excellent presentations.
Yeah.
What I was astonished by is the level of sophistication you're talking about.
Yeah.
And the question in my mind is whether most Indians can afford this kind of technology. This is a question that goes through my mind. But again, you guys are dealing with the patients and you're doing very well. So I think it's something, that I have to praise. I only want to challenge one statement, which is made by by Mithun in the final slide. So treating diabetes is not just an art; it's science as well.
I'll take that. Definitely.
It's both art and science.
Both. I think it is very true. It's both science and art. Both. Very true.
Dr. Dandona, about your, see, we've got the Chandrayaan on the moon. I'm sure we'll find technology possible for us.
Well, that is amazing. I mean, what India has, and then of course, within 2 weeks, they launched one.
The sun
to the
mission.
sun.
Yes,
To the sun as well.
Aditya, which is very, very creditable, I think.
No, I mean, when I was a student at All India Institute of Medical Sciences in the 1960s, I could never have imagined that within 60 years, these amazing scientific achievements will be made in India. But, hats off. And clearly, people are dedicated and they work hard and they achieve the ends. And I think in diabetes, again, it's a major challenge because in the major cities of India, I understand that the incidence of diabetes in the urban areas is 1 in 4.
Yes.
So that's an enormous challenge. And of course, it's not based on obesity, it's genetics. So we have to deal with it with sort of new tactics, new strategies, and profound dedication.
Very true.
Yes,
I think you have seen an era changing over the last 50 years from your days to what is now currently being used, or it's not a standard care yet in India, but these people are already using a lot of technology from different parts. So,
and of course, I want to remind people that we are talking in the AHUJA hall.
Yeah,
absolutely.
I'm my endocrinology teacher.
Yeah.
Rajiv sir, I would like to share one incident, or maybe if you remember, it is not more than 10 years. I came to your clinic and we talked about how the technology is coming, and
agreed.
That time there was no CGM available, no mobile.
Yeah, I was very reluctant. You brought one Japanese guy who was, I think, CEO of a company, and we had some discussion. And I know I was probably I couldn't take it because I thought that this may not be the part of practice.
And in 10 years, sir, everything has changed. Probably next 10 years, I think things will change.
Things will change even faster. I remember very.
I think next 10 years we might have oral or nasal insulin, which will again be a path-breaking technology used in managing diabetes, I guess.
I think if we all read the book Who Moved My Cheese, I don't know if everybody has read, by Spencer Johnson. If you don't adapt, you will be a forgotten entity very soon. So I think technology is coming so fast.
Yeah.
But see, we've all adapted to technology.
Exactly,
I mean,
exactly.
what we are doing today, sitting in so many different places, and we're all together talking, seeing each
This
other. What
also
more do you want?
this also use of
This
technology
is
in
adaptation to
science.
technology. I mean, all of us in different cities, different places, different time zones, and we're all talking and seeing each other in real time. So I think this is the best display of technology at work.
Amit,
Yes,
Amit, you reminded me 10 years ago. I remember 2015, I switched to EMR in Toto. And I'm honestly blessed that if that was not there, it would not have been possible to practice in COVID days. So now since 7 years, 8 years, my entire data is on EMR, and I started using fundal camera. Sir, I'll share with you, Dr. Nona, sir. I started using fundal camera. This was again one of the first application in this part of the city. And last year, 2021, we published 4,000 data. I shared Dr. Shalini, and we shared our data, and we pulled data, and we got published in Primary Care Diabetes, a very prestigious journal, a data of close to 3,900 patients of fundal images. Based on that, we said, yeah, so it was a huge data, and we had a lot of citation on that paper. I'll share that paper with, and this all happened over last 6 years time, because till 2015 I was requesting one of ophthalmology colleague to come every time, twice or thrice a week, to do direct fundal examination. But then I realized that it's not going to work. I went for Forbes camera. Now I have 2 cameras at my center, and we are regularly getting it interpreted by a top retina specialist from AIMS. And touchwood, it has been a great journey. So I mean, things are evolving very fast.
AI-based retina imaging now, Amit and I, the cameras that we are using.
Yeah.
You don't even need a retina person to interpret anymore. I mean, that's the way technology has evolved. So I think we all need to adapt to technology to better the lives of not only us as healthcare practitioners, but our patients in delivering standard of care.
So can I ask you, Shalini and Rajiv,
Sir.
In this enormous database that you have on the retinal images, did you discover something new? Because you must have found something which people did not know before.
Well,
that's an enormous database.
One is that standard prevalence data, which is close to 18% in this part of the world. But much more important, we could correlate it with the modifiable risk factor. So our paper is that modifiable risk factor in practice of diabetic retinopathy, what we can do after learning that this patient has mild, moderate or severe retinopathy, we can look into microalbuminuria, we can look into EGFR, we can look into lipids and try to modify the reversible factors, modifiable risk factor in an attempt to deliver a standard care. So did
you find any new correlations there?
Yeah. It correlated typically with the duration of disease, of course, glycemic control, BMI also, and LDL levels also. So we had
LDL levels as well.
Yeah, multiple. Okay. We ran multiple regression analysis, and we could find a very good correlation between retina and poor lipids also. So we said it is a modifiable risk factor, and if you are looking into retina, it's a sort of window of opportunity to have insight into other complications.
And so it's like we picked up only those patients who were positive, who had retinopathy, and then went back and looked at all these parameters, and we found a correlation.
And we did multiple regression analysis, and it was quite impressive.
Excellent.
So at least it gave us a lot of insight that I remember when I was with you in 2000, you said that why you give so much emphasis on foot nerves and Doppler. Do you remember? You were doing that skin test. That guy, Vani's husband was doing.
Prabhakar.
Prabhakar. Prabhakar was doing that. And every time I said that we do a lot of foot examination in India, I still remember your wordings that in my clinic, no one gets amputation. But I told you that Indian patients are very, very prone to neuropathy and neuropathic ulcers. Fortunately, we don't get that much PVD. You get more PVD because a lot of Caucasians have PVD. They're smokers and they are having huge height, and many of them have long-standing diabetes. Fortunately, with standard care, they survive longer. Our patient may not survive that longer, but we have a lot of neuropathy and diabetic foot ulcer, which are neuropathic. So that time also, I remember I told you that we are doing peripheral nerves, and I should boast about that, but I devised that NSS NDS score. It's a published data, which is neuropathy symptom score and disability score, and it is a validated one. And we have a huge data of almost 7,000 patients where we've done that NSS NDS score, and we found it as a very good clinical tool for early diagnosis of peripheral neuropathy. And it is part of standard RSSDA guidelines today, that there we have a quote that we could do simply NSS NDS as per the Young et al. Criteria, and it is validated one. And as per our study, peripheral neuropathy comes out to be 15.6% just by simple bedside examination.
Okay, so Rajiv, let me extend that comment that you made about about the amputations. We've not had a single major amputation.
You scolded me that why
since 1997, 26 years.
Commendable. That's commendable.
I remember.
No center in the world can claim that. And we've not had a single end-stage renal failure or dialysis since 2001. If you come to us with a GFR of greater than 30.
Wow, that's amazing. That's amazing.
So really it tells you that good control really matters.
Really works.
It pays off.
Yeah,
absolutely.
Glycemic control goes a long way. So with that, we can end this very interesting session. And
before you end, Rajiv, I need to tell you that you need to mount my slides and move them for me.
Yeah, I've already.
We'll do that.
Yeah,
we'll do that.
Because we are going to have a very interesting oration.
Let me just thank the previous speakers. So let me.
And all the delegates to stay back, because we are going to have a very. Mithun, you have interest in hypogonadism and HH, I know, because you practice a lot of ED and sexual dysfunction. Trust me, sir's oration is going to be wonderful, awesome. And what he's going to do is he's going to talk about HH in type 2 diabetes, a subject which is very, very close to his heart. So we will do a formal, read his formal citation, and we are happy to confer upon him 10th CMRE gold medal oration to our Professor Dandona, who is a mentor to all of us. He's a teacher of teachers and guide to all of us. All of us, me, Dr. Makkar, Shalini, Dr. JK, we have been visiting his center as observers a couple of times, and he has been guiding us how to practice type 2 diabetes in India and how to have a more rationalist-based approach. I remember 2000 when I was working with him, I for the first time...
Can we have Sir's slide?
Yeah. I realized that just by simply doing clinical practice, still you can come out with a lot of data if you are little observant, if you have that clinical knack to pick up things. And I think that changed the practice, at least my practice over 20 years. Professor Dandona is a distinguished professor of medicine, Jacobs School of Medicine and Biomedical Sciences at University of Buffalo. He's founder, Diabetes and Endocrinology Center of Western New York. He's recognized as one of the world's leading experts in treatment of endocrine disorder, especially diabetes, obesity, and vascular diseases. Diabetes Endocrinology Center of New York, the largest academic endocrinology center, is in state of New York. His research on diabetes ranges from new treatment to exploring basic scientific mechanism involved in type 1 and type 2. I must tell you, he was the first one to define what is inflammation in diabetes, how insulin has an anti-inflammatory action as early as 85, probably. I think he will share. He talked about that even a venom from a scorpion could have a lot of anti-inflammatory properties, and that could also be a clue to future research. He made groundbreaking discoveries like uncovering links between obesity, diabetes, and other health conditions, identifying diabetes as a leading cause of low testosterone in men. From his center, with his team, Dr. Sandeep Dendsa and Devjit, who is going to visit us tomorrow, they have had huge data for the first time in the world, talking about low testosterone as a cardiovascular risk and how ideally it should be replaced. He actually defined the process of that definition of HH in type 2 diabetes patient, drawing new connections between inflammation, obesity, and diabetes, and identifying orange juice. This I remember 2003, he was working on that data, grape extracts and resveratrol as an anti-inflammatory agent, and he has made remarkable recoveries, almost groundbreaking discoveries and recoveries in direct vasodilatory, anti-inflammatory, and anti-atherogenic and cardioprotective effects of insulin. HH as the cause of low testosterone in 33% type 2 diabetic patient. Following his data, I replicated the same data in our city, and we found it was close to 36%. That is already published data. Testosterone is an insulin sensitizer and a metabolic hormone. Liraglutide and DAPA, for the first time, he said, could be an adjuvant therapy in type 1. Procalcitonin is a marker for endotoxemia, especially in children. Glucose cream and macronutrients are pro-inflammatory and contribute to insulin resistance. And orange juice, grape extracts, and dietary fiber are anti-inflammatory. So I think he has always been talking what is non-conventional. This is one thing I always say about him. Anything which is not conventional, he will look into that and he'll come out with something which is a groundbreaking research. So over to you, Professor Dandona. And we are again, me, my colleague and co-director, Dr. Shalini, and the entire team of CMRE ASD International Symposium, which we have been organizing for the last 10 years now. It is the 10th one. Is very happy to confer upon you this prestigious oration, CMRE oration. Thanks a lot, sir, for being and for accepting this oration for us. Over to you, sir.
Well, first of all, thank you very much for the award, and thank you very much for your friendship over more than 2 decades now that you've known each other and worked together. And of course, my wife also remember the visit of your group, you came along a few years ago to Buffalo and spent some time with us, and we had a great dinner together and so on. Now, today's topic is this amazing new concept and syndrome of hypogonadotropic hypogonadism in type 2 diabetes and obesity. But before I launch into it, I'm going to digress a little, taking the liberty, because 2 weeks ago, we published an article, letter article in New England Journal of Medicine, showing that in type 1 diabetes, at the time of diagnosis, within the first 6 months, since 50% of beta cell function is still available, the treatment with semaglutide can, over a period of 3 months, replace fast-acting insulin, and over a period of 6 months, replace basal insulin in 7 out of 10 patients. So basically, what we have shown in that, and since that was published, I've had sort of correspondence and telephone calls from all over the world about this, as to how semaglutide can replace insulin in type 1 diabetes, where we used to believe that there is no insulin reserve left. But of course, at the time of onset of type 1, 50% of insulin reserve is still there. And we utilize that to show this. And now we are planning longer and larger studies to extend the data. And maybe we can link up with you guys to look into this in India as well. So I just wanted to say that, because that really has caused a tremendous amount of excitement all around the world. And I've had telephone calls from Australia, India, Pakistan, Afghanistan, Saudi Arabia, England, and so on and so forth, and of course within the United States. So let's leave that alone now and get on to the topic that was meant to be for today, which is the syndrome of hypogonadotropic hypogonadism and the novel effects of testosterone treatment in patients who have this syndrome. Our original observation was described in 2004. I don't know why. I don't know. Can you just take that speaker off? Observation was described.
RX, I'll just arrange for this, sir. Just a moment. I'll ask them to mute the speaker.
Yeah, remove the speaker so that you can hear me rather
Nina?
than my old speech. Okay, I think it's silent now.
Yeah. Can you just share sir's slides without the audio, please?
Ma'am, just a second.
Yeah, just the slides, not the audio recording.
So anyway, while we're waiting, I can tell you that as in clinical medicine, all new discoveries are due to certain surprise elements. So in 1997, sildenafil or Viagra came. And when sildenafil came, urologists began to prescribe it as if there was no tomorrow. Because in the New England Journal of Medicine, for the first time, they had shown that 75% of patients with erectile dysfunction responded positively to sildenafil. So it was a major event. Now, they didn't realize that there was another paper in JAMA where they had looked at diabetic patients separately. And in the diabetic patients, less than 50% had responded. And these non-responsive diabetic patients were then sent to me to find out as to why there was the erectile dysfunction and impotence. And I systematically carried out testosterone measurements in all of them. And amazingly, almost all of them had low testosterone levels. Till that time, I only had a total of about 4 or 5 hypogonadal patients in my practice. And suddenly, the whole thing was sort of going through the roof, the number of these patients. And so we published a paper, preliminary paper in 2003, showing that 100% of these diabetic, non-sildenafil responsive patients had low testosterones. Since then, they had erectile dysfunction as well. And then I was joined by my fellow at that time, Dr. Sandeep Dinsa. And he's also a graduate from the All India Institute of Medical Sciences. So he joined me as a fellow. And his first task was to get all the patients who were coming to us for diabetes for the first time to have their testosterone levels measured. And it turned out that 33% of them, exactly 1/3, 34 out of 104 patients, 102 patients were hypogonadal, low testosterone, low free testosterone, and low LH and FSH. So clearly it was a syndrome of hypogonadotropic hypogonadism, because if it was a primary hypogonadal state, LH and FSH would have been high. Now, can we get to the slides now, or what's happening?
Mahima?
Mahima, aapki mahima chahiye.
Mahima, are you sharing the slides? RX?
Yes, ma'am. Just a second. We are removing voiceover.
Okay. So just remove the voiceover and then share the slides, please.
Yeah.
How much time is going to take?
Ma'am, 5 minutes.
So let me carry on in the meantime then, while we await the slides, because I've told you the first sort of few facts about the discovery of the syndrome, and that the syndrome was due to hypogonadotropic hypogonadism. And when we stimulated these patients, pituitary, tried to stimulate the pituitary with GnRH, there was normal increase in the gonadotropins. So clearly the defect was not in the pituitary, it was a hypothalamic defect. Now, the only other very interesting thing that we found in this particular publication was the fact that neither the duration of diabetes nor the severity of diabetes, A1C, determined the testosterone concentrations. It was BMI that was mostly related to it. So clearly that left an impression in our minds that obesity itself could be a cause of the hypogonadal state. Now, having...
Yes, sir.
So are we managing the slides now?
Yeah, she's
So
just...
it's going to take another 3-4 minutes because, every slide
Okay,
has
so
the audio recording.
I'll carry on in the meantime.
Yeah, I'll inform you, sir, just as we are ready, we'll inform
All right, okay, all right. Then those slides will be a revision of what I've talked about. So what I'm saying is that the state was hypogonadotropic hypogonadism. The lesion was not in the pituitary, it was in the hypothalamus, and that the correlation was with BMI. So the higher the BMI, the lower the testosterone. And that really, again, caused tremendous excitement. And then what I did was, because we ourselves were so shocked by our observations, I said, well, let's look at type 1 diabetics, children. And we published that paper showing that in children with type 1 diabetes, hypogonadal state was not there. It was only in the type 2 diabetic population that we saw this syndrome. Then we went on in 2010 to do a study, a very large study on obese and type 2 diabetic patients based in their primary care. And what we demonstrated was that 25% of the non-diabetic obese also had hypogonadism. So diabetes was not the only determinant, obesity was another determinant. So this led to the concept, and by this time, all studies globally confirmed these data. So now there is no doubt about the presence of the syndrome, and everyone accepts it. The only thing is that the knowledge is still not there, and not enough patients are being treated for the hypogonadal state. Now, next thing we did was to look into the obese population amongst the young, because all of our clinic population was in the middle age, 50s, the mean age was 54, and by that time the patients had their families and so on and so forth, so there was no problem in terms of in terms of deficiency of sexual function, except the fact that testosterone was low. So we then did the very first study in the obese children between the ages of 14 and 20. And what we found in this group, okay, now, can I change the slides? No, you change them. Okay.
Yes, sir, the slides are there.
Yeah,
so RX Mahima, you will have to change the slides for sir, as sir tells you to.
Yeah. So can you go on to the next one?
Okay, Mahima?
Mahima, you stay vigilant. Whenever he says next slide, please keep changing.
Okay. So now this, just go back. Yeah. Okay. Stay there. So basically, as I told you, low testosterone in the diabetic group, as you can see in the red, and then you can also see that LH and FSH were also lower in these patients. Prolactin concentrations were normal. Next slide. And then there is this inverse relationship with body weight, between body weight and the free testosterone concentrations. Next slide. And then the study that I mentioned, with comparing type 1s with type 2s, and you can see the type 2s have low testosterone values, whereas the type 1s have normal testosterone values. Next slide. And then we come on to the obese study. An obesity study, you can see that there is a presence of around between 25 to 30% of hypogonadism in the non-diabetic obese, and in the diabetic obese, back to about 35 to 40%. Next slide. And this is the study, the very first study in obese young pubertal and post-pubertal males between the ages of 14 and 20. And you can see that there is a lower level of total and free testosterone in the obese group. And this group is the one that is a challenge for me right now. And for you too, it would be, because these guys could remain impotent and infertile for the rest of their lives. So we need to do something about them. And I'll come back to that a little later. Next slide. And this is just to show you one of my favorite artists of all time, Michelangelo, and his amazingly beautiful sculpture of David standing in the Uffizi Gallery in Florence. So if you go to Florence, you have to go and see this. But I got introduced to David through my institute library, where when I used to get bored from classes, I would go to the library and open up art books. And Michelangelo's book was one of my favorite ones. So you can see the normal, perfect anatomy of the male on the left. No, go back. Right. And then in a cartoon in 2003, 1 year before we published our syndrome, came this thing on the internet. So this is David visiting United States and staying there for a short time. And you can see the guy has become obese like all Americans. His deltoids are gone. His pectorals are gone. His tummy is bulging out. His thighs have grown. And his genitals have shrunk. So this cartoonist, obviously had observed the state of hypogonadism in obesity. So I like to congratulate him, but I like also to show this slide because it sort of leaves an imprint on your mind. Next slide. And then the next question was, what was the etiology? So one of the issues that had been raised was that adipose tissue has a lot of aromatase, which is the enzyme that converts testosterone to estradiol, and therefore that this enzyme may be overactive, and therefore the extraestradiol may be suppressing the hypothalamus. But to go back. Don't change till I ask you, yeah. But you can see that the estradiol levels in these patients were not altered. They were not changed. So next slide. Now, around that time, in Joslin Clinic, they were conducting a study on creating insulin-resistant animals. And this was through the deletion of insulin receptor in the hypothalamus and the brain. And as a result, they did get insulin-resistant animals. But what they were also surprised to see was that these insulin-resistant animals, whether they were males or females, did not develop their testicles or ovaries properly. So you can see in the slide on the right, the section B, that the seminiferous tubules are not developed in the knockout animals, and the ovaries are not fully developed either. So clearly then, the cause is in the hypothalamus. It could be insulin resistance that is leading to this syndrome. Next slide. And then the next question we asked was, since we had shown already that insulin is an anti-inflammatory hormone, could the insulin resistant state be associated with greater level of inflammation? And this is something we published in 2006, showing that C-reactive protein levels are higher in the hypogonadal patients with obesity. Next slide. Now, we come on to some molecular biology, so please be alert because there's very interesting data at a cellular and molecular level. So, in the hypogonadal diabetic patients, we took their fat biopsies. And in the fat biopsies, we demonstrated that the hypogonadal patient had lower expression of insulin receptor substrate, GLUT4, the transporter of glucose from outside the cell into the cell, and AKT2, which is one of the mediators of the action of insulin. All of those 4 genes were expressed to a much, much lower amount. So clearly that explains the insulin resistance. And then again, you can see the difference in the eugonadal versus the hypogonadals. Those 4 elements are diminished. Next slide. And here, another element which is responsible for glucose transport, AMP kinase. In addition to the insulin insulin-dependent transport of glucose, there's also an AMP kinase-dependent glucose transport, and that too is diminished because the expression of AMP kinase is diminished in these patients. Next slide. Now, these patients who were hypogonadal and whose gene expression I've shown you already were then treated for 6 months with testosterone. And you can see the testosterone concentrations in the treated patients versus the untreated patients. In the untreated patients, there was no change. In the treated patients, testosterone levels were consistently normal. Next slide. And then, while their A1C levels did not change, weight did not change, lipids did not change significantly, and PSA, the prostatic specific antigen we look for, did not change. Next slide. But what was exciting was that while the overall weight did not change, the total lean body mass increased significantly, total fat mass diminished significantly, visceral fat diminished, but not significantly, and hepatic fat also diminished, but not significantly. But the most important part is that the total fat mass diminished and total lean mass increased. So this is very important to remember. And often patients who are given testosterone by me come back to me and say, "Doc, my weight has not changed, but my belt size has gone down." And I just tell them, yes, that's exactly what we wanted in the first place, that your tummy would shrink and that you'd feel healthier and better. Next slide. And then we looked at their insulin resistance through glucose and insulin infusion. And what we found was that the hypogonadal patients who were significantly lower in terms of insulin sensitivity at the beginning and later on after testosterone treatment, they had normalized. Next slide. And the same thing again. Next slide. Now, further analysis of all of this revealed further interesting phenomena, that plasma free fatty acid concentrations diminished remarkably with a reduction in the fat. Fatty acid concentrations also diminished. And then leptin concentrations, leptin is a product of adipose tissue, and leptin concentrations also fell. Next slide. And there was, again, do you remember the 4 elements that were abnormal at the beginning in these patients? And all of those 4 elements, insulin receptor substrate, AKT2 and GLUT4 increased following testosterone administration. So clearly, you reverse the specific metabolic defects in the adipose tissue. Yes, go on, next. And here AMP kinase also reversed. The diminution initially was reversed following treatment, both in adipose tissue and in muscle. Next slide. And then there was also overall decrease in inflammation in the circulating mononuclear cells, and three pro-inflammatory elements that interfere with insulin signaling also diminish following testosterone treatment. They are SOX3, IKKB, and P10. And then two important elements, CRP, fell, and TNF-alpha, a major pro-inflammatory cytokine, also fell. Next slide. And here, what is very interesting here is the fact that not only is the testosterone low, the androgen receptor that mediates testosterone action, is also diminished. Estrogen receptor is also diminished. And aromatase, the enzyme that converts testosterone into estradiol, is also diminished. So there is diminution of both estradiol and testosterone in these patients. And then when you treat them, all three elements normalize. Next slide. And then again, androgen receptors in the circulating mononuclear cells also reverse and normalize, both at the mRNA level and at the protein level. Next slide. And then, again, you see here this is a repeat of the last slide, so let's go ahead. And then a very specific factor which determines the muscle mass and skeletal muscle growth, called fibroblast growth factor 2. This is the very first study on fibroblast growth factor 2 in the human at any level. I mean, this is in our diabetic population here, but there was no other paper before this on FGF2 in the human. All the studies had been in rats and mice. And then you can see that FGF2, which is a major determinant of muscle mass, increases with testosterone. IGF-1 increases with testosterone. Next slide. And FGF2 receptor also increases with testosterone, and FGFR2 and at the protein level also increases following testosterone. And then two factors which suppress skeletal muscle growth are suppressed by testosterone. And they're called myostatin, which is MyoD, and myogenin, which is on the right, MRF4 on the right, and that they are also suppressed. So clearly, whether the factors are stimulating muscle, they increase, and on the other hand, the factors that diminish muscle growth are suppressed. Next slide. And then next comes the issue of hemoglobin and testosterone, because we know that testosterone increases hemoglobin, and that is partly due to erythropoietin, and you can see the erythropoietin concentrations going up at 15 weeks after testosterone, and hepcidin, which is a protein which diminishes bioavailability of iron for hemoglobin synthesis, is suppressed. So two important mechanisms underlying the effect of testosterone on hemoglobin. Next slide. And now this is a very interesting study we did with collaborators in Hamburg in Germany, where testosterone, this is the longest study on testosterone in literature. So the patients were treated up to 11 years, mean of 8 years, and you can see the changes in testosterone on testosterone therapy on the upper curve, and the lack of changes in testosterone, in fact, further decline over this period of time in the hypogonadal patients. Next slide. And you can see that weight consistently increased further in the hypogonadals due to increase in adiposity, and at the same time, it diminished in the testosterone-treated patients. Next slide. A1C fell with testosterone, and with it, what is very interesting in this group of patients, 34% of the patients had a total remission of diabetes with testosterone treatment over a period of 8 years. And in the rest, also there were improvements in HbA1c, but the important part is not only did the diabetic control improve, but in addition, some patients actually lost their diabetes altogether. Next slide. And then there was survival, overall survival. Also, you can see the red curve showing the hypogonadals dying at a much faster rate than the eugonadals who had been given testosterone. Next slide. And then within this chart, you can see that myocardial infarction and stroke were increased in the non-untreated control group, and other complications also were commoner including fractures, because as you know, testosterone determines bone strength. Next slide. And here is another study which was done in pre-diabetics going on to diabetes, and where basically this slide shows that those who got testosterone did not progress to diabetes, whereas those who did not with pre-diabetes, 40% went on to become diabetic over the next few years, and resolution of pre-diabetes occurred in 90%, whereas resolution of pre-diabetes occurred only in 1% in the control group. Next. Now, this is another very exciting study. This is Teen Lab study in children, again, the same 14 to 20 years olds who were given bariatric surgery. And we, of course, we were not on the part of that original study, the pediatricians study, but we approached these patients, these investigators, to ask whether they had blood samples available from these patients so that we could study changes in testosterone. So the mean age at the time of the study was 17 years. Average total testosterone at baseline, 194, which is low, because the low level of normal is 300. And of course, the subjects were followed for 5 years. Next slide. As you can see, weight fell, and you can see the curve and stabilized after a while. Next slide. Testosterone levels increased, and you can see the peak at 24 months, 2 years after the bariatric surgery. The levels peaked and stayed more or less stable after that. Next slide. Sex hormone binding globulin, which is a determinant of how much free testosterone you'll have. It tends to be low in the obese, and then it normalizes and stays steady after that. Next slide. Free testosterone. Next slide. No, last slide, please go back. And the free testosterone again peaking at 24 months and declining a little thereafter. And I'll come back to that. Next slide. And you can see the change in testosterone as related to change in body weight. So again, body weight, major determinant of testosterone concentrations. Next slide. And here is the dynamic of relationship between weight loss and testosterone concentrations. And you can see in the gray curve, as the time proceeded, the testosterone concentrations increased and remained high and normal, whereas in the blue line, the testosterone concentrations began to decline at 36 months and thereafter, because as you can see in the red line below, this was the group which had a weight increase after the bariatric surgery. So there is a group of patients who do regain weight, and they then lose their testosterone concentrations. So clearly, this nice curve, I call it the fish-shaped curve. You can see a fish here, and that curve shows you that body weight is a major determinant of testosterone concentrations. Next slide. Then we come to, well, this is the final sort of study I'm going to be talking about. And here, this is a study done from Australia called T4DM study. And in this study, the patient, these were either early diabetics or pre-diabetics, and they were either given testosterone or placebo. Next slide. And what is interesting is that the group that was given testosterone had only 12% having diabetes at the end, whereas in placebo, 21% continued to have diabetes. So there was a 41% difference in the two groups. Next slide. And here, the mean change in glucose, 1.7 millimoles per liter in the testosterone group, and only less than 1 millimole per liter change in the just lifestyle group. Next slide. And then here, reduction in the risk of type 2 diabetes, which in very much more dramatic fashion in the testosterone group. Next slide. And then again, lifestyle versus testosterone, far better than the placebo plus lifestyle group. Next slide. So we come to the end of this, but I want to now conclude with saying that clearly hypogonadism is an intrinsic part of having type 2 diabetes. 1 in 3 patients will have that, and they'll have it right at the outset. So it is probably more common than the microangiopathic complications of diabetes, because microangiopathic complications of diabetes develop as diabetes goes on over a period of time. So hypogonadism is intrinsic right from the beginning. And in fact, it's existent even in the pre-diabetes group and with obesity alone. So please, you need to change your practice in future by measuring testosterone in every type 2 diabetic patient, every obese patient, because you can change their lives. Now, one final little story I want to tell you, it'll take me a couple of minutes, and that is a patient that presented to me about 4 years ago with flushing. And we were investigating him for pheochromocytoma and carcinoid and so on. And then when I saw him in the clinic, I saw that he was obese. So I asked myself, could he be having flushing due to male menopause? Because males get flushing as well. So I asked him, how is your sexual function? And you know, he looked sad and didn't say anything, but his wife smiled. And because she knew that I'd hit the nail on the head. So the other thing that the patient had was that he would go off to sleep while talking to his friends and his wife. Narcolepsy. We treated him with testosterone, and within 2 months, not only did he feel a lot better, his narcolepsy vanished. So he's the only case of narcolepsy described in the world literature today. So keep in mind, sleepiness, lack of energy is a common symptom of hypogonadal state. And if patients come to you with that, think of measuring testosterone. So thank you very much for your patience and my confusion with the slides, but I hope it's been a fun journey.
I think it has been worth, and it has been wonderful hearing you year after year. And every year I really wonder that with growing age, your energy is increasing and you're getting wonderful. Awesome oration, sir. And we are extremely grateful that you accepted this oration from CMRE, and year after year, you have been part of this program and delivering your sessions from Buffalo, that too getting up very early in the morning. I'm sure this must be just now some 7 o'clock time.
No. It is very comfortable actually.
Okay.
It is around, it's about 11 o'clock now.
11 o'clock. Okay.
Yeah.
So even then, I think that effort we really appreciate. And once again, we express our gratitude to our teacher and our mentor for being part of our program and having agreed upon to deliver this oration for our 10th International Symposium. Thanks a lot.
Well, thank you. And I hope that next year I can tell you a little more about type 1 diabetes.
Surely. That is what I'm saying. Year
Sure,
after
sir,
year.
we would like to hear your experience on semaglutide. I mean, it's amazing. So we would really like to hear about that, sir, maybe.
So is semaglutide available in India now?
Yes, sir.
Oral is available.
Oral is available.
We already published.
Rybelsus is available, but injectable is yet to come.
Oh, I see. Okay. All right.
We presented almost 150 patient data in ACE last year. Already we are using for 2 years now.
Oh, okay. Great.
Rybelsus we have been using quite often now, sir, but the injectable is not yet open.
Yeah.
Okay.
So, Dr. Shalini, you may close with vote of thanks and invite people, those who want to come for a physical meeting tomorrow.
So I think it's been a great day, and we started with a bang, and we're ending this day with a bang with none other than Dr. Dandona himself blessing us by accepting this oration and delivering a wonderful oration. His experiences are always inspiring for not only Dr. Chawla and me, but I think for everybody who's logged in to listen to him. Thank you so much, sir. We're always obliged and grateful to you for all the wisdom that you share and all the motivation that you give us to do more and more and to think out of the box. The kind of scientific research that you do is groundbreaking, and this just reflects on the kind of the great mind behind it. So we're really, really thankful to you, sir, for agreeing to be with us every year, and it just motivates us to do more and more. And with that, I would like to conclude today's sessions. It has been a wonderful day. We've had a lot of logins from India, Southeast Asia, Middle East, Egypt, Cairo, and I'm sure everybody is going home wiser. For people who are based in Delhi or NCR or nearby, tomorrow is our physical conference at Hyatt Regency, New Delhi. So we welcome all of you to join us from 9:30 a.m. tomorrow morning. We have a big scientific feast to be delivered, and I'm sure you will relish it. Thank you so much, everyone. Good night. Take care and have a great day. Stay safe.
Good night, everyone. Thank you. Thank you, sir.
Thank you, sir.
Thank you.
Great, sir. Thank
And
you.
regards to man, sir.
Okay, thank you. I'll let her know.
Thank you.
Thank you so much, sir.
Good night, sir.
Thank
Take
you.
care, sir. Have a great day, sir.
Thank you.
You too.
Recording stopped.
Chalo ji.